So a quick welcome again, now with the recording on. And me, Stina Klemming, a NEDCAP-trained neonatologist. I'm your host for the day, and the meeting will be moderated by me and Björn Westrup. And Björn is also a NEDCAP-trained neonatologist here in Sweden, Karolinska. Many of you know Björn very well, but for those who don't, I would like to introduce you to Björn. He is one of the world's leading experts in infant and family-centered developmental care, both in implementing clinically and scientifically. Björn brought NEDCAP to Europe, and in 1999 he founded the Scandinavian NEDCAP Center together with Hugo Lagercrantz, Lena Hellström-Vestas, Karin Stjernquist, and Agneta Kleberg. And Björn was the director for the center for 20 years. The Stockholm Conference on Ultra-Early Intervention is a scientific meeting on infant and family-centered developmental care, what we know as the acronym IFCDC, and NEDCAP, Newborn Individualized Developmental Care and Assessment Program. It's organized by the Karolinska NEDCAP Training and Research Center, and this year is the 11th annual conference. We thank Karolinska and the neonatal department for the support of the meeting and for the trust and opportunities that we have been given through the years. We also would like to thank our corporate sponsors for their support and their flexibility for this year. And I would like also to take the moment to thank Stefan Wengelin at Come AB for his help in arranging and cancelling our physical meeting and helping out with many other things for the virtual meeting. This year has been, to say the least, a challenge for all of us. We are happy that we early on in this global crisis of pandemic took the decision to convert the meeting to a webinar instead, and we hope that this will work smoothly during the day. For so many reasons, we all now hope that the situation worldwide will subside and that we can all meet again physically for next year's meeting. Today's virtual meeting is being recorded, and if that works fine, the recording will later be linked from our webpage, karolinska.se, for everyone to view, free of charge for you to share with others who could not join us today. This year, we will focus on the standards of care for infant and family-centered developmental care that was launched in November 2018 by the European Foundation for the Care of Newborn Infants, EFCNI, as one of the 11 European standards of care for newborn health. Silke Mather, chairwoman of EFCNI, will give us an overview of the greater project. After that, we will focus on the standards for IFCDC and look at different parts of the standard. What are the statements? How can they be put into practice? How can we use the standards to highlight inequality in a European and global perspective? How can we use the standards in the local implementation of IFCDC? Or in lobbying for specific changes to get leadership in political structures, hospitals, and neonatal units to grasp the needs for many evidence-based changes in the care for newborn infants and their families. We would also like to acknowledge World NEDCAP Day tomorrow, March 20th, as we highlight the importance of respectful, sensitive, and individualized care for all hospitalized infants and their families. Welcome to the 11th Stockholm Conference on Ultra-Early Intervention. Now, the plan was to make a little exercise to say hello to everybody. So if everybody, for now, turn their video on and unmute yourself. And then you write a little chat message to everyone with your country, the city, and your occupation. So for me, that would be Sweden, Stockholm, neonatologist. Write that only. And then you can switch to gallery view. It's in the upper right corner when you move your mouse, it comes up and you will see everybody. And I will just stop sharing and we can see each other. Ta-da! Hello, everybody.
Hello.
So we can see that.
Hello, everyone. Hello.
And remember that.
So now everybody is muted again. The audio couldn't take it. But here we are. So we are 93 at the moment. 330 people have registered for this meeting. Because of the situation in the world, I don't think that we will be 330 people today. I actually almost hope that we want to get this all running smoothly. But a lot of people anyway, and I think that some will wake up in the other end of the world and join in the afternoon, and some might go to bed in a while. And we have people from all over the world registered. We'll see which part of the world that we have represented now in the morning. And you have the program, and I will also put the program as a PDF in the chat room if you want to download it.
Good morning, everyone. Is it functioning? Stina, give me a thumbs up if it's functioning. And Silke, you can of course put your video on, because I'm now going to present you. Actually, you are the reason why we have this conference today. As a chairwoman and founder of the EFCNI, we wouldn't have done this conference without your initiative. Of course, you can all read the bios in your handouts, but just like to mention a few things about you, Silke. It's a fantastic woman and a very nice and dear friend. The reason is, of course, that you have experienced extreme prematurity yourself with some severe complications, and one of your twins actually didn't make it. But you have taken this experience so much way further. First on the European level, now you're taking it further on to the the global level. Not only founding the EFCNI, but also taking the GLANCE initiative, the Global Alliance for Newborn Care, which is a collaborative project with the parents as initiators, which is a very big strength of your movement. And so I'm extremely proud to be a member of your activities as a scientific expert. And you have been appointed lots of lectures and so forth, but I don't want to take time from your presentation. So Silke, please. So nice to see you. Go ahead.
Yeah, good morning, everybody. It's a challenge at the moment. I know I'm also in home office today because we want to save the health of and protect the health of our colleagues in the office. So I'm happy to be here, and as Björn said already, it's a great pleasure to be again partner of this wonderful conference. The standards project is something we had in mind as we started already EFCNI, that this becomes such a real big movement worldwide in the meanwhile, that also World Health Organization is looking at it. And as Björn said, we collaborate for a very long time together from the very beginning, when we as parents were often seen as someone who not belongs to the baby and is more a visitor instead of a really part of the main caregivers. And Björn was one of the key really supporter in the very beginning, and stood up all the time when people criticized me or us with the family-centered care approach in the beginning. And now we really have a movement worldwide. I'm very happy to be part of this and happy to be with you today, also when we not can be physically together. So I wish you all the best, of course, for the next weeks and months. And so I'm happy to now start with my presentation and giving you an overview of the project, and also some insights in one of the standards, the nutrition part, especially breastfeeding, because this is something where I was thinking together with Björn that this is also important for the program today. Yes, again, welcome to this project overview. And as Björn said, I'm an affected mother. I'm not, for my background, I'm a preschool teacher, so I'm not a neonatologist and not normally working in healthcare. The reason why we have started this is really somehow also anger that things were not moving, but also we saw as we founded the EFCNI that we have this huge inequalities between the countries, and being here in Munich and being in, I would say, in this island of having never seen outside the neonatology across Europe, it was quite surprisingly for me as a patient to see how different it is. And even the years before, as I was 8 years the president of the German organization, I saw several hospitals across Germany, and I saw this huge inequality between these different hospitals, the way how parents were treated, but also the difference how babies in general, all the healthcare issues were handled. And so this was one of the key motivations for me and all our partners in this organization and project to really make a difference. And so the ones of you who never have heard maybe about my organization, EFCNI, it's the European Foundation of the Care for Newborn Infants. And we have founded our organization in 2008. And our first idea was really combining forces between the different patient and parent organizations who have existed at this time, but also with healthcare professionals to work hand in hand to make a difference. And we are were the first parent organization across Europe. In the meanwhile, as Björn said, we have founded GLANCE, which is a global initiative to combine forces also on a global level. It was planned in the very beginning to go global, but we were only 2 people with a lot of dreams and no money, so therefore we couldn't really think so big in the very, very beginning. You see here a picture of our last parent meeting we had here in Munich. We have this once a year where we meet together the parents, where we make plans together, where we developed also World Prematurity Day in 2008. This was the idea of really having a day which many of you, or most of you, I hope all of you know already in the meanwhile, and celebrate every year. So our idea is not only raising awareness for the parents' needs. For us, it's important to work hand in hand with the healthcare professionals, and this is also why we developed the standards. We are working research projects together, and the areas where we are working are the fields of preconception and maternal care, so to prevent preterm birth or any kind of birth complications, to treat and care the baby in the NICU and in the hospitals really proper. And for me, as a mom of a preterm born baby, in the meanwhile 23 years old, I'm also thinking, of course, a lot about the long-term consequences, and I also will take care in my presentation and show you some pictures what it really means for us parents. It not ends at the end of the NICU time frame and after discharge. This is the journey where for us parents it really, really starts, and it's a really long, long way. And for some parents, it's the lifelong consequences, also financial burden. So for us, it's really important to take care also of the discharge of these children. Our network in the meanwhile is really huge. So we have more than 100 parent organizations across the world. So we started with 16 parent organizations in the very beginning. The most of them were very, very small, 1 person, 2 persons. In the meanwhile, we helped them to build up really to be a strong advocate in the different countries. We work with more than 20 global healthcare organizations together. That's, for example, the FIGO, the World Health Organization, We Save the Children. This is a wrong number, what I have here, the 30. So we have more than 190 European and national healthcare societies in the meanwhile together, and we work in different areas to really make a difference. We have seats as a patient representative at the European medical agencies, at the World Health Organization, and also we have attended at the G7 preparation meeting. So we really try to represent this topic, but also the parents in these different areas of maternal and newborn health. The project itself, it's very important, and this is what I'm really fighting for, is that we have a really big transparency of our project, but also of everything what we are doing. Our organization, and as a patient representative in Europe, for example, you are not really supported from governments or any other big institutions. We are working with industry partners together. All of them are supporting us, and here you see the names and the logos from the companies who are helping us for this project. And maybe you will ask yourself why they're working with Nestle together. You will see when we go to the nutrition part why I personally also, but also our organization, thinks it's important to work with industry, having proper products for our babies. And I'm a real fighter for breastfeeding, you can believe me, because I lost all my milk during the first weeks in the NICU, because I had no support. I had no support, I had not any kind of advice. I was lost in this journey, really, and I'm still angry about this, because I left the hospital after 2 weeks, and then no breast pump was available. Nobody supported me. I got not advised, because the message was for me, well, we don't know if Lucas survives, so then you have milk without having a baby. So that was the reason why I got no support. There was no milk pump available for moms at this time. It's because you were discharged, so you had not the right to have a milk pump. So I'm really a fighter for this. But we also need supplementations. We also need good alternatives. And this is why we work with all these companies together, because I know that a lot of people from a global perspective are here, and maybe you asking why we are doing this. We have started first to ask for a European research grants for this project. We failed twice, but we didn't want to wait longer, and therefore we decided to work with industry partners. They had no influence in the project at all. They only were observer or even nothing at all. So a little bit background to this project, why this project really was needed and is also needed on a global level. The difference between these European countries and the actual corona situation shows it very, very well how Europe acts. So we have health is a national issue. That means each country, each hospital still can, across Europe, have their own protocols and guidelines. Most of the guidelines are not binding, they are recommendations, so it's very, very different. Often it is the people who work on a shift who really do this, and the other do something different. What we have recognized, and this was a 2 years work before we have started this project, was to find out what is the infrastructure of the whole hospitals across Europe, how many hospitals we have across Europe who treat preterm infants. And it was really a disaster, to be honest, to recognize that not all hospitals really are somehow registered in one big data registration. They also, the most of them have no data about these children. The babies were not really registered when they were born. So we've started with a benchmark report first, and we recognized that only in 16 countries, and we have it the EU, or at this time we had 28 countries, and we had only 16 countries where we could find any data about preterm babies or babies in general. So therefore we said, okay, data is one of the big issues. We recognize that the infrastructure of high-risk pregnancies are very, very different in the different countries, even in one country, even in one town. Also in Germany, my own country, where all of you know we are a very, very rich country. The organization of the medical centers were different. We had different transport systems. We recognized at this time that Ireland, for example, and we hear later today, Mandy, our very close friend and partner in this project, and also at EFCNI from the very beginning, she was fighting for years to get a transport system in the evening and on weekends, because this was not organized in her country really proper for very tiny babies. We realized that the education and the trainings of healthcare professionals varies from country to country a lot. But in Europe, you can move when you want to work, for example, in Sweden, or Swedish people want to work in Germany, but there was not really a proper European-wide regulation. follow-up is really different organized, and in the most of the countries across Europe, still not like we would like to have it with a preterm baby. The medical treatment was one of the key issues where we had also struggled a lot to do this project. You can imagine that only a topic like jaundice or breastfeeding or how to resuscitate. We had a lot of discussion, how to treat a baby with sepsis or how to prevent sepsis or ROP or BPD. These were discussions where I never thought that there are so big difference between the countries. The level of family-centered care, NICU design, and also nutrition was a big issue. And when we started, and this is where I'm still extremely grateful for Björn and also the whole Karolinska, is that we have these topics as an individual topic, because you can imagine that all these people at this time, not today, but we started this project in 2012 in total as a discussion, and at this time nobody wanted the family-centered care approach, and at this time we called it family-centered care. They wanted it as an individual standard package. They said, well, that's something really emotional, that's something what we not need, so therefore why should this be really an own topic? There is no evidence behind. So there were a lot of criticism at this time to have this really as an individual topic. Also the care aspect, care, the nurses, does this really need an own topic? There was a huge discussion, even I have to be honest, also sometimes some very strong discussion, if not to say really a fight. And NICU design was the same aspect, and Karolinska really took here responsibility with Björn Westrup and fought for us and with us to have here really a big voice. And I'm very, very grateful for this today, and for sure Björn forever. And here are some numbers, what are so different. So when you see here the different numbers of, for example, mortality rates, that's really huge when you see this in the different countries. You see here the different countries, and then the next one, the numbers, and you see that neonatal mortality rates are different. Preterm birth percentage rates are very different. And so these were things where politicians, for example, never have thought before about it. And so this helped us a lot. This is the Europeristat, where you can find easily on online. And with these numbers, we started the discussion on the political level, on hospital level, but also on the healthcare societies level. That is a need. We have to change. We have to make it more equal. And you can maybe imagine if parents and parent representatives sees the numbers, they are shocked. When you are close to a border, for example, in Italy or in the Netherlands, and you would in Germany survive, but in the Netherlands they have a different regulation and they would not start treating the babies under this or that week. And the first time, I never forget in my life, as I visited Björn and I saw the first time Karolinska, and I saw rooming in situation for intensive care babies. I saw palliative care rooms where you could treat a baby, or not baby, it was already death. You could treat parents really in a very, very nice way when their baby passed away. I had nothing like this. And I was so shocked. I was so shocked and so angry in total that I cried and cried and I couldn't stop. And then they were overwhelmed, of course, at this time. And I just said, well, this is something I have never, ever thought that this would exist. It was something like Here to the Moon. This is something I have seen the differences. It was not something like Star Trek. It was real. Sweden did it very, very differently, like Germany. And then when I first in my life saw East European countries, hospitals where they had, of course, a lack of staff, they had a lack of equipment, they had a very, very different way of treating babies and families, I said, well, we have to change the situation. And that's the background, that you understand what kind of emotions, but also what kind of facts were behind when we started this project. So the process itself, it was really, really a challenge. So that's something to make you a little bit aware how politics work here in Europe, but also between the healthcare societies. So we had a lot of advice from agencies who helped us to understand how such a project should be developed. We made a lot of research in other health areas, like in cancer, in heart diseases, in HIV, to understand how other health areas have done such a big project. We got a lot of advice from agency how to handle in the end the different healthcare aspects of gynecologists, midwives, nurses, parents, industry, systems like hospital administration. We needed ophthalmologists, we needed the respiratory healthcare area. We needed a lot of different people, different societies, different systems. So how can you handle this in such a really big project? And I guess most of the people in Europe, they didn't believe that we can manage it. And today, maybe I would say also I was this crazy young lady and had these ideas. So it was, of course, not so easy. What we have done is we just sorted out from the different presidents, the key presidents of the societies we really have to have in the boat. And at this time, it was Professor Bertel Kolecku. He was at this time the president of EFCNI, so the nutrition experts across Europe. It was Professor Luke Zimmermann, who was at this time the president of the ESPR, so the biggest research organization in pediatric and neonatology. Professor Giuseppe Bonacore, he was at this time the president of the UENPS, so this is the organization of the different national societies. It was Odile Fraunfelder. She was at this time the president of the Neonatal Nurses Society. And then we, of course, tried to combine forces in the European Parliament to get really a good statement. That's something what we really need. All the other, there are a lot of more people like Björn, who helped us with the family center care approach. There was Pierre Kuhn, who also comes today and is a speaker. There were a lot of nurses who helped us. So there was a group of, I would say, maybe 25 people, key opinion leaders across Europe, who said that is something what we need. Because still at this time, we had a lot of criticism why this project is needed. Does a parent organization tells us what we have to do? But this was not what we wanted. We wanted to combine forces, but we wanted also people behind us who help us to realize such a project, even if at this time we had no 1 cent and no euro what we could do. So this was in the end just a message, and this is what you see here. We had a huge event in the European Parliament with a lot of symbolic signatures and also symbolic support of several societies and parent organizations. And what we then did, and this is very, I don't know if you can see my mouse. Can you see my mouse? Yeah, I hope you can. So I would start when
we can see your mouse. We can see your mouse.
Oh, super. Perfect. So this what you see here, we developed together with 220 experts and with around 35 key experts the idea of this project. The first was that we met every year with a chair committee. The chair committee was in the end, Björn was together with Pierre Kuhn, the chair of the family centered, infant family centered and developmental care project topic expert group. That was one of the groups, and in each of these 11 groups were 2 or 3 people who managed in the end the project with us. That means they had the head on and they had to coordinate the other authors and their topic. So that was really a lot of work what these people agreed to do for this project. All of them have worked voluntarily. Only a few people in our office were paid to manage everything and to manage in the end the meetings and the technology that we can manage this project in total. But all the 220 people worked voluntarily. So that means in this group here, why is it not working now? So this group was in the end meeting once a year for 5 years that we could coordinate and manage it. In this time frame, so in the first year, the first meeting was really challenging because of course, nobody really knew what's going on with this project. The first key thing is we have to find a common solution how to do it. And do we really want to have minimum standards, or do we want to have best practice standards? And it was a really 2 days discussion to decide that we need to have best practice standards in Europe, and we cannot accept minimum standards. That's something what we said, this is what we not want to have. So the next step was then to develop one common template where all of them work together and all of the standards in the end look at the same way. So that was the idea. And here we had this template. That needed another year to agree with this big group on the same level. We then started with this 220 experts to develop standards. And you can imagine when 220 people write on one project, you have in the end more than 1,000 opinions. So that was really, really challenging. But our chairs did a really great job. So therefore, we are very grateful that they had loops and loops and loops to discuss this, although most of them took place digitally. We had several review processes so that the chairs took care of all their standards, did all the proper work with the references, and checked the different opinions. So they really proved it. And what was also a really big work was the editing process. And you can imagine 220 people from more than 35 countries write in English such documents that the grammar and also the style and everything is different. We needed in total 12 working days that we could really work on this. And here I'm very grateful to Neil Marlowe and Dietmar Schlembach, who helped us to make this possible. After then, all the authors have to see if there was a change or is this still the way how they want to have the standards. That was another couple of weeks. And finally, we have, of course, to make a really proper edit, a really proper formatting, that the standards you find now on the website are looking in the same way, are really in the same document, have the same wording and the same design. So that was another couple of weeks. After this process, here you see this, we had a Delphi process, a kind of Delphi process, a voting process. All the standards went to the chairs and they had to vote of them. It's not that you can vote one package. Each of the 96 standards have to be voted on. So that means that they had to read it, they had to check it, and then they voted. And only the ones who had an 80% agreement were then in the end accepted. And you can imagine that some of the standards, especially the family-centered care and the ones where the whole community is not so happy about it, they were close to 80%. So of course you have to have a treatment on sepsis, on jaundice, but having 24/7 access to the parents have access to their baby, or breastfeeding, or this kind of things, had a very, very high risk of being not accepted. But we made it. We really tried to motivate the people to see the importance of the parents' involvement, and that's really key. What is really a difference to all the other guideline processes you normally maybe know in your countries is that in this project, in every single step what I showed you here, parent representatives from across Europe were involved, even across the world, because we had people also from the US and Canada involved in this project who helped us to manage it from the parents' perspective, and also from Australia, from really getting more global perspective. We hope that with the Glance project, we also get more members and colleagues and friends and partners in other areas of the world, like South America. I know that many people from Asia are here in the call, from Africa. Please help us to make it possible that we get a global voice on such projects in the future. What after this 80% voting was that we asked all healthcare societies and parent organizations across the world to support this project, to agree that such combined standards are helping us to make a difference in the different countries, that we have to work together, that it's more equal in the future how we care for our newborns. That was done then afterwards, and now we launched the standards in the European Parliament. I have a picture for this as well. And what we are now working is on this is the long process for the next years, is the implementation process. What I also show you what we have done already so far and what we are planning in the future. Already after 1.5 years, we work on a life cycle process. That means the standards were made in the last 5-6 years. We cannot have the standards forever because health is something what it moves, and we have to have updates on this project. That's really a challenge. You can imagine 96 standards. We have to make them always updated. This is why end of each standard is a date where this standard has to be updated. So at the moment we are working on 18 standards where we are already on the life cycle process, and still 5 standards were not finalized because the quality was not what we wanted. So in 21 we will have the next loop of the updated standards, plus hopefully the new standards are published here as well. So you see that this process was very complex, and it is really a process where we not have founded it. It's a process what we saw from other guideline processes, from global guidelines or recommendation processes. That's not something what EFCNI has developed. It's something where we have learned from other experts, and this is why we have combined these forces with these other societies and experts to have really a proper project where others can then start to implement such standards in the future. That was the idea behind, and I'm very grateful that all these healthcare professionals gave us so much advice. And again, I'm not a healthcare professional. I'm a preschool teacher and a mom, and I'm happy that we got so much support from all of these people. What we have done then, what I said before, is the different societies who has given us the support. Here you see the actual numbers of the different societies. This helps us, of course, to spread the message and to get acceptance from politicians, from institutions who want to implement this now. We have several countries who on a governmental institution now work to implement the standards, like in the Ukraine, for example. In Portugal, they are working. In several countries are just examples where they are now taking the standards and try to implement them. The parent organizations are key drivers, but I show you also what especially the parent organizations have achieved and how powerful our parents are. Here you see how we have launched the standards. We had 2 different events. One celebration event in the Bavarian representation in Brussels. So Munich is where I'm coming from, is in Bavaria, and we have a huge castle in front of the European Parliament as Bavarians, and so we had really a big celebration. And on the next day we had a huge event in the European Parliament where we had politicians who supported us, different societies, also the World Health Organization joined us, and so we could really send in the European Parliament, there is a need, we have to change, we have to improve, we have to really implement the standards in the different countries. So the topics themselves are, we hear today a lot of the different topics, of many of them, not of all, but have a look also, of course, on our website. But here are, again, the topics. So we have 11 different areas. We have not started in pregnancy because the FIGO and the EPCOG organization have worked on pregnancy guidelines and standards, so we didn't want to reinvent the wheel. What we have done is, we started at birth and transfer. So what is important for the babies, where they are born, how they are transferred, the baby themselves, but better would be, of course, the mother is transferred or the pregnant woman is transferred. And this is where we have started the standards. The medical and clinical practices, the care procedures, so what the nurses are doing, the infant and family-centered developmental care aspects, what Björn is presenting today. What's about NICU design, because this is key to really be able to do all the things what we want to realize. The nutrition part, where I take more focus today. The ethical decision when a baby dies or when they have to be made a decision, how to do it, what we have to take into account, what's going on at discharge and follow-up, what's about patient safety and hygiene aspect, the data collection documentation so that we also can benchmark, but also know more about these babies later on. Education and training is one of the key aspects, and being a preschool teacher, you can imagine that this is something what for me comes really from the heart. So today I want to focus on the nutrition part. And when we go to nutrition, you maybe think, well, that's this package, but it has maybe not influence of everything else. But when you think about breastfeeding, or you think about parenteral nutrition, you think about the long-term consequence of nutrition, the growth, then you would see here it has, of course, when you want that babies get breast milk, and then you have to have, of course, the infant family-centered developmental care aspects. You have to be able to bond the two, because then the milk is not flowing. When you want to have this really implemented, then you have to think about care procedures, because the most of the aspects of breastfeeding and bringing this together is also care. It's also what the nurses are doing, and also how the NICU looks like. So if you have no space, if you have no opportunity also for pumping, how should breast milk and nutrition work? It is an aspect of patient safety and hygiene, because when we talk about parenteral nutrition, it's a patient safety issue. And so therefore, it has also an influence in this area. Education and training, if the nurses and doctors and all the other key experts, nutritionists, are not really proper educated and trained, how should in the end a good proper nutrition plan work? And the discharge management and follow-up. It is so important to have really a proper discharge management plan, that this breastfeeding is also working at home, how the nutrition works at home, that the baby can grow and can really grow up healthy. So when it goes then in the end to nutrition, we have the different nutrition parts, like the guidelines on nutrition care. You find all of them on the website. As I said before, we have parenteral nutrition. We also have a standard on preterm formula, on early enteral feeding, on growth and monitoring, on parental knowledge about the feeding, because we parents have to know why breastfeeding is so important, why we have to pump, how often you have to pump, what kind of equipment we need, the hygiene aspects on that. That's really important, what parents have to know. And also about parenteral nutrition, parents have to know the risk of this part, but also why this is needed. We have to talk about early nutrition with human milk, about donor milk, about supplements, and this is why I'm focusing on, is on why we have to encourage the mother and also help and support the mother to be able to pump and to breastfeed later on, really when the baby is able to suck themselves. And why is this for me so important? I said a little bit about it in the beginning. So my son, or my children, were born in week 25. Lena died after a week. Lucas survived. I had a resuscitation. It was not clear if I would survive or not. After 3 days, I saw the first time my children, and that was the picture I got. Lucas had only 515 grams. I could kangaroo him after weeks later on. I had no support for breastfeeding. I had no support for anything. There was one chair I had to share with all the others to be able to kangaroo. So at this time, it was a disaster. Of course, today, many, many things have changed. But today, many people from all over the world are watching this webinar, and maybe later on as well. So we know that in many, many NICUs in the world, the parents are not welcome. They have visiting hours for 1 hour per day, 1 hour per week. Even in some countries in the world, not at all access. How do you think breast milk should flow? And the consequence of having not really a good proper nutritional plan, and that means of course breastfeeding, that means also supplementation, that means a good and safe parenteral nutrition, that means really everything. And for me personally, a baby born too soon, too small, or too sick is a nutritional emergency, and how they are treated have a long-term consequence. And you see the picture next to him. The small one, of course, is my son Lucas, and the next one next to him is my nephew. And they are born. Lucas is born February 17, and my nephew 1 week later as a normal baby. And you see here the differences. And my mother, for example, she always, because they were born in the same week, she bought always the same clothes. And many people maybe now laugh and say, okay, that's the consequence. Yeah, but can you imagine how I was looking on this picture when I saw this the first time? I was crying because I saw that would be if Lucas would be born normal. If Lucas would really have a normal nutritional plan. If Lucas would really get all the nutritional needs he needed. Lucas, you will see later also a picture, has made a really good journey. But I live in Germany, I live in Munich. We are both preschool teachers. We have invested an enormous amount of money, and we have really reduced everything else just to invest in him, that he will have a really good life. And that's something what not all babies in the world can do. But you can make a difference in nutrition, and this is for me key. How can you support parents in breastfeeding? How can you ensure that each of this baby have a good and proper nutritional plan? That these babies really get what they need? That they have also supplementations? That they have support and advice when they are going home? That they really get what they are needed? I'm absolutely sure that everybody here in the room knows that there are lacks of giving this kind of resources. We are not all living in Germany or in Sweden, but there are many, many people maybe who have opportunities to support this in a very proper way. And you see this picture. I live in Munich, I live in a rich area, and still Lucas had not this kind of nutritional plan, what he would needed. And I had no support in breastfeeding and support. And also in Germany, not all parents get this kind of support of breastfeeding so far. And so therefore it's really important, and I'm speaking not about my psychological burden I had at this time. So what can you do? You can provide information and training for parents and staff in your unit to really be able to, that the parents can, or the mother can breastfeed, that you inform the parents about the importance of nutrition, and your staff, that they also have this kind of support. You need lactation support, so qualified staff is needed. So therefore it's important that these nurses have time to support the mom that you see here in the picture, that she can breastfeed and is relaxed. How can you provide space and equipment and privacy, or their own pump, that they are able? It's a very, very intimate situation to breast milk, so you need also space. And the privacy of doing this. Welcome parents 24/7, seeing them as your partner and not as visitor. Provide healthy nutrition also for parents and mothers. I had no food and no opportunity to drink during my time when I visited Lucas. It was really something what I cannot see sandwiches anymore, because I had sandwiches for 4.5 months, and this was the only food I could get, and this for a very long time. So we need really proper food and space where we can sit and relax and eat something. We have to have motivation and not pressure. And that's for us very important, because the milk was not flowing. The milk, I was stressed, I was overwhelmed, I was sad because my daughter died, but there was nobody who had really time and was patient with me. How can you provide support and advice at discharge and also at home? Is there a system in your country, or can you build up a system in your country that midwives or neonatal nurses or case managers can support parents at home? And if you not have yet, of course you as an individual, but also together with parent organizations, healthcare societies, you can fight for a longer maternity or parental leave. That breastfeeding is important, and breastfeeding is key, especially for the babies born too soon, too small, and too sick. So in this project, we really tried that we have a theory, so we have the standards, and then we want to implement them. But what you have heard, and you see at the corona pandemic at the moment, that health is a national issue. So our standards at the moment are standards we have developed. These are recommendations, and you have to implement this really on a national level. That means, this is what I have said, now we have to implement them. And implementation means, on the one hand, of course, to translate this on the national issue. That means not the translation of the English wording to Italian, for example. It means really on the practical aspect, because in some countries it's a governmental issue. In my country, it's a state issue, or it's also a hospital issue. You have to see this from country to country differently. And in some countries, we also really have to translate this in their national language. We are already translating the standards at the moment to Italian and to Ukraine, because these are the first countries who want to have this implemented really proper and also ask for real translation of the whole standards. So where can you find the standards? The standards you can find on this website, www.newborn-health-standards.org. And when you go on this website, you go on the standards themselves. You find at project several information about the project. You find some policy information, use, but the standards themselves you find on the standards wording here. So one example, for example, is medical care. You go there, you find in each of the standards, you find the overviews. Then you find the standards. And here you have always a nice picture, then the overall topic of the standards, and then you click on one. Here you see the ROP standards, so the prevention, detection, documentation, and treatment of retinoscopy of prematurity, ROP. And here we start always with the authors. In this case, it was Anne Hellström, together with Lena Hellström-Vestas, Luke Zimmermann, and Giuseppe Bonacore, and several other key authors. You find the target group, the user group, and the statement of the standard. We always have a rationale that shows you with more details why the standards is really needed. You see always references. We were very, very strict with this because we need the references and the argumentation for the political implementation, or for example, for lobbying for this. So this is why we really were very strict to have for each references. We have also the benefits, so the short-term and the long-term benefits, also again with the references, also needed for making political activities, for making lobbying to fight for the change. So why should a politician change something when he doesn't know why it is important? That's the reason why we were here so strict. Then it comes to the core issue of our standards. This is the standard per se. You see here a table where you have the parents and the families. That means what is important for them, for the healthcare professionals, for the neonatal unit, for the hospital, and for the healthcare society. And this is in the end the idea behind this table, so that for each of them you find what you can do and what you should do. So we also were very strict with the grading of evidence and the indicators, because our idea is later to measure in the end if the standards are really implemented, and how they can implement this, how can they measure it, and which kind of quality the standards really have. When you want or you say, for example, you have already everything. Maybe in Sweden, some of the hospitals say, well, this is a standard we have already. But there are always ways you can make things better. And here you find where to go. That means what else you can do. And this is a table where you can see more advanced issues. Most of the countries would have a look first on this area, means getting started. When you see the standards is so advanced, you don't know how to reach this at the moment and not in the next couple of years. You could maybe be very frustrated, but you should not, because you find this table. And here you find a lot of ideas what you can do to start to reach the standard somehow in the future. We have for some standards, because we are very limited with space, so we allowed only an amount of letters in our rationale. So we have more information in the description. You find the sources here when you open it, so the different references. And here you find then in the end what version it is and when the standard needs to be updated. The outlook. What we have done so far. After the launch, of course, we have published the standards. We had a publication in the Lancet. We have a lot of materials you find on our website, because maybe now you say, yeah, well, how can I start? You find here a lot of social media graphics. You find fact sheets, what you can download. You find information brochures, so the whole standards, packing them in a shorter version, only with the statement of the standards. We have this already in several languages. We will have soon Spanish and French. So Hungarian is also in planning, as far as I know. So therefore, there are a lot of languages available that you can spread the message about it. We have a lot of PowerPoint presentation that you can talk about it. And I can also strongly recommend the project report, because this gives you much more detail as my presentation, what's behind the standards, what's going on. And so you can everything always free of charge download. And now maybe you think, oh my God, how should I reach politicians? How should I reach maybe the director of my hospital? What you can do, and that is very, very detailed, is our toolkit. You go on the website and you find also in the downloads the toolkit. This is really a proper handbook, what helps you for more information about the project. How can you start? There's a proper advice on advocacy on an EU level, but also on a national level, so that you can maybe also use it on your national level on a global perspective. There are a lot of communication ideas, best practice examples, a lot of materials to download. That means, for example, letters to politicians, letters, what you can do, a whole project plan, how to organize maybe a round table, or how to talk to politicians, to journalists, so that you really have an idea of what can you do. Everything is free of charge, everything is free to download, and if you have questions, please feel always free to come back to us. Now, a short overview of our parents. Our parents are really the power behind this project. We have started 2008 with all our dreams. And our dream was really to make it more equal. And we started with our parents in 2016 with a proper training program. We have trained them in understanding what standards are. What is the difference between guidelines, recommendations, standards, or a law? What is country specific, and what are the challenges and how can you face it? That was one training package. The next training package was in 2017, where we shared best practice examples from different countries, some lighthouse projects. We asked already what are the implementation process, are there anyone starting already? And we planned with them, each of them, a 5-year plan per country. In the 2018, we went then into more political actions, like call to action application. We made a stakeholder mapping, who in their country are the key opinion leaders. This was needed to get in the end agreement for the standards. So we asked them to reach out to all of the national presidents of societies, of their key opinion leaders, to inform them about the project, to ask them if they want to implement them after the launch, what is their role in the country. And in 19, this is why you see here already the figure where they start to run, is that we really make presentation trainings, how to present, how to move on, how to motivate the people in now starting the implementation. So that's what we have done the last year. And the planning for 2020 and 21 is having tandem workshops where healthcare professionals and parent organizations from one country come together, and we train them country by country by country to mobilize in the end and make the process faster. Here is just a bench of ideas what our parents have done and activities. We had expert roundtables, we had policy events in the national parliaments, we had conferences, we have already really working groups where they implement the standards like in Portugal or also in the Ukraine. So they are really huge activities. And on a global level, it's also that we had a global activities with a global summit. I had the opportunity at every newborn action plan at the World Health Organization to present the standards. And so this is something where we have a lot of global activities as well. And so now the movement, hopefully that Corona is not killing us with this movement, so that we can continuously working on this. And this presentation, for example, and this conference is one of the key success stories of our project. What can you do? So you hear later today for sure more and more. So you can start now to see what in your hospital is, for example, missing, or what you already are doing very well. So these are standards where you not have to look in more detail. And so that is what you have to do now to identify where are your needs and where you are already quite good. What is a really good, proper plan in the end for your hospital. So have a look into the standards, or where you already know there is a lack in your hospital or in your country, what is needed to realize. And then start in really the process with many other stakeholders. Don't go alone, work with others together, because together you are first of all much faster and much more successful, and you can learn from each other. So here, look into these details. Take home message for you. Work with the standards and help us to improve the health for mothers and babies across the world, in your country, in your hospital, in your region. Make really an initiative and start with your colleagues to see what can be done, what needs to be done, and start maybe with a smaller, more realistic standard instead of really the big problem standard, because that's something where you maybe then also get frustration. It needs all of us to make a difference. It needs partnership, and it needs commitment, and you will need time for doing this. You cannot change the world from one day to other. You see, I have started my journey in 1997 when my son was born. I started in 1990 with my first parent group in Munich, and now we have 2020 and we have the standards developed, but they are not implemented. So it needs till my retirement, and this is the next 20 years, to start the implementation in a bigger phase. You can inform us and should inform us when you are acting and when you are presenting. It would be great if you get in contact with us if you have questions, if you need something from us. We are more than happy to help. And I would close my presentation with a picture of my son today. Lucas is 23 years old. He is studying on one of the most famous universities here in Munich, at the Ludwig Maximilian University, sociology and ethnology. He wants to change the world for people across the world to have more equality in the different countries, so not in preemies, more in general. And what he wants to send you a message, he gave us this quote last year for the standards. Babies born preterm do not only have a tough time during the first days or months of life. Preterm births may affect us and our families for a lifetime. Lucas had an ROP too, and he struggled with his eyes. As you have seen, he is not as large as he would be born normal. He has a small cerebral palsy on the right side. And we struggle. We have the opportunity here in Germany to make it very, very good for him and for us. But every year, 15 million babies are born preterm. Not all of them have these resources. So it makes a difference how you in the future act, what you can do, and everyone, really everyone, can make a difference. Thank you very much.
Thank you so much, Silke. Fantastic as always, and emotional also. So we are a little bit short of time, but so we can save questions. Unfortunately, I think you are not able to stay throughout the whole conference, are you?
Yes, I'm not able to stay the whole day, but I will try to let it open so that when there are questions, I have also my WhatsApp with me, so that when there is a question during the day, I'm with you.
You're with us, good. We are with you.
Okay. Just a short, there's no question for you yet, at least, but they wanted to see you again. So please put your video on again.
Do you see me?
Yes. Okay. And actually, Silke presented a few things that helps me to present, because I can skip a few slides. As she said, I'm going to present on just this topic expert group and the whole day, and I will present just one of the standards, and that's, I think, the most important. It's called family access, but in the future we will re-edit, and we will call it zero separation and couplet care, maybe. But also, as she pointed out, and she has been enormously successful in making this a global perspective. I'm extremely impressed by all your contacts globally. I will touch on that. But here is our group, the Infant and Family Centered Developmental Care Group. And Pierre Kuhn is the co-chair of this group, and you can see all these members from all countries. Several disciplines: physical therapists, occupational therapists, nurses, of course, neonatologists, and psychologists. And we will hear from many of them today. In my presentation, I would like to talk a little bit about terminology. Developmental care, Silke mentioned, was actually the first term that was mentioned originally. And then people started to talk about family-centered care, and then later on we had patient and family-centered care, where you put the patient in the center, not only the family. So this is the next thing that I've heard about, and we'll hear something about, is family integrated care, and we will not cover that much because it's actually a program and not a generic term as the other terms. And family participatory care is something that they have coined in India, and I will come back to that later. But in our group, we actually quite quickly decided on this terminology. We thought that this was, all the different professionals thought that this was the best way to call it, to frame it: infant and family-centered developmental care. And of course, developmental is very important to have in this concept. I'll come back to that. Now it started up in Europe, and it has been accepted also in the United States. We will hear that from Joy Brown at the end of the day, or in the morning in her place where she's in the US, and it's also now getting globally by the GLANCE initiative. So what is the IFCDC? As I said, it's a generic term of nurturing care of the newborn, with goal to ensure best health and development into adulthood for every individual infant, by optimizing both individual care, hospital systems, and it's founded on the leading edge work of Barry Brazelton and Heidi Lisals. They were the pioneers in this area, I must say. And also, of course, founded on the Declaration of Infants' Rights, developed by the WAIM in 2016. IFCDC is easy to remember because CDC is something you talk about these days, don't you? And just add IF in front of it. IFCDC is evidence-based. The science of neurobehavior, neurodevelopment, parent-infant interaction psychology, parent involvement, nursing science, breastfeeding promotion, we heard about that, environmental and systems adaptation, very, very, very important. We say IFCD had 3 core principles, and it's sensitive, responsive caregiving or parenting based on the behavioral communication of the infant is essential foundation for the child development. This is self-evident for older children, but it actually definitely applies even more important for our immature babies. The third principle, that parents' engagement promotes, of course, parental well-being and parent-infant relationship, and thus child development. And finally, it's an individualized care. It gives the baby a voice of its own. So remember, this is a generic concept. Several programs try to address these things, but some of them more completely than others. So this is the IFCDC. We have the different standards. We mentioned zero separation, talk about that today. Continuous skin to skin, not so much today. Parental infant bonding, we'll hear about. Parental involvement, we'll hear about sensory environment. Also, we'll hear about supportive services, something, and case management also we'll hear today later. And clinical consultations and supervisions for healthcare professionals we will hear Sari talk about that later. And education and training may be very important, maybe the most important, or not the most, extremely important topic. So I often use this picture that Heidi Als made 1992, but I think it's very useful to have the systems thinking of the infant system, parent system, family system, NICU system, hospital system, and community systems. And of course, you all know that it's so much happening in the brain of the infants. That's why the developmental part during the care is extremely important to underscore. You need to have the competence to observe the infant, how to interpret the behavior of the infant, and how to support it during painful procedures, for example, and to promote by co-regulation, to promote the baby's self-regulation. The baby is regulating you, the caregivers, the parent, and you regulate the baby. It's a co-regulation. That's extremely important. And that enables for social interaction and parental bonding and infant attachment if you can help this self-regulation of the baby. Also, I don't need to go into the standards format and template because Silke did it so well, so I just skipped those slides. I go directly into the zero separation issue. And we have these, I'll show you a set of slides from Stockholm, Sweden. And you can see here slides where we keep the baby as much as possible together with the mother and father, even if we need to do caregiving at the same time. It's extremely important. You can see these parents, they don't know what we are doing, but we know what we are doing. We have the equipment, we have the monitoring, we have the gases and everything. And also after C-section, we are very keen on keeping contact with the mother as much as possible. And in this case, unfortunately, the mother needed intensive care of her own, so she couldn't come into the NICU for a couple of days, but the father was there, skin to skin with the baby. Breastfeeding, Silke covered. So I think she was completely right to emphasize this as a very important standard. Virtually all mothers can breastfeed if, as she pointed out, if she gets support and information about breastfeeding. But also very important, we need to start very early, not only with expression, but also giving this half milliliter or milliliter of manually expressed breast milk to the infant as soon as possible by a syringe in the mouth. It's doable. And in a global perspective, of course, exclusive breastfeeding should be done up to the first 6 months at least. It's for survival purposes. So we need to support the breastfeeding. But couplet care, it's the sort of top notch of family of IFCDs, I would say. Couplet care, in this concept, it means that you from the very start are coupling the care of the baby with the care of the mother, the medical care of the mother in the NICU, in the same ward. And of course, you all know that maybe 30, 40, 50, 60% of the mothers that give preterm birth do it by C-section. And or other they might have this hypertension, diabetes, and whatever, preeclampsia. So they definitely, the majority, I would say, have medical needs of themselves. So that's why you need to try to couple the care in order to avoid separation. Twin mother, diabetes, C-section in week 31. Midwife or postnatal nurse checking the uterus and the mother in the NICU. And our experience and research has shown that it reduces the total length of stay, especially during the most intensive care period, which is also the most expensive care period. It reduces the incidence of lung morbidity, reduces mothers' anxiety, and boosts their feelings of competence and as a parent. It improves and attunes the mother's infant stress regulation, and it enhances breastfeeding. 3 months post-discharge, we have some unpublished data from the Stockholm trial. But of course, sometimes the mothers are too sick. And the exclusion criteria for couplet care would be severe preeclampsia, or eclampsia, of course. And also if the mother has had a large bleed or other hemodynamic instability, other reasons for intensive care of the mother. So we don't propagate intensive care for the mother in the NICU yet, at least. Maybe in 10 years, we don't know. And of course, if she has contagious diseases, we have to take some extra precautions. And also if she has severe psychiatric illness. But then, of course, often the father or a relative can be present. I will not talk so much about the NICU design, but of course, you have to redesign your NICUs if you will be able to do couplet care. Just one slide. I think that sorry, it was Stina that texted me a message, but I read it afterwards. She can talk with me loud if she wants. Anyway, at Karolinska, we have the experience of having one area where we have the most intensive care with mechanical ventilation, chest drains, and these hundreds of IV lines in one area where we have space for the mothers to have a decliner or a bed, but we don't expect them to sleep in this area because it's so taxing for them. We have family rooms in a suite model adjacent to the intensive care area or a few steps away in the corridor. And remember, the family rooms need to have their own bathrooms, showers and toilets. And if you have couplet care, you need to provide big bathrooms for the sick mothers. So that's one thing that I want to point out. But as for the global perspective, it's very important to remember that you see the size of these circles, the pie diagrams, represent the numbers of infants born preterm in the world. Approximately 20 million infants born every year that are either preterm or very low birth weight. And most of these infants are born in this area of the world, of course. You can also see, and the high-income countries are the yellow countries, and they are very much less. And also you can see that the sector of babies that die are proportionally much larger in these countries, of course, and also the ones that have severe impairments or mild, moderate impairments. So it's very important to have this global perspective. Also interesting to note is that the daily risk of death for a newborn infant in general, during the first 28 days, is actually occurring especially in the first 24 hours. So 50% of the neonatal death occurs within the first day, and then 2/3 within the first 3 days. So, and 70% of all neonatal deaths are attributed to preterm or very low birth weight infants. So we need to concentrate on those infants if you want to increase the survival of children in the world. And also remember now, note this, that most infants die before they are considered stable. Thus, before they are eligible for the current WHO recommendation for kangaroo care or skin-to-skin contact. So the previous studies have been done on stable infants. This has caught attention, of course, to the WHO, and I would like to highlight Rajiv Bal. He is the lead of research and guidelines in the Department of Maternal, Newborn, Child and Adolescent Health at the WHO. Very important person in the World Health Organization, I would say. And I borrow some slides from him now. Kangaroo mother care initiated in hospitals has been shown already that it improves survival by 40% and reduces the nosocomial infection by 55%. But even if we have this knowledge, we have not been able to decrease the mortality that much. So the WHO has identified knowledge gaps. Is KMC equally effective if initiated at home for stable infants, or immediately afterwards without waiting for the babies to become stable? Would that increase the efficiency? And they have just concluded a large community-initiated KMC trial in India, and I will talk shortly about that. The population that studied was babies that are, in many countries, are actually discharged as soon as they become stable, from 1,500 grams to 50 grams. That was the population studied. The intervention was KMC initiated within 24 hours, either in the hospital, not often, but after discharging, so that it was actually often community initiated, because the babies were discharged before they were trained in KMC in the hospital. And it was continued at home and supported at home. The control group was conventional existing care. And the outcome was mortality in the first 28 days, neonatal mortality, and mortality during the first half year. And it was studied in the poorer district of India. And the sample size was the impressive 8,000 babies, published in the Lancet last fall. And here you can see that the mortality, the 28-day mortality was significantly lower in the intervention group as compared to the control group. And also, if you followed it at 6 months of age, it was even more larger difference. It's very, very interesting to see. It seems to be continuing the difference that is increasing between the two groups. They could demonstrate more breastfeeding here in this group, and also better growth. So that's probably one of the reasons, and lower infections. So very important with community-initiated KMC for low birth weight infants. But what the other question was, immediate KMC. This was a study that Nils Bergman and Barack Morgan and I have been planning for many, many years, and it took us about 8-9 years before we could convince Melinda Gates Foundation to support us. And then we're very happy that WHO is now taking over the study, and they are actually the sponsor, the organizer, coordinator of the study. We randomize is a RCT in referral hospitals, not in the other study, small birthplaces. This is academic centers, referral hospitals in Ghana, India, Malawi, Nigeria, and Tanzania. We chose that because it's an efficacy study. We wanted to test if it could be effective on under the best circumstances. The sample size moderately 4,200 mother-baby dyads, and the birth weight here we addressed the smaller proportion, 1,000 to 1,800 grams. We couldn't have larger babies because they were discharged too early. The intervention was KMC, or skin-to-skin contact, initiated as soon as possible after birth and continues beyond the mother, or by the mother or a surrogate. I'll come back to that later. The control group got their KMC according to the current WHO guideline. After they become clinical stable, they got the KMC. Outcomes were mortality, clinical sepsis, hypothermia, hyperglycemia, and also 2 years out developmental outcome we will cover. And shortly, it's small infants, mostly preterm, considerable number of twins, considerable number of C-section babies, some were asphyxiated, at least moderately, hypothermia babies, and we have RDS in 30%. And here's preliminary data that the skin-to-skin contact during the NICU stay was in average around 18 hours per day, mostly by the mother, but also by surrogates. In the study, we also provided for both groups, both the control group and the intervention group, CPAP systems. They were based on electric oxygen concentrators, no gases in pipes, electrical concentrators. And we used the original bubble prongs, easy to clean, good, easy to maintain. And we also provided saturation monitors. For the intervention group, we trained, and for both groups, we trained for minimum package of care so that we raised the standard of care in all these hospitals. But also we taught about the skin-to-skin contact, in safe skin-to-skin contact, highlighting, underscoring secured airways, and also breastfeeding supports for both groups. But the initiation of skin-to-skin was different. Also, extremely important, I don't have time to cover this, but minimum care package for mothers were also designed. And look into this later. What should the obstetricians do for vaginal deliveries, C-sections? What the staff nurses should do the first 4 hours, and after the 4 hours, how often should they check and what should they check on the mothers? These were implied to both groups, of course. Zero separation then. Some pictures this is from Tanzania, twins, 10 minutes old, around 1,300 grams, and they are suckling, aren't they? A little bit later, another baby from Tanzania, mother still on the post-op department, and this is the aunt of the baby, and very sweaty, and also the mosquito nets, of course. And this is Jill Bergman, which was our KI team, KMC and breastfeeding educator. Conventional care could look like something like this, but actually, for the study purposes, we actually provided single beds for the control babies. So this would be control babies. This is from India, and these are actually not control babies, because in these countries, 3 babies or 2 babies or 3 babies in one incubator is not uncommon at all. It's mostly the most common thing. The control infants, when they were stable enough for intermittent care, they got that even before they were discharged to their KMC wards. And just an idea how it would look like for the families. This is the family quarters in Malawi, which is outside the hospital building, but on the grounds. This is the kitchen with open fire cooking. And this is where they are eating, laundry. And these are the family supporters that take care of that. That's our sisters or mothers-in-law or mothers of the women that gave birth. Also, a fantastic picture from India. I took it in the middle of the night in December, and I saw, who are these people? These are grandmothers or aunts, supporters, family supporters that don't have a bed, but they don't leave the hospital. They just lie down on the floor outside the NICU to support the postnatal ward, to support their young female relatives. So, and this was 12 degrees Celsius. So I'm quite impressed by the commitment. But for the study purposes, we needed to provide opportunities for continuous KMC, of course. And this was the first unit open in India, Mother Neonatal ICU. It is Safarja in New Delhi, India. And it would look like something like this. This unit is a 12-bed unit. And you have declining chairs by quite well equipped, actually, as you can see by these beds. And one mother in each bed. That's also not so common in every country, but we provided that, one mother per bed, and also space for the surrogate. A nursing station in the middle. This is a newly delivered mother, young mother, and her mother, baby on CPAP. And this is the family kitchen, simple but efficient. And it serves 12 mothers and 12 surrogates, family members, 24 people. And they have bathrooms there as well. So here, these surrogates or mother support, family supporters, they lie on the floor as well, without beds, and they're very happy because they can stay with their with their mothers. So this is how it will look like. And of course, we need couplet care, medical rounds from the infant by the neonatal team, and also medical rounds of the mother by the obstetric team. Some pictures from Nigeria, intervention babies. This is from Ghana, the control area, quite a new unit actually. And this is the intervention area, the IKMC couplet care area. But you can see it's very, very crowded. This is from Malawi, young mother that gave birth to twins, and she got a lot of support. It's very important, common in these countries. And this is from Tanzania, also to rebuild the unit so that more space. And and these are examples of provision of respiratory support in KMC position in these countries. Of course, from the very beginning, mothers couldn't be skin to skin with CPAP because they are they need to be observed. So then the surrogates stepped in, and in Sweden it would be the father, but here in these countries there are female relatives that do that. But then when they are stable, they leave the NICU or the mother NICU and are discharged to the KMC wards in these units. So this is again, colleagues and Jill Bergman supporting the families. We have, this is the planning group, this is Nils Bergman, and this is Rajiv Bal, very, very important and very enthusiastic, as you can see, testing how it would feel to have a baby, not skin to skin, but at least on these binders. And Professor Harish Chilani from New Delhi as well, and the KIT neonatologists. So what's happening with this study? Well, we, of course, in this such a large study, there is always an external monitoring team, and they are looking at what's happening with the two groups. And we plan to complete the study this summer. However, already in January, this Data Safety and Monitoring Board stopped the study because their statisticians discovered that we had actually significantly lower mortality in the intervention group, even if we had not come up to the expected numbers of the study. We don't know the details yet because we haven't had time to meet, and we cannot meet now. We were supposed to meet in a few weeks in Geneva, but of course we need to do it on Zoom now because we need to do the write-up and analysis. But very, very important result. We lowered the mortality with at least 20%. That was the cutoff. We lowered the mortality with at least 20% by this immediate intervention and breastfeeding support. And also, if talking about system change, even before these results, the Indian Ministry of Health issued already 2 years ago a recommendation how the Indian level 3 units, SNCUs, should rebuild or should remodel themselves. And of course, you can understand that it's approximately 1 million infants cared in the NICUs each year in India. And they said that the NICUs should provide developmentally supportive care. It's fantastic. And they also said, as Silke pointed out, that they should provide bed and diet and treatment for the mothers in or close to the level 3 unit, in the same building at least, or very close to. So they actually propagate for couplet care all over India. They have around 1,000 NICUs, so it will take some time. But WHO is working on this zero separation concept. And we had a meeting 2 years ago, or 1 year ago in New Delhi, in Southeast Asia region, approximately 2 billion inhabitants. And the policy taken was zero separation policy was decided to propagate on. So, well, thank you very much. That was all I had to say today. Stina, come in and guide us.
Yes, thank you, Björn. That was fantastic, as always. Now we are waiting for, I think that we have Pierre with us. So I think, Björn, that your next slide
Okay.
might be
Yeah.
Pierre. Or?
Yes, this is Pierre, of course, the bio. See if I can also see if I can. Pierre, he is also the co-founder of the Green Group in France. And I heard that you are extremely busy with the COVID. I don't know about if you can tell us something about the infants, but we're extremely happy that you could come and make your presentation. Please. Salut,
okay.
Ça va?
Hello to everybody. And it's a pleasure to join you. Thank you for inviting. Yeah, so it's a pleasure to join you. Of course, we are all facing a very difficult situation, and so I wasn't really concentrated on that meeting the last days. But I'm very happy to join you, to be able to talk with you. So first, I would like to speak. I was invited to speak about NICU design and sensory supportive environment. And of course, I am very thankful to EFCNI to have organized all these European standards, which are very important for us, and to disseminate infant and family centered developmental care, and also for the good work and the good collaboration. So I will speak a bit about NICU design. Although I was not directly involved in that topic, but we had strong exchange in a relation with Atle Meun and Bubu Alberg, because it's very close to infant and family centered care. And of course, they are the chair of that topic group, and they work to reflect on NICU design in order to support, to meet infant sensory needs and to support parent-infant closeness, mainly through skin-to-skin care or contact. But NICU design, and also to give an answer to our parental needs, and also to the caregiver's needs, in order to optimize care. And the main goal is at the end to improve infant and family medical outcome. And of course, for that, to reach that goal, NICU design should include a group, a collaboration between NICU planners and hospital administrators, but also direct collaboration with NICU staff and parents representatives. This is very important to co-build the project. And so the group has focused on 3 different subtopics. Core principle of NICU design to promote EFCDC and facilitation of skin-to-skin contact, and general layout of the unit. So it's very difficult to go through all of that, and you can of course access to all the standards directly on this site of EFCNI. But I will just go through some points and discuss maybe some application and how to do it in a practical way, and which ways you have to take to improve NICU design. So I will just go back to each statement of a standard. So the core principles of NICU design is that the NICU should be designed to support safety and healing through unrestricted parental presence, and to use of supportive sensory material and optimal working facilities. And what is very stressed in that is that it should be promoted through close collaboration between families and staff of caring for the ill infants. And there are many benefits for that, because the first step is to be convinced with the scientific evidence. And one is from NICU design is has been shown is that NICU design can facilitate the implementation of infant and family-centered developmental care. It can improve parental presence, and it can also reduce the rate of late onset neonatal sepsis. And just to go back to some of the studies that are supporting that, it has been shown that in case of family room, single family room, the parental presence is much higher as compared to a family hotel, or when the parents are at home or in the maternity ward, because they can stay the whole day long, 24 and 7 to 7. So this is important also. The other thing is that this has been published in the Lancet last year, and it was a systematic review and meta-analysis about single family room versus open bay units. And so it has been published after the issue of the recommendation of the standards, but this review nicely shown that in single family room, you've got a significant reduction of late onset sepsis, and also with a combined objective also to reduce the use of antibiotics. So a strong impact on bacterial sepsis. The other thing is to support, facilitate skin-to-skin and parental involvement through the physical environment. And with this nice picture taken in my unit of 3 triplets born at 25 weeks, you can easily understand that a bed in a room make a difference to offer the opportunity of skin-to-skin care. So for that topics, of course, it's again Atle Meun and Bobo Alberg and Bang Bang Otemo and Uwe Ewald and some other colleagues, and Fabrizio Ferrari and Jacques Sizin and Bob White work on that. And as Bjorn talked about skin-to-skin very nicely before, I won't insist on that. But and go directly to a general layout of a unit. And many aspects has been taken into account: light, acoustic, material, patient safety, and space for the infant. As I will talk later again about light and acoustic, and I will just focus on the general layout and the space for the infants, because this is quite important to communicate with the stakeholders of the hospital. And there are many benefits that you can find on the EFCNI site from many studies. I think what is the most important in the standards is the provision of enough space. And it has been recommended, it is recommended that a patient treatment area has a minimal space of 18 square meter, and in case of no single family room, there should be also a sleeping area for the parents with a minimal space of 10 square meter. In case of single occupancy area, the minimal space should be of 24 square meter. So this is very important to have this in mind when you're building a new unit, or when you are thinking of reorganizing the design of the unit, because it's something that should be argued with stakeholders of the hospital. What is really important also is to have monitoring areas for clinical settings that are close to the infant's room, so that the safety of the care is still maintained. And what is stressed also in the standards is that you need really, if you want the parents to stay, to meet the parental needs, to have a parental area where they can eat and socialize together. And what is important also is to have a staff room that is out of the sight of the parents, where the caregivers can be together. And also, it has been also already said before by Silke that you need to have also a palliative care room or bereavement room when an infant is passing away, for the family to be together with him. How to reach that? Of course, at the parents' level, and this is very important in the standard from the EFCNI, that there is a the recommendations have declined through parents and healthcare and services and healthcare providers and at the hospital level. Of course, parents should be informed about the importance of their active role and what are the hygiene rules if they are staying 24/7 in the unit. The staff should be trained for, of course, in EFCDC and emotional support, and there should be national guidelines on NICU design elaborated in collaboration with parents, representatives, and healthcare providers. So if you're on the way, the first maybe point should be to support a more comfortable welcome to the parents with a comfortable chair close to the infant, so that parents can stay at least a couple of hours close to their infants and practice skin-to-skin contact. One other thing is to, if you are in a multiple open bay NICU or multiple rooms, you should use folding screen to provide privacy. You should also provide a dedicated room or an adequate space for breast pumping. And of course, you should think about the next step and and identify areas that are at need of change. So how will we improve the next year, in the coming months? What is our design project? And if you are on the way, the next step should be where to go. Everywhere we should have single family rooms with full parental presence and support for involvement. So these pictures were taken in Sweden, so lots of people will know this place, and because it's still the gold standard, single family room are highly supported by scientific evidence and should be implemented everywhere. So how to change, how to pass, how to go from open bay NICU to a single family room where the interaction with the infants are mainly provided by the mother and not by the caregivers. How to go from one infant mainly being in an incubator to infants cared in skin-to-skin care. So what is known is that you have challenges, and one challenge is that you to reach that point or to use adequately single family room, you need a change in culture and mindset, and for that you need a strong leadership, and you need knowledge about what is the scientific evidence and about the implementation of infant and family centered developmental care. The other challenge is that it's a long process. You won't reach a single family room the next year, so you should work on that, and so you need for that a will to work, very important, and a process implying shared decision with stakeholders and the team and the parents. And it's very important also to visit other units that have gone through that process and to discuss with them the weakness and the strength of their design, what they would change and how they reach that. And you should be aware also, this is in every study, that there could be sometimes a conflict between families and the staff preferences. And when you are moving from an open bay NICU to a single family room, the staff could feel less secure at the beginning. So the project should be co-constructed with NICU staff and the parents, and you should support the staff also. And what is well known in the developmental care programs, that you need to work on the system change. And this is a long process, a continuous process. One other thing is that single family room is not a goal by itself. I took again this sentence because I think it's very important. It's not the goal, it's a tool to fulfill the rights and to reach better infant and family-centered care, and to support at the end the neurobehavioral outcome of the infant and the family. And what you have to keep in mind is that a good NICU design is the way to support and to provide a protective physical environment for the most vulnerable infants hospitalized in our settings. And I come back now to an editorial that was published in Journal of Pediatrics in 2017, where 2 studies were published about the impact of single family room as compared to open bay NICU on the auditory environment of preterm infants. And with data showing that in single family room, the babies are more exposed to voices, to human voices, that can at the end support their language development. And the sentence and the take-home message from Alan Job was, my take is that the essential inputs are the sensory contents of the environment and not the physical design of the NICU. The physical design can help to support infant and family-centered care, but it's not the goal. It can facilitate optimal care, but the biology behind the improved outcomes is the critical factor. So it's the interactions and the sensory content of the NICU that is the most important. So that makes a good transition for me with the second topic about the topic expert group of infant and family-centered developmental care. I worked with on the topic of supportive sensory environment with Bjorn, of course, and Natasha Bertoncelli and Manuela Filippa, Petra Uppi and Inga Warren. And the main message is that the sensory environment should be adjusted to the infant's sensory expectancies and perceptual competencies. So that means that you need to go back to the science and the neuroscience, and we know that the sensory systems of the babies are anatomically present by the end of the first trimester of gestation and the beginning of the second trimester, and that the first physiological and behavioral responses of the infants can be recorded by the beginning, the end of the first trimester, the beginning of the end of the second trimester of gestation in all sensory modalities. And that we have proofs and indications about cortical integration of sensory inputs at the brain level, starting at the end of the second trimester or the beginning of the third trimester of gestation. So that means that preterm infants are well equipped to react to their sensory environment. And the problem is that they are facing a sensory environment that is quite different and atypical as compared to the one they should have continued to encounter in the womb of the mother. And the sensory systems are mainly exposed to sensory inputs coming from the mother, or that are lessened through the abdominal and the uterine wall, like levels that are very low. And what is very important is also the contingency between every sensory inputs. So it's a multi-sensory perception of the same object in utero. And whereas it's quite different, many studies have shown that noise is very high with highly pitched sound, and hospital odors are strong and can be irritating through the trigeminal system. Light can be very bright, and preterm infants are exposed to very high stressful and maybe painful procedures that are repeated. And so finally the level of exposure to the sensory inputs coming from the mother can be low, and maybe the most important strategy and is to support skin-to-skin care, because it can restore the sensory continuity between the mother and the infant through different sensory exchanges. So this is in a neuroscientific and developmental psychology way very important. So how to do that? Of course, you have to provide access and to support the exposure of the baby to hedonically positive and biologically meaningful stimuli. It's what I already said. Maybe the three domains where it is very important are skin to access to breast milk parents can do, and that we cannot really do as healthcare professionals. And this is very important because it's a dedicated role for parents. That is very important. Of course, you have to minimize exposure to environmental stressors, and maybe there is room also for sensory intervention that can work if they are attuned to the neurobehavioral state of the infant. And through all these three actions, we can act and provide benefits. So just one study to go back to the evidence to show that repeated exposure to stressful stimuli can alter the brain growth and development of every preterm infant. This study has nicely shown that babies that were included had stress score that recorded the number of stressful stimulation, and they had an MRI at the end of their hospital stay, and also a neurologic examination. And what was found is that the more the baby were exposed to stressful stimuli in the first month of life, the more the cortical thickness was decreased in frontal and parietal areas. So there is a direct impact of stress on brain growth. This was also associated with function, because the babies that were full term here had full interhemispheric connectivity, whereas the less stressed preterm infants, when they reach term, had the same thing, but the more stressed infant didn't have the same development of brain connectivity. So both function and maturation can be affected by excess of stress. So the benefits when you use the three principles, core principles I mentioned before, is that you can, of course, support sleep, support the stability of infants, support social interaction that are so important for the development of infants, and also enhance maternal attachment and interaction between the mother and infant. And at the end, there are some evidence about improvement of neurodevelopment, and strong evidence about the improvement of language and cognitive outcome, and also of parental mental health. So just one study to go back to the auditory environment, most of the people are aware of that, and we already discussed that last year at the ultra early intervention meeting. This study from the group of Betty Vore look at the amount of exposure to adult language in the NICU and to the production of vocalization by preterm infants. So there were two recorded sessions at 32 or 36 weeks using a very smart device that is the linear language analyzer that is able to count the number of words, and also to identify reciprocal conversation, that means vocalization and adult words that were occurring in the following 5 seconds. And what this study has shown is that there is an increase of the number of vocalization per hour from 32 to 36 weeks, but also that conversation and reciprocal vocalization were much dependent of a number of adult words, and they were much more important during parental presence, showing that, ending with a conclusion that the more maybe you talk to your baby, the more he will vocalize at later. And so this is a very important message. And this group it's very important. They are also followed the infants and shown that at 18 months of age, corrected age, the babies that were vocalizing the more at the neonatal period had the better cognitive and language outcome at 18 months. So there is a link between the auditory environment and the auditory exposure to human voices during the neonatal period and a better language outcome after. So what about the standard? Of course, the parents should be informed and should be guided to know how to better respond to the infant's behavior and sensory needs, and they should understand why the involvement in care is so important, and why skin-to-skin care and contact is maybe the most important thing they can do. And healthcare professionals should support that and should be trained and supported also, and they should pay attention also to preserve the speech intimacy between the parents and the infant, to support a very meaningful interaction between the parents and the infant. There should be guidelines about noise and light, and we all know the guidelines from the group of a standard NICU design from Bob White, and also the work from Kathleen Philbin, and that have been updated. And so we know that we shouldn't exceed 40 dBA in the auditory mode. We know also that it's not only a question of protection, but we should also avoid auditory deprivation, and we should, to provide a nurturing environment, we should offer the infant access to language stimuli and direct talking, especially from parents. So how to do it at best? So at the hospital level, you should, of course, monitor the noise. You should reduce the pitch and the level of the alarms. You should work on the reverberation of the incubator, and maybe skin-to-skin contact is maybe the best way to avoid reverberation of the incubator. To pay attention when you use material device, and to use noise criteria to choose your material device. And maybe the best way is to provide skin-to-skin care as long as possible with parents, and using and talking to the infants using a mother's language full of emotion. About the olfactory environment, you have to think about which product you really need to use, and of course, hydroalcoholic solutions are very, very important at the moment, and should be used near the infant, but you should really use it in the right way, and to use it to work, to respect the drying time before accessing the infant. There is no conflict with hygiene, safety, and sensory environment. It's just a question of the respect of the guidelines. And what about light? Bob White and his group has worked a lot on that. And of course, we should avoid excessive light levels, and we should have dim a switch to increase very slowly light levels, and to protect the eyes during situation of the infant during situation of high exposure. And it should be adjusted to the infant's behavior. and mainly before 31 to 32 weeks. Also, before the infants reach term-corrected age, we should ensure adequate day-night changes and before the infant is going home. And this is very important. So how to work or to get started? Maybe the easiest thing at the beginning is to work on excessive light exposure and to protect infants from excessive light. Excessive noise is a much more tough work, but it's a long process, but it's something really we should work on. And when you start to think about the sensory environment, you should focus on that also with material device, but also the behaviors of the caregivers. And maybe to promote skin to skin as early as possible, and maybe to start with less vulnerable infants to get confident with that practice and to increase it and to provide it more longer and at an earlier time also. This is the getting started point. And what about the further development? Of course, we should imagine and support as much as we can the interaction, sensory interaction between the parents and the infant, and with stimulation that are attuned to the infant. So that means that the parents are well informed and supported to recognize the behavioral cues of the infant and signs. And maybe there are opportunities for new ways to offer sensory stimulation combined with skin-to-skin contact, as it has been done for the strategy of early vocal contact, nicely supported by Manuela Filippa and colleagues. And there is place for maybe more sensory intervention through parents in the NICU and attuned to the infant. And maybe the best way is to have parents and infants cared in the same room, and couplet care, of course, is the best situation to meet the best sensory and to provide the best sensory environment to the infants. So I wanted to thank a lot Björn for this very important and very nice collaboration on that standards and all the group. It's not only the group of supportive sensory environment, but it was a very, very fruitful interactions. And thank you very much to all the people and also to EFCNI to have supported this all this process that is so important. And also, so thank you to EFCNI. I will also, because you cannot do anything on NICU design and sensory supportive environment if you are alone. So it's really a teamwork and teamwork with parents and healthcare givers. And so just a picture from my team in Strasbourg, where a couple of months ago we were celebrating the 10th anniversary of birthday of NICAP implementation, and we were all parents and caregivers together. And this is maybe the most important thing to reach the goal in NICU design and sensory supportive environment. Okay, thank you for your attention.
Any answers on the poll, Björn?
Yes. The question, in your unit, do you have free visiting hours? 30% said yes for parents. 20% said yes for parents and siblings. So that makes 50%, doesn't it? And yes for parents, siblings, and other visitors, 33%. Yes, with exception for rounds and staff handover. That's only 8% that has these exceptions, actually, seems. And only 10% say they don't have free visiting hours. So that's quite impressive, I think. It was, response rate was 54% of the participants. Because 78 of 115 registers have answered, so I see those 7. I end it now. Another poll. I'll try to do that. Let's see if I can. The question was, can parents sleep in the neonatal unit where their infant is cared for? 30% says yes, all mothers and partners. 19% all mothers, and 9% some of the mothers, and 13% only a few of the mothers, and 30% none. So the situation is good for approximately 50% of the units that are represented today, but approximately 50% needs some improvement, of course.
So welcome back after coffee break, and we now will listen to Mandy Daly on family supportive services and parental involvement.
An old friend of mine, and it's very nice to see you. Of course, you are a mother of a 25 plus 6 week girl, and you also been founded the collaborative multi-stakeholder platform in Ireland, the Irish Neonatal Health Alliance. I think is fantastic. Advocacy for education and training and research, and also you are from the beginning of EFCNI very much involved. You are a member of the advisory board and chair committee of the GLANCE, and you have published several papers together with others in Lancet, British Medical Journal, and so forth. We're very, very happy to have you here, Mandy. Also a member of the IFCDC board, NITCA Federation International Board. Welcome, Mandy. Go ahead.
Well, the statement of the standards I'll be talking about today for the parental involvement, that parents or members of the caregiving team and with individualized support assume the primary role in the provision of care of their infant and are active partners in decision-making processes. The statement of the standard for family support services states that the family receives care in an environment where their socioeconomic, mental health, and spiritual needs are supported. But how does this translate into practice? What I'd like to do is to walk you through my journey about prematurity and highlight those missed opportunities that would have changed our perception of the world of prematurity, but more importantly, would have actually had an impact on our outcomes as a family. In 2006, after 10 years, I finally managed to get myself pregnant. And for the first 13 weeks, it was a really, really happy event. Unfortunately, at that point, I turned into a high-risk pregnancy. I had a massive bleed. And when I presented at our local neonatal unit, I was very surprised at the reaction to me. It was just assumed that I was having a miscarriage. And for me, that was the most devastating thing that could have happened at that point in my life. I wasn't viewed as somebody who was going to be getting any additional care. As a mother to be, it wasn't all about me. I was admitted, I was told this was most likely a miscarriage and that they would keep me in hospital until the severe bleeding had come to an end. I had to demand to get an ultrasound carried out. The bed that I was sitting in the emergency unit was located next to an ultrasound machine, and I'm a radiographer, and I had pleaded with them to just let me see the baby, just to see was the baby alive, and it didn't happen. They refused and refused until ultimately I said I will do it myself, which obviously they didn't allow, but they did actually agree to do an ultrasound, and the baby was okay. So for me, that was a huge reassurance. That one moment in time shattered all of my expectations. I assumed my baby was going to be dead, but just by reassuring me through that ultrasound, it gave me that little bit of mental strength to continue on. I was hospitalized for 10 days, but again, in a ward with other parents with new babies, and that was incredibly difficult. My obstetrician felt that at all points this was going to terminate in a miscarriage. So the relationship between us was quite strained. For me, I needed that reassurance. Even if it was going to end in a miscarriage, I just felt as a mom, my fears and my needs weren't being met. And unfortunately, for the rest of the pregnancy, that scenario continued. So at the end of my 10-day stay in hospital and I was discharged home, my obstetrician said he would see me at week 28 if the baby was still alive. Now, that was a total of 15 weeks after I'd been admitted. And even those 10 days, bleeding every single day, waiting for the baby to die, It was emotionally and physically draining. It was very lonely. It was isolating. I'd never met anybody who had had a pregnancy and had continued to bleed and had had a successful pregnancy. So I was very much alone and I felt quite unsupported. I took the decision myself at that point to put myself on bed rest, which I did for the next 12 weeks. It was really difficult because I didn't feel anybody was supporting my actions. I did manage to change obstetricians and to find a really kind obstetrician who would sneak me in every Tuesday to give me that weekly ultrasound to reassure me that the baby was still growing, the baby was still healthy. They didn't have any reason for my bleeding. They couldn't stop it, but they felt as long as the baby was continuing to grow, they were going to let me come into the hospital every week. It was very, very difficult because every single time I got up off my couch, I felt this could be the very end of my pregnancy and I was going to be alone. And again, there was nobody out there. There was nobody to reach out and talk to. There was nobody to reassure me. That one trip to the hospital every week was my only lifeline. It was the only thread that kept me mentally going. It would keep me going for 24, 48 hours. And then the anxiety would overcome me again, the fear of losing the baby. So any joy that would have been expected to be associated with pregnancy was completely annihilated. At no point was the prospect of a preterm delivery even suggested to me, which I found unusual afterwards, I suppose, in hindsight. I often blame pregnancy hormones for my brain not thinking properly, but it possibly was that they didn't think I'd get to viability and it was just never discussed. So I wasn't really prepared for what lay ahead. And what did lay ahead was at 25 plus 6, I had a placenta abruption and I had to travel 160 miles in our car to get to a tertiary unit. Unfortunately, I was located in an area that wouldn't have been able to care for a baby so small. I didn't have the birth I wanted, neither did my daughter. It was an emergency cesarean section. We both faced the prospect of possibly dying. I felt a bit removed from the entire situation simply because there was a lot of people around. There was a lot of frantic people working around me to keep me alive, to keep my baby alive. And I was very, very scared. When she was delivered lifeless and had to be resuscitated. So I didn't have the opportunity to see her or touch her. And I think what sticks with us parents is somebody else has had that first cuddle. Somebody else has touched my baby. My baby has smelled somebody else at delivery, not me. And there are moments you can never get back. They always stay with me. She was obviously whisked to NICU and it would be another day before I got to see her. I remember lying on that bed after delivering her and feeling like a piece of meat. You know, the most important thing seemed to be treating my daughter. I was secondary. And at the time it didn't bother me, but in hindsight, I felt my mental energy sapping out of my body at that point. I had managed to get myself to delivery just about mentally, and I had no idea what lay ahead. I didn't know if she was dead or alive. And it was like, it just got worse and worse. I felt like I was spiraling into a much deeper pit. It would have really helped, I guess, had I had somebody supporting me throughout the pregnancy, supporting me and preparing me for what lay ahead, supporting me to understand what the delivery room would look like, what the NICU would look like. There was nothing there. There was never any discussion about the birth plan. It just simply was, I guess, perhaps I didn't think it was going to happen, but when it did, we were all pretty much unprepared for it. That photograph of me there in the corner is one of the few occasions I did get a chance to meet my daughter when she was very small. As you can see, she's on CPAP, so that would have been at least more than 4 weeks after she was born. I look absolutely exhausted. Any photographs of me at that time are really distressing to look at. So what was life like in the NICU? I remember being in a ward with mums, all of who had their babies who had just delivered, and I was stuck in a corner with curtains drawn around my bed, shattered physically, shattered emotionally, not knowing how I was going to get through this. And the very first thing that was delivered to my bed was a breast pump. It was rolled in, there was very little discussion, and I was told, we need milk. And there again, I felt almost detached from the situation, that I was a conduit for some process, but I wasn't part of it. It was really hard to hear doctors come to my bedside, pull back the curtains and say, where's your baby? So little things like that, being placed in a ward with other parents, healthcare professionals not reading my notes prior to coming to my bed. They all stick with us parents. We're quite fragile emotionally at that point, and it doesn't take a lot to keep chipping away at that mental health. For me, I had absolutely no idea what lay ahead. Thankfully, there was one midwife who accompanied me to the NICU to meet my daughter, but I didn't know what she looked like. We entered a room with 10 babies, and I was happy to be given any of those babies at that point. I just, not that I didn't care, but I felt I needed to connect with the baby that I had delivered 24 hours earlier, and it hadn't happened. I obviously wasn't allowed to touch my daughter. She was on a ventilator, and it was heartbreaking to see her, because the first thing that goes through your mind as a mom is, this is my fault. I've caused you this pain, and this is what you've known from the very first time you were born. So up to that point, there was no love, there was no warmth, it was just pain, and that still stays with you as a parent. It doesn't leave. You can suppress it over the years, but it always bubbles back to the surface. Life in the NICU was hard. We spent 4 months traveling to and from the NICU. I would be there every single morning at 8 o'clock. Even accessing the NICU was distressing. It was a long corridor. I had to buzz a doorbell to be permitted access to visit my child. And at no point did I ever feel part of that caregiving team. I was a visitor. I was excluded during rounds. I was excluded during staff handover. If there was a baby being treated for whatever reason, parents were asked to leave. It was a difficult situation. I know it was 13 years ago, and I know it has slightly improved, but the access is key, I think, for parents. If you get to the door of a NICU and you have to buzz in and be permitted, it changes the equity of where you stand in reference to the other people who work behind that door. And if we talk about equitable partners and primary caregivers, we need to treat everybody the same. And I'm constantly asking NICUs now, please give your parents the same access as you give your staff. And it's really difficult for them to make that change. There's that security issue that they find it very difficult to get around, but it means a lot to us. It means we're being welcomed into an area as parents. I still want to be my daughter's parent. It's very difficult because I don't know where to start when I'm a new mom in the NICU. I'm also battling the fear that she's going to die. I don't want to bond with my baby, because if she dies, I'm going to be so heartbroken. I'm guilty because of where she is. I'm helpless because I don't have any information. I don't know how to parent. I need the help of people to support me in that situation, to guide me through that altered parenting role, to help me find me as my mum. I know I'm a mum internally, but I can't express it externally because it's just not within me to work within a NICU environment. For 3 months, I sat at that bedside every single day for 14 hours for the first 4 weeks, desperate, absolutely desperate to hold her because she was on a ventilator. Our unit didn't allow ventilated babies to have skin-to-skin care. So all I could do was express milk in what can only be described as a closet. It was the tiniest little room that connected our SCABU, which is our special care baby unit, to our NICU. And it was a walkway for all the healthcare professionals. It wasn't very conducive to expressing milk. It was really small and cramped, and there were 2 pumps available to well over 30 parents. It was really difficult. It was the only thing I could do, so I made myself do it. What I do look back on is the lack of knowledge I had with respect to nutrition. At no point was the importance of express breast milk discussed with me. It was forced upon me. I would go so far as to say, in hindsight, I am so guilty that I didn't make a better effort. I did reach out to see if there was lactation support, but it wasn't available in my hospital. It was really hard to express breast milk at 3 o'clock in the morning, having had a bad day in the NICU. What would have helped would have been camera access. I would have loved to be able to look at my baby at 3 in the morning. That might have helped me express a bit more milk. It would have put my mind at ease because every time I left that NICU, I was just waiting to get home so I could ring the NICU to see what had happened in that 2-hour journey between the last time I saw her and then. So I think we really do need to embrace technology to help parents. It helps their physical health. It also helps us emotionally recover from what's going on. As it is, we feel disconnected from our role as parents, and it's difficult for us to reconnect with that because none of us has read the book before we've had that baby about delivering preterms. It's a very different scenario. And I spent a lot of my time confused. I observed my daughter for 14 hours a day, as I said, for the first 4 weeks, not being able to hold her. And she seemed to be very distressed. I kept a diary every day. I recorded all my observations, only because it was all I could do. But internally, something was making me do that. And in hindsight, having spent the last 13 years learning about infant cues and learning how to read infant cues, I know that my baby was talking constantly to me, but as a parent, I didn't have that ability to interpret her behaviors. And there lies another element of guilt. Had I been able to recognize her distresses, which were a lot, perhaps I could have comforted her in some way. You know, there's no reason why I couldn't have held her skin to skin care. She would have benefited, I would have benefited, my milk would have been better, she'd have gained weight better, she wouldn't have such severe BPD. There are a whole gamut of reasons why I should have been able to be her mom at the time. Again, I realise it's 13 years ago and times have changed in some respects, but there are plenty of units still who don't actually embrace kangaroo mother care as a form of intervention, who don't look at EBM as a nutrition or as a medical emergency. So there are lots and lots of things that can still be done. It was overwhelming. Having to recover from a cesarean section or put the recovery on hold and do 14-hour days, having a 2-hour trip to the hospital, a 2-hour trip home. But I felt I needed to be there, even though I was a passive bystander for much of it. I needed to be there in case something happened and I missed out on it. It was really hard. And I guess I would have been one of those people in the NICU who would have been constantly asking for things to change. We had a parent room, again, no bigger than a closet where we could have a cup of tea, but we weren't allowed to bring food into it. It's already been mentioned today. If you want me to breastfeed my baby, my premature baby who needs breast milk, you need to have conditions that are conducive to producing the absolute optimum quality breast milk. And that means facilities for families to eat and to drink, to take time out. It's a very intensive environment. A lot of you work in this, so you know what I'm speaking about. But for us too, it's intensive. We need time away from it to recoup, to think about what's going on, process what's happening, and I guess to regroup that energy, that little bit of energy that we have. In our NICU, there were only a certain number of chairs. Not every incubator had a chair assigned to it. So you would do your best to get into the NICU in the mornings early because you wanted to get a chair on the off chance somebody might allow you to kangaroo mother care. That's just wrong. You know, kangaroo mother care is a medical intervention and it ought to be seen as that. I would have loved to have become involved in the cares of my daughter much earlier. It would have helped my recovery. It would have helped me understand my role better as a parent. I appreciate some parents sometimes are so scared that they don't want to touch their baby, but that's where the team and the NICU need to come together and offer that support to families to understand what's happening to their baby and allow them to understand that bonding and attachment can still happen and to facilitate that process. Nurturing our kids not only nurtures them, it nurtures us. It's a fulfilling experience, and if it doesn't happen in the NICU, we are looking at families who are damaged upon discharge, but we are giving them this huge burden of having to care for a most likely a medically vulnerable child, and when they themselves can't take care of themselves. Again, in our NICU, we were constantly asked to leave for rounds and left for staff changeover. We weren't allowed access to our children's medical records. I do have a medical background, and on the few occasions that I snuck a peek, the medical records were snatched from my hands, and the excuse that was used was, we don't want you to misinterpret the content. You know, if you want me to be the best mum that I can be, I need to be part of that team. I need to be part of the decision-making process, and I need to feel that I'm equal. At no point in my journey did I feel equal. I often felt I was in the way, or because of my medical background, people kept their distance from me for fear I might ask a question about my child's condition. I find, looking back, there was a lot of inconsistencies. For me, it depended on what nurse was on duty, what you as a parent would or wouldn't be allowed to do on the day. And again, That's very distressing as a parent. I'm learning to become a parent in an altered environment. With one nurse is giving me different information from the next. There was no written information for us. There was no online access. I would have really benefited from a structured, I suppose, parent education program, if you want to call it that, that would follow me through my journey as a parent in the NICU, where I'm acquiring different competencies and I'm becoming more confident. Because at the point of discharge, that's it, the support ends and I'm taking over. And I do remember leaving the hospital after 4 months thinking, I'm surely they've made a huge mistake. They're letting me bring this baby home. It was Christmas Eve and I had no idea how to care for her. I was terrified I would kill her. And I remember getting to the hospital door and thinking, there's nobody following me here. They're actually really letting me home. And one part of me is resounding and joyous, but there's another part of me that's gripped with such awful fear and anxiety that if anything happens, it's all going to be my fault. And it would have been, I guess. All of this, I suppose, has led me on to look at, in hindsight, at our experience, where I was as a person, what I had felt as a mum. You know, there was nobody ever asked me how I felt. How was I doing? And every day, having gone through a high-risk pregnancy where my self-esteem was being chipped away every day by a set of circumstances that I had no control over, nobody at any point stood back and said, how are you doing? You know, what can I do to help you get through this? Thankfully, I was financially okay in that it wasn't going to be such of a burden for us, but there are so many families out there now we know who lose their homes, who sleep in cars because their baby has been transferred to a NICU that's far away from home, who suffer enormous financial loss as a result of having a preterm baby. It is really important that when we look at this baby in our NICU, that we just don't look at them independently. They are part of a family unit. They are part of them. There's a mum, there's probably a dad, there could be two mums, there could be two dads, there's siblings, their grandparents. The ripple effect of prematurity does not stop. It starts at the infant and it keeps spreading outwards. And it will be very helpful for everybody if a support structure were put in place in terms of having, for mum, a psychologist during pregnancy and after pregnancy, and most certainly after discharge, because a lot of our issues, we tend to internalize them while the baby's in the NICU, and it can take a long time for us to allow those issues rise to the surface, and for many it's really, really difficult to process them. Having a social worker that's designated to your NICU would be incredibly useful. Families often don't know what entitlements there may be out there for them, and to take that burden away from them would allow them to concentrate their energies on learning to bond with their child, learning to be a parent in that environment. I had never met anybody who'd had a preterm baby, who'd had a really high-risk pregnancy, who'd had a pregnancy similar to mine. I felt alone, and I felt I was the only one that this was happening to. Now I know I'm not, and I know we have so many preterm babies in the world, but it would have certainly helped me to speak with somebody who knew what I was going through and who wasn't just a healthcare professional, who was a parent who had endured the pain and the heartbreak that I had endured. And yes, unfortunately, some babies don't actually make it, but it would have been really helpful for me to connect with somebody. After discharge, it was a shock to me how little support there was. There are some photographs of me that I don't like sharing because it's me looking at my baby in her little chair at home, and the look on my face is one of horror because I've realized that I'm in the community now. I'm the full-time carer for this baby. It's my first time in 4 months being a full-time carer, and there's nobody looking over my shoulders. What if something goes wrong? I can honestly say I don't think I slept for 3 or 4 years after my daughter was born home. Now, neither did she. She had a whole host of medical problems which have led to that. But I guess for me, had I been a stronger parent, had I been better prepared, more competent, and I guess more confident in my ability to parent, it would have changed how I enjoyed motherhood, because I did not enjoy it. I say it time and time again, for the first 3 years, I did not feel like a mum. I felt like a carer with that responsibility of having to care for this child. There were no joyous moments. There were no times when we could sit and have fun. She had so many medical complications post-discharge, which is an entirely different conversation, that it just took away from the whole joy of parenting. And for me, It was one stumbling block after another, from the high-risk pregnancy, the emergency delivery, the time in the NICU. You know, the NICU is our home for 4 months. It doesn't feel like a home. It's meant to be for families. We are growing a little baby together, the entire team, mums, dads, healthcare professionals, but it doesn't feel like a home to us. We often feel like visitors, and I think it's really important that we step outside our roles and ask, if this were me, how would I like to be? You know, my hospital didn't have any family accommodation. It was a 2-hour trip both ways for me to get to the hospital every day. Having had a cesarean section, there was no quiet space for me to go and have that cry. I had to be really strong for those 4 months because I had no other choice. It would have been lovely to have access to the canteen. I had to fight for access to the staff canteen, and in our unit, we weren't allowed, up to the point that we were in the unit, parents were not allowed to use the same canteen as staff, until I had a row with one of them and explained, you want me to express milk? You want me to be here for my baby? You know, meet me halfway. Let me go and get my meals in the canteen. There were plenty of parents in our unit who had nowhere to wash clothes. They were staying in hotels, they were in bed and breakfasts. I remember taking lots and lots of patients' clothes home with me because I could. That's wrong. It's an additional stress for parents. And again, would you like that for yourself if you were in their situation? Needless to say, there was never a sibling in sight of our hospital. And these are children who are at home for 4, 5, 6 months, who apparently have a brother or sister, who have never met them. Can you imagine you being like that? You don't have the emotional or the mental capacity to understand that circumstance, to vocalize how you're feeling, and then perhaps the baby dies. What happens then? So I think, again, it's about not just focusing on the baby, it's focusing on the family and understanding that the family is a much, much greater unit than just the baby. What we do to the baby affects the family. The family are the ones we're trying to build and nurture so that they can then take that baby into the community and raise it to the best of their ability. It makes perfect sense. We all share the same goals. I don't want to be in the NICU. You don't want me to be there any longer than I have to be there. I want, as a parent, to be able to know my baby, to get to know my baby. I can do that if you teach me how to read my baby's cues. I know that my daughter was in immense pain during her time in the NICU. I have the notes in my daily journal that tell me that. At the time, I didn't realize that her behaviors were indicating the distress and pain she was in. But now in hindsight, I can read those notes and go, well, nobody was reading her cues at that point. As a parent, it makes you feel like a failure. And it's so basic. As a mother, even for me to record what I was observing, there was obviously something within me that understood that there was something happening to my baby, that there was a need to record this. Perhaps, maybe it's just coincidence. We know that by involving parents as early as possible in the cares as primary caregivers, that it reduces the length of hospital stay. We know that these babies do not come back in for readmission afterwards. We're sending these parents home prepared, they're competent, and they're confident. The science is there. We know they have improved behavior and long-term cognitive development. It absolutely enhances the bonding and attachment process. I sat for 4 weeks outside my baby's incubator, pleading to even touch her. There were days when I was so distressed, I would have just picked her up and left because I hadn't touched her. I was her mom, and I was watching these people every single day for 4 whole weeks do what I should be doing. They were touching her, they were changing her nappy, they were feeding her, they were taking bloods. She didn't know any love. And that's the biggest regret that I have, is that every human interaction she had brought pain. And you can't undo that. You know, every mom with a new baby wants to enjoy motherhood. What can we do to facilitate that process? There is so much we can do. We can make them feel like moms in the NICU. We can adapt the environment to ensure that these parents feel like parents, that they're confident, that it reduces their stress. My God, when you get a child home after 4 months in hospital, you don't know what the stress is like until you're home and you're by yourself. And it's 3 o'clock in the morning and something happens to your baby, and you are being faced with making that decision, whether to act or to hold back. It's really difficult. So if we can do something to ensure that parents feel competent or can actually take charge and responsibility of taking care of their child when they're home. We ought to do it. It's our right to do it, I think. Again, holding baby in skin-to-skin care, it improves breastfeeding rates. If my baby's breastfeeding better, she'll gain weight better, she'll get out of hospital sooner, she'll have less infections, she'll have less chance of BPD, neck. It's just, it's almost like a cycle here. There are so many benefits to having parents as the center point of the caregiving team. It seems incredible that we haven't done it to date, or we haven't embraced it in the same respect. What I'd like to do now is I would like to read out some statements that parents have made about their time in the NICU and something that they would like healthcare professionals to understand. It's written by a girl called Jodie DeLiesel. I need to be present. Please do not tell me to go home and rest while I can. If I say I need to be here, then I need to be here. My heart is sleeping in that incubator. My hands are empty, and my head can only feel clear if I'm by my baby's bedside. I'm grieving. This is not what I had planned and dreamed about. My hopes for healthy and natural delivery were crushed by this unknown NICU world. Please be patient and kind while I try to grasp what all this means, and while I mourn the loss of a normal pregnancy and delivery. This is supposed to be a happy time. I will get there, but I'm not ready yet. Please understand. I feel lost. The NICU is somewhere I never expected to be, and seeing my baby struggle is the hardest thing I've had to face as a parent. This roller coaster ride is tough. Please be there for me if I need you. You may not know what to say, and that's okay. Just knowing that I have your support if I need it can make all the difference to me on the hard days. I need to be part of my baby's team. I may not be a medical professional, and this may be the first NICU baby I've been around, but it's my baby, and I need to be included in the care and decision-making on a daily basis. Please respect this important aspect and see my baby not only as your patient, but as a child that is loved beyond measure. I will learn. I may not completely understand everything that's going on. If I don't, please teach me. I need to learn. Please take the time to help me so that I can be the very best advocate for my baby, not only while in your care in the NICU, but what I need to know to meet my baby's needs once we're discharged from the hospital. Let me be a parent. I know I may take more time to do the little things like changing a diaper or take a temperature. But if you encourage me to do these tasks for my baby, I will feel more connected and comfortable. These moments will be my memories, memories I will cherish for a lifetime. Please be consistent. I understand that the NICU has a vast array of staff, from nurses with different backgrounds and philosophies, doctors and therapists whom I only see from time to time. But if you can all get on the same page when it comes to the care of my baby, I won't feel so lost and confused with the expectations and the goals for me and my child. I need to trust you. I've handed over the most precious gift that I've been given to you. I know that you are only human too, but I need to know that you will do everything in your power to make my baby well, to grow and to succeed. Please treat my child like they're one of your own, and know that I'll be forever grateful for the love and care you show while you work. I have hope. I don't really want to hear the statistics all the time. They scare me. They cut the thread that ties my hopes to my dreams. I understand I need to know when things are bad, but please remember, I also need to know when things are good. Please don't just break the bad news to me, but help me mend my heart with the happy stuff too. I thank you for every bit of what you do, for every aspect of what you give, every day of yours you dedicate to my child. The NICU is tough, and no parent wants to be behind its doors. But I'm happy that it exists, that you're here, and that you work hard every day, not only to help my baby survive, but to thrive. And I'd like to add to that, it was really important for me as a parent to be able to find out, take a positive out of every day. And sometimes just not moving anywhere can be considered a positive, and telling parents that even if the baby hasn't deteriorated, hasn't gained weight, hasn't moved up the scale, by staying still, that's still a positive. Because I think we need to leave the NICU every day. We need to leave those closed doors with something in our hearts that we can take home and hold on to. And I guess always remember that every action you take when interacting with these babies has a consequence. It can be a negative, a positive, or a cumulative, and that these consequences can impact the lives of these children and their families forever. So take that moment, step back, ask yourself, what will the consequences of my interaction be? Will it be positive? And try to make it a positive one for us as families. And thank you for your time.
Thank you so much, Mandy. It's not the first time I listen to your talk, but I get so emotional. Thanks a lot. And I think we hope that these recordings will function and you can use this, your talk, when you talk with administrators and so forth. It's very, very strong arguments, of course, for IFCDC. Stina, do you want to say
I
something?
thought maybe before we welcome Siri, we might have another go at a poll.
Okay.
And
So
poll 3 and 4.
I can do 3 and 4. First 3, but you have to. It's only one question that could maybe you can respond quickly. Can mothers get medical care for her own needs while staying in the NICU? That is, do you have couplet care in your NICU?
Meanwhile, we have one question and reflection. There were many reflections about the COVID-19 situation and visiting hours, but also concerning KMC and skin-to-skin contact, which is now in many units been banned. And there was a question for you, Björn, if you could reflect on that or comment.
Oh, I wish that Pierre was still here, but he isn't. We heard yesterday that they had 300 cases of adult patients on mechanical ventilation at his hospital. Can you imagine 300 cases? Of course, this is an extreme situation, and I will not make any recommendations, but you have to listen to what your own hospital recommend. I would not go against any of those recommendations. This is an extreme time. In ordinary infections, we know that we can prevent, if you have single rooms, you can prevent the spread of nosocomial infection and so forth. But as we had on our exclusion list for couplet care, one thing was actually contagious disease. So I think this is actually the case during these coming months ahead. 64% have, 78 people have replied. Then I end the poll and share the results. And as you can see, it's quite extraordinary. Actually, 41% of the units represented have couplet care. This is fantastic, I think. And for us, it goes ups and downs. Sometimes it works, sometimes it doesn't work. So the local ones that have, be sure that you try to continuously defend it. Cooperate with the Department of Obstetrics and see that if you have any problems, and try to solve them as quickly as possible, because it will come up, go back up and forth. But this is very encouraging, I think. Okay.
And then we had another question about to Mandy, and thank you, Mandy, for your absolutely fantastic presentation. About you mentioned online resources as a parent. kind of online support would you imagine could have helped you and could help others in the future?
Well, 13 years ago, there wasn't much online support. I know now there are some American programs that are up and running that tracks the parental journey through the NICU, and it explores their emotions, how they're coping physically, how they feel they're developing as parents. I tested the program for one of the groups in the US, and it was really, really good. It touched on all the points I felt as a parent would have helped me at the time. So there are a number of parent programs developed and in development, and I think a lot of apps are there now that parents can feel a little bit more in control of the situation. And I think it's very much about allowing them evolve in their role as parents with that support that tells them they're doing an okay job. I just felt for me that wasn't there. There was nobody to say what you're doing is okay. There was always that just underlying fear that I didn't have the skill set necessary to do the job that the healthcare professionals had done for my daughter. And I wasn't getting that feedback when I was bringing her for checkups. There was a lot of negativity around post-discharge, a lot of focus on things that weren't going right because she wasn't developing correctly, because she wasn't eating. Just felt as a parent I wasn't part of that process, and there was almost maybe an inconsequential finger pointing going on at my parenting skills. So I think having those programs early to help parents develop their skills and to be reassured that what they're feeling is normal. For a whole year after my daughter was born, I had a knot in my stomach, and I didn't realize it was there until it was gone. I remember distinctly waking one day and feeling different and realizing that that knot was anxiety. I couldn't articulate that. I didn't even recognize it until it was gone. So having that whole cross-sectional support structure there, I think, is really important. It's not the physical, it's the emotional, the psychological, the psychosocial. They all knit together to make a better family unit ultimately. And I think if there were more educational programs there, it would be great, because our healthcare professionals don't have the time to administer teaching classes in the NICU. It would be great if they did, but they don't. Some units have parent gatherings where they can exchange information. I think on an exponential situation, we need parents to be brought on that journey, whether it's through education programs or peer-to-peer support.
Yeah.
To ensure they're better.
I'm sorry to be impolite, but we will come to some training programs. But another thing I'd like all the participants to do, you had the question if there are online support links. If you know of one in your continent, in your country, please write it down on the chat to everyone. Because I'm sure there are in Australia and in the United States. Maybe Gretchen Lohan could write something in the chat to everyone. But also, I was very impressed by your emphasizing the importance of skin to skin. So we actually have a poll on this, and maybe I can take that now, Stina, is that okay? So a quick poll on, during the hospital stay, what is the estimated daily skin to skin contact time in hours for the infants in your unit? Of course, most of you wouldn't know because very few units actually record and monitor, but you might have an idea after being visiting or working in the unit, and some of you might even have been recorded it. You remember in the global trial with the support, we had approximately 18 hours. So that was the median.
So do we have an answer on the poll?
3%, 2 units, have more than 12 hours per 24 hours. 8% have somewhere around 8 to 12 hours. And 36% have, actually, this is the wrong order here, 4 to 8 hours is 36%, about 1/3. And then 8 to 12 was only 8, and less than 2 hours, as many as 8 units, 11%. So I'm sure that your unit is not following the guideline of WHO. And you can, actually, I know that it is not implemented for more than maybe 5% of all the neonates in the world. So you're not alone. But can you imagine, even if it's evidence-based, it's only just less than 5% that actually gets the skin-to-skin contact. Siri Liljesköld, an old collaborator and friend of mine from the Karolinska. She's a registered nurse, also has a master in nursing, and she's now a PhD student. And her main areas of interest is actually conceptualizing and working with the neonatal couplet care with zero separation. And she's now very much involved in the immediate parent skin-to-skin study. So please, Siri.
Yes, thank you. Now let's see, I'm just going to thank you, Björn, for that introduction, and thank you for your patience. Wow, I feel quite, as always, when listening to Mandy and to parents, one feels quite humble. And I feel also very grateful to Björn for giving me the opportunity of being part of this TEG and part together with such great people. And of course, thankful for EFCNI for initiating such important work. So I'm going to give you an overview and some of my thoughts on the standard case management and transition to home, which I think, given the magnitude of the other standards within this TEG, may have a risk of becoming a bit marginalized, but I hope to be able to lift it up as an important standard. So a standard that, of course, also is closely linked to the TEG follow-up and continuing care. But I think emphasis when placed within our TEG is case management as a process that really starts directly from birth and as an ongoing process during NICU care as well as beyond. And also, most importantly, case management as a collaborative process together with parents. So rather than healthcare staff planning and coordinating for the family, we are planning and coordinating with the family. And there's a big difference in what I would say such a mindset. So an important goal of neonatology is that after days, weeks, and often months of care in the NICU, we have parents who, despite adversities met along the way, feel empowered and confident as parents and well prepared for discharge, whatever the next phase might be during that NICU stay and after. So preparing them for the life beyond the NICU, helping them to navigate on the sometimes bumpy road along the way. The role of case management is then to, in a structured way, plan and monitor the entire care pathway and prepare parents for the next phase. Now, as a NICU nurse, planning and coordinating between needed investigations and treatments and services and communicating with families around these issues is, of course, an important part of what we do every day, and together with, of course, the rest of the team. Yet I've often experienced that despite sort of the best of our intentions, we do often fall short and fail in providing a case management plan that has been well communicated and established together with the parents. as well as adhered to by the team. So parents saying, saying to us or saying, these changes, they're coming too sudden. We don't feel prepared. Why didn't someone communicate better to us and involve us earlier in planning for the next phase in our infant's care? Every day, I think a very frustrated mother once told me when the rounds were coming in, she said, look, every day someone is coming in here with a new agenda, and we just feel that we're the last to know, and so on. So I think it can be important that we in our various settings also consider what are the challenges we are facing in providing effective case management to better be, so we better can address these challenges within the NICUs and beyond. And when thinking about this, I think that taking on a systems perspective can be very useful. So just as Björn also showed, here I've used the synaptic model of developmental care by Heidlis Alls. So if you like the NIDCAP model of NICU care, to help provide insight into our ability to provide a care pathway that is well-defined, well-structured, and well-communicated to and together with our NICU families. So within a systems perspective, the entity or the whole is made up by interrelated and interdependent parts, and changes in one part of the entity will affect the other parts of the entity as well, or the whole. And when thinking, at least in my own context, one factor that I believe is influencing effective case management is the challenges that we see in maintaining a continuity of care, both directly bedside by the infant and the parent, but also within and between the NICU hospital community systems. And there are, of course, many examples of issues that are disrupting continuity of care. Definitely staffing issues. I think we share that, many of us. So shortage of nurses, shortage of hospital beds, or problem of keeping hospital beds open. We have a lot of transfers of families transferring during their NICU stay to different units, which even those transfers that are planned most often are experienced as very disruptive for our families. But also the chain of responsibility within and between the NICU and hospital and community systems not always being clear or well defined. At more macro level, case management is about the chain of care, how it's organized, the various disciplines and departments, and how they're involved in the chain of communication responsibility between them. And how does then this affect the possibility for the individual patient and family to receive a case management plan that is managed and clearly defined by the system? So putting the responsibility on the healthcare and community systems and not primarily on the parent and family. So this is a picture that of work that we did in the Stockholm region, so 2018. So mapping the current chain of care for the premature infants and shortcomings. So it was also work that was initiated very much by the Swedish parental organization, for premature infants. So the text is in Swedish, and my point is not to go through it in detail. Let's see. If I get there, the pointer.
Pointer, if
Your mouse is working actually, so you can use your mouse.
Okay. Is it working?
The red, okay, yeah.
But showing you how we map the chain of care from birth, or before birth really, up to school age. So going through neonatal care, home care, the follow-up program, and up to school age. And in the blue circles, where we could identify various challenges as well as shortcomings throughout the different time points within this chain of care. And what we could see doing this mapping, that there really was an overall lack of continuity of care and standardized communication and coordination between various disciplines and entities within the system. So really putting a lot of responsibility on the parents themselves to manage and define their own case management plan, if you like. So this work could lead to recommendations on actions that could be taken to better come to terms with these shortcomings. And we also see initiatives now on a national level to improve the chain of care for premature infants. And then on a micro level, case management is about tending to the individualized need of every infant and family starting their life and parenthood in the NICU. So planning collaboratively together with parents on an individual level, but with the help of a well-defined and structured chain of care. So coordinating between needed investigations, treatments, and services in regard to expected clinical course, and ensuring adequate communication with families along the way. So preparing them for the next step or phase in their infant's care. And this is a picture that I actually use because I think it's quite symbolic that we don't want parents to be standing on the outside looking in, but rather being on the inside together with their infant and together with us looking out. That's a much more empowering experience. So the statement of the standard says that an individual case management plan for each newborn infant is established in collaboration with parents to plan and coordinate needed investigations and procedures and ensure the acquisition of needed parental competences prior to discharge and to plan follow-up and continuing care. And it got a heart from me. And it goes very, I think, much into also what Mandy highlighted in her in the previous presentation. So the essential components of the standard, sort of put in my own words, are that parents, of course, are seen as the primary caregivers to their infant. So this is, that's a mindset, and that's a mindset that runs through all the standards really within this tag. And also when it comes to case management is placed within a relationship-based care. It's not a task-oriented care or procedures. It's based within a relationship-based care. And with that said, of course, planning, coordinating, and monitoring the entire care pathway is done in collaboration with parents during hospital stay and after discharge. Planning and preparing parents for discharge begins around the time of birth. So it's about early parental involvement. And case management is always an individualized process aimed to meet the specific needs of the infant and family, but with the help of a well-defined structure to lean back on. So what steps can be taken within the neonatal unit to ensure unit guidelines on and implementation of case management and transition to home? As Silke pointed out, we all have our have different places from where we start, so we have to look at where we're at in our own setting. And the standards, as also been shown, show steps, both initial steps and further development. But one place to start is to designate a unit discharge planning group or a discharge planning nurse, with the aim to develop a structured discharge planning education program, and that this is clearly communicated to the parents. Together with parents, create and regularly update an individual case management plan throughout the NICU stay, to provide ongoing and structured conversations about the infant's needs and development, and a way to do that could be to bring in and start with family-centered rounds in the NICU, which this picture shows. It's a picture from Danderyd Hospital at Karolinska. So doing the rounds together with the parents collaboratively is a way to have an ongoing and structured conversation about the infant's needs and the parents and families' needs. To support parents in the acquisition of needed parental competencies prior to discharge. So preparing them for the next step, whatever that next step might be. And there, I think we probably have many examples of tools or checklists to use together with parents. To empower staff with the knowledge to be able to support parents in how they can interpret their child. So discussing the infant signals with parents and how they can interpret their child's behavior. And providing post-discharge family support. Could be peer-to-peer support, maybe a helpline, 24/7 helpline, or a home care program. So I just want to show an example from our neonatal units at Karolinska, a tool that we developed to support parents in being early involved in their infant's care and in the acquisition of needed parental competencies along the way and prior to discharge. So it's a chart that parents can fill in together with staff to better understand sort of the level of support that they might need at any given moment, and how this support can best be provided by the staff. So in the left column is described various caring procedures that parents can be involved in at an early stage in the NICU, and then different ways of receiving support from the staff. For example, taking the baby's temperature, nappy change, tube feeding, skin-to-skin contact, weighing the baby, bathing, breastfeeding, how staff in the beginning might need to be a bit more instructive, and the parent participates, but with support from the staff, to staff supporting actively, but parent acting together with staff, to staff maybe taking more coaching approach, and parent being able to act alone, but with the support from the staff, to staff always being nearby, but the parent feeling confident and acting alone. And on the base of this chart is, of course, and very importantly, the developmental support to always observe, feel, and follow the baby's behavior, and support parents in doing this. This is not a linear process. It's meeting the parent where they are at the moment. The parent can maybe feel very confident and be acting alone, but then something happens medically with the infant, which throws them back, and we have to meet them where they are at the moment, and to what level of support that they need. And the standard also emphasis that a very good way of supporting a smooth transition to home from the hospital is through home care. So considering an early discharge program or a home care program is a great way of enhancing, supporting and enhancing parental skills, at the same time reducing hospital stay. So it's a very cost-effective way of also caring for the infant in the home. And we have at Karolinska, we're very proud of that program. We can care for almost half of our patients are cared for at home, where they have home visits by nurses 2-3 times per week, and access to the unit after discharge if readmission is needed. And this becomes a very good link between hospital care and community care services or child healthcare services. So yes, thank you.
Thank you so much, Siga. It's I'm very grateful that you took a very systemic approach in your presentation, and even if that slide was in Swedish, I'm not sure it was clearer to me than to the others that don't speak Swedish, because I think with all these small circles and all the stakeholders involved, you can understand that parents become confused. So I think that work is enormously important. Thank you so much for this. Stina, do we have time for any questions, or should we ask Sari to start again immediately? Very impressive material you present as well. And I think very good to point out that the parents are moving across this competence or feeling of competence, and also emphasize that it is the parents, both parents, that are filling in where they are feeling that they in this list. It's not the nurses or the staff that decides, it's the parents. So you have to have a pen that you can erase and move around.
Yes.
One for mother, one for father.
Thank you so much, Siri. And we move forward. So
Okay. So if Sari is there, are you there, Sari?
Here I am.
Good. So we are very happy to have another member of our topic expert group and a psychologist. Sari is Alkis Björkrot. She's a doctor in psychology and a researcher at the university and a university lecturer at University of Turku. And her focus has been parent-infant psychotherapy and also influences of the environmental and psychosocial factors on parent-infant relationships. And of course, one of the key founders of the close collaboration with parents training program. And I think this is very applaudable because few researchers actually take the effort it takes to make a program, supportive program. So thank you very, very much for all your work, and thank you for your contribution in this standards project, and also for coming today. Please go ahead.
Thank you, Björn, for your kind words. It's really a pleasure to be here, although it feels odd in a way that I'm sitting here and you all are sitting in all over the world. So this is really a new concept for all of us. But I have to congratulate Björn and Stina being so brave and taking this step to keep this virtually, the whole Congress, that it's really, you know, with the short notice. It's amazing work. Thank you for organizing this. And thanks for Björn for inviting me in to the standard work with the EFCNI. It has been really important part of the work, and thanks for whole our team working on this standard, which is about clinical consultation and supervision for healthcare professionals on supporting families. And of course, I have to thank the EFCNI team for the whole initiative and how Silke presented today. We know that it's not a big, it's not a small work they have done before we are here at today. So I hope you can see my slides well now. And as I said, that it feels funny that you are all over the world, so I wanted to tell where I am to you. So I'm working in Turku, Finland. That's my workplace, but as everybody now is working from home and taking care of their part of not spreading the coronavirus more, so I'm working from home also, and the picture down in the right is where I am now in an island, like outside in the Turku region. And my content of my talk today is about statement, the whole standard, about the statement and the rationale behind of it. And I go through the components of the standards also, and some forms that what the consultation and supervision could be in this context. And then we talk about the benefits and some concluding remarks. And then I also have delivered some polls for you to answer related to this issue. So first of all, I would like to go back to the history for a short while, because often by the history helps us to understand where we are today. And the Western neonatal care has gone through a huge change during last decades. And starting from the very professional-centered care, where the focus of the care has been solely the infant and the infant's well-being. and transitioning towards that we are involving parents into the care of the infant. And these pictures below here, they are from Finland, all of them, and most of them from the Turku University neonatal unit. And the picture where the year 2000 is below is describing that phase on that unit when the parents were more involved on the care, but still they were placed in the big rooms, open bay rooms, and they didn't have own place in the unit. And currently the phase is that families have their own rooms where they are living home kind of life, and the professionals are the visitors in those rooms. And that requires a lot more negotiation and communication between the professional and the staff, and also by that the parents have become a team, really the members of the care team. So, so I think that this change tells us that new skills are required in the work of the doctors and nurses and other specialists who are working with the families in the NICU. And therefore, they are in the need of education, but I would also say that in the need of support as well in the facing new challenges and new situation in their daily work with the families. So some research findings to show how parents, for example, experience the communication with the NICU healthcare professionals. By that I mean both nurses and doctors and other professionals as well. So parents have stated that empathetic attitude from the part of the staff is the key factor on their experience, for their experience about the communication with the NICU professionals. So, but how to impact attitudes of the NICU staff? That sounds abstract and difficult, but please keep in your mind the word attitude. We will come back to that when we go further in this presentation. Also, it's very strongly shown that the good relationship between parents and healthcare professionals impacts on parents' relationship with their baby, parents' feeling of inclusion to the healthcare team of their baby, and parent satisfaction with the neonatal care. You may have heard that sometimes people are using the word gatekeepers, and that sounds a bit negative, but I think that if we can see it from the positive perspective, it's the ones who can facilitate and make the relationship possible and make it more stronger. And then if we move to the side of the healthcare professionals, how they experience the provision of the emotional support to the parents. So one nice Irish study mapped how healthcare professionals are thinking about the emotional support provision. 90% of them experienced the emotional support as a one core part of the working role. Although they also showed that the work experience increased perceived competence in this, but not confidence about talking with parents about their emotional experiences. And I think that the one nice example of this lack of confidence is coming from a paper done by Anna Axelin and the other researchers from that group, where they observed medical round communication and found that when infant condition was critical, professionals were concerned that the parents would become too emotional and maybe break down during the medical round, and that could lead to the chaos and were unsure about how to deal with the emotional expressions of parents, or whether really comfort them or really ask that how they are doing with this situation, but like maybe more like leaving it there and withdrawing from the situation. But of course, anybody would need skills on that kind of situation to provide the needed support. And then I think that what was interesting in this study from Ireland was that healthcare professionals, they reported that treating and caring infants in the NICU was emotionally stressful for them. So, and almost all of the persons who answered this study experienced so. So I think that is something to keep in mind as well. But however, in the same study, because I was interested about the ways how to support the medical staff, I found this sentence, what is here in a purple color, that the least preferred setting was formal supervision for support, and the most preferred setting was informal one-to-one meeting. So this was very interesting to me, and I would like to further understand this issue, that what is really the preferable way of receiving support. So another, if those results which I just presented were from 2 units, like the individual units, so there are also studies which have done in larger amount of units, which one is called International Closeness Survey, delivered by SEEN Research Group. And here are people also who have been participating in this study, like Björn and Rosario Monterosso, and maybe some others as well are listening. So in this study, parents and staff members were asked to rate they received and given emotional support daily basis, so that they got a set of 7 random questions where one was related to emotional support. And by this method, the researchers got a good idea of the unit culture related to emotional support, not just single experiences. So the parents actually rated the emotional support as one of the lowest 3 scores in 11 units by mothers, and in 7 units by the fathers. And the nurses, they also gave most often the lowest score in the emotional support, meaning that they felt that they didn't deliver or provide emotional support during that work shift for the parents. I think that there are several reasons why the emotional support is felt like difficult, or people are feeling like lack of skills giving emotional support, or not confident in it. I think that if we put it in the historical perspective, we start to understand more what is happening. And I think that in before the transition of the care to becoming more family-centered care, it hasn't been the core component or core competence of NICU staff to give emotional support for the parents. So probably not the education for doctors and nurses haven't consisted education for this part. And I would like you to now think about, for example, own background education, that how much you have received education for giving emotional support, or even for the communication skills. We will come back to that. So back to the standards and the main component of the standards. So what we came up with was that parents, of course, they should receive psychosocial, and if they want, also pastoral support during the stay in the NICU. And also the team, the healthcare team professionals are really core providers of the support and sensitive interaction with the parents. And what that could be in the healthcare professionals level, it could be a unit guidelines about that how people should or can participate to supervision or counseling, and education provided for the whole team about family support strategies, and also regular supervision available, and especially related to that kind of so-called difficult situations where there are critical decision-making situation or pregnant situation where you have to be the ones who are helping the families to go through the loss of their baby, for example. And in the unit level, it could be a unit guideline that is also related to that how staff is getting supported. That could be available, that everybody knows, and regularly, of course, updated as well. And then a good unit guideline also about communication and support. And when I was listening today, Silke and Mandy, thank you for them for sharing their story. It was really, really meaningful to hear your perspective. And I think that we didn't really emphasize that much that what is really the parents need. They need help and support to on their way becoming parents. So it's not only about debriefing and trauma and bereavement. Those are of course important and they require special skills, but also supporting attachment and bonding and becoming a parent requires special skills. So that should be emphasized in this standard better than it has been. So for hospital level, the hospital should provide education for the staff and support for the healthcare professionals. So these two words seems to pump up all the time and are the core things that I think that are helping the professionals to in their well-being and developing their skills. So for health services in a kind of on a national level, we could also have like the associations, doctors and nurses associations could create guidelines related to supervision and counseling, and more also delivering knowledge that what it really is. And I think that the continuing professional development also after basic education should include these two issues very much. So what could be the further development in this field or under this standard is that the units could implement quality improvement projects related to emotional support and communication, and they could also monitor frequently that how they are really doing auditing in their own unit and asking from the parents that how they are getting supported, and based on that feedback develop their own practices. And for the hospital level, I think that we could also have career development programs for healthcare professionals to become really practice development experts and debriefing facilitators and clinical supervisors. Often the supervisors are coming from the NICU, out from the NICU context, as I have myself done. But I think that if we would have more clinical supervisors who would have a background of neonatal nurse or neonatal doctor, that would be really important addition to the supervision or provided supervision. So then I picked it up some ideas from the standard about how to get started. So we could ask feedback from the parents. Today we heard how capable the parents are giving us feedback, and how easy for us is to understand what is important for them when we hear it that in their voice when they are telling that to us. And of course we need training, but I also think that we would need, training is maybe a wrong word here, it's more like education on counseling and clinical supervision. I have my own experience that sometimes supervision is not quite understood in a right way, that it is like that if I'm not it's based on that if I need it, or if I have difficult times, or if I'm not like handling my work, then I would need supervision. But I think that it's more like for everybody who works with the parents and infants and around their relationship and supporting their relationship, that's always needed, because there are some factors that are very emotional, can touch our own issues in a way that makes it very complex for us to support them, or that is making us like increasing our own emotional burden. So then we need some place where we can get loaded, energized again, and heard and understood. So it's more like that to stay fit, you have to exercise. So to stay fit as a supporter of emotional supporter, you should get supervision and support. So one way to get started would be the auditing, in doing an audit in your own unit, which I already mentioned, and also established team inside, a specialized team inside your unit who have a special focus on developing staff skills on communication and collaboration and parent support. So now I'm wondering how much time I have left, but Stina, can you give me some understanding?
Yes, I thought that we should You should get until 1:15, so
Okay.
10 more minutes.
10 more minutes, thank you. No. So something about the forms of consultation and supervisions, which I have mentioned here several times. So the debriefing or counseling can be like a case-based one-off session. That is a one time, is after special event or happening in a unit, or with family that you have some difficulties to understand or get a common understanding with, or something like that, which is based on that something difficult has happened. But the supervision is usually progress and of several meetings that are scheduled advanced and enables different kind of things than just this kind of case-based sessions. So we come back to the attitudes, and communication and collaboration skills are strongly related to individual attitudes and values. And if we could have a place where we could safely study our own attitudes and values related to parenthood, parenting, mothering, fathering, bonding, whatsoever, which are often very individually loaded things. So that kind of a supervision could be called reflective supervision, which is a technique that enables us to be like a mindful related to our own feelings, own attitudes and values, and also by that enables us to be mindful for parents' feelings and thoughts and fears and hopes related to their parenting and parent-child relationship. So, so I think that being really listened to and heard yourself, you are able to also listen to better and be more empathetically understanding towards others. So that's basically what the reflective supervision is about. So the case-based, I already mentioned that, is more like debriefing situation. And of course, that also provides emotional support for the staff members. And especially, I think that it offers a nice possibility to analyze the communication between the team members, the healthcare team members, and of course, between the healthcare team and the parents as well. And that could be one, like even without any difficulties, you could have that kind of consultations and supervisions. And then, of course, it enables a wider professional understanding if the supervisor represents a certain profession where they can deliver more understanding from that perspective, like a psychological well-being of parents, or parenting, or parent-infant relationship, and then it can also increase the knowledge of the neonatal staff members. So the regular consultation, I think that this might be the most used or existing way of getting support in the NICU, that there is a regular person, a counselor, psychologist or social worker or priest, or who is somehow integrated into the healthcare team, is probably providing direct emotional support for the parents, but also works with the healthcare team as well. And then again, we come to the regular clinical supervision, is especially clinical, not only related to relationship inside the organization, for example, not like focusing on organizational supervision, but all really focusing on the clinical work and being and supporting the healthcare professionals' work on that way. And I think that having these kind of facilities available for the staff would decrease the emotional burden from the work, the important work that they are doing. The benefits are several. I would say that these are the ones that we collected for the standards. It's improved staff self-efficacy in supporting parents. So I think this is very important, that you have professional tools to support parents. Of course, many of us are like naturally empathetic and able to create good relationship with people, but I think that in professional life we should have also professional tools to do that, which is a different and decreases also the emotional burden of being emotionally supportive. So it reduces emotional stress for healthcare professionals related to supporting parents. It improves work satisfaction, and thereby it improves the quality of care and even reaching the support of the parents is better, and that's supporting better the bonding and so on. And I would be very interested to see more studies around this topic, more systematic studies showing that whether this kind of actions like regular supervisions, for example, would decrease the staff turnover, which we thought that it would make. And also, I go to my concluding remarks that I just heard very good talk by Terry Inder in the Cravens conference about the burnout rates in the NICUs, and I was really shocked about the frequencies. And I think that also speaks about that it's important, it's really, really important to support the supporters and take care of their well-being and give them, of course, skills, but not only ending to the education. So thank you for having this possibility to share these ideas with you all.
Thank you very much, Sari. Very, very important that you mentioned we need professional support. We might all think that we are very good in supporting parents, but I'm sure the psychologists could and social workers could definitely improve our skills, competence. Stina, should I launch the polling now, or?
Yes, this is Sari's poll.
8 and 9?
Yes, first 8, I think.
8, yes. So we have tried to do polling of this very complex area, of course, so it might not be easy to reply. But the first question, does your NICU have supervision available for the healthcare professionals? The second question, does your NICU have consultation on emotional support and communication available for the healthcare professionals? And thirdly, do you think that existing staff support is enough to meeting the communication and emotional challenges in your daily work with families? Do you think that the existing staff support in your unit is enough for meeting the communication and emotional challenges in your daily work? I think that was the third, yeah.
Yeah.
We have been just saying a few times now that we are so many people from many different places of the world, and I will just show you where we are from, all of us gathered here today. We are from at least 32 countries with 130 attending participants that has been joining the webinar at any given moment. We are now a few less, 107, but that is a lot. And registered was 350 participants from 42 different countries. So somewhere between 32 and 42 different countries in the world are represented here today.
Fantastic. So have you had time to reply on this question, these three questions? I think actually we have approximately half of the attendees are voted. So due to the time constraint, maybe we should continue to the next one. Is that okay? Yeah. So I end this poll and I share the results. And maybe, Sari, you could comment on this.
Yes. Oh, yeah. Oh, very interesting. I see that almost half of the units who have replied here have, or persons who have replied have supervision or counseling or consultation available. But surprisingly, it seems that it's not really enough. That it's the 80% of people are experiencing that what is available is not enough for them. And this may be the most important message for us at the moment, that we have to try to find together with the staff that what are the best possible ways to support them.
Yes, and that shows how important your lecture was, actually. Thank you very, very much. And I think we have another next question or poll questions. Just one. Does your NICU or the NICU in your area have mental health service available for the parents? Sorry, could you comment on that?
Yeah, I think that this is a more familiar situation for me on those NICUs where I have been worked more closely with, or with those, that there are quite good systems available for the support, mental health support for the parents. Either that the mental health supporters comes to the unit and meet the parents, or the parents has a referral to a unit where they can get the mental health support. So this is very good, and I think that this is also needed. But yeah, we still have to improve our ways to support the staff members.
Yeah, to avoid emotional fatigue and burnout. Thank you very much.
Yeah.
Stina, please take over.
So now it's actually lunch in Sweden. So now during the break, I will present a video here on the screen as a pause activity for those who want, but I will also write the link to that movie, that film, in the chat room. And it's a film of immediate skin-to-skin in the IKMC study that Björn told us about.
The purpose of this study is to test whether kangaroo mother care, also called KMC, can increase survival of very small and premature babies. In this hospital, all babies will get the same care, the best that is possible. This research will give that same care to half of the babies in the incubator or cot, which we know is safe. The other half will get exactly the same care, but in KMC, to study whether this is safe and even helpful for helping babies survive. Both sets of babies will get the same care. It is only the place of care that is different. This film is for parents and staff as they care for the tiny preterm baby together on the mother's chest. In this film, we will say that the baby is a boy, preparing for the birth. You, as parents, have come into the hospital as your baby was born prematurely or early. The staff will have already spoken to you about the research study. After your baby has been weighed, you have by chance been put in the group that will receive all the best care for your baby, but in kangaroo mother care position on your chest. This film will explain and show practically how to care for your baby with the warmth of your body. Immediate KMC in the labour ward for a normal birth. The baby will be weighed as soon as all necessary care has been done. If chosen for KMC, the baby will be put on mother's chest straight away, and both will be covered. The baby will be watched carefully. A red light will be put on his hand to measure oxygen and heart rate. The baby should be disturbed as little as possible. It is best to keep the baby on the mother at about 40 degrees. This seems to help his heart and with his breathing. Premature babies are very small and their lungs may need help to breathe. The baby may need to be taken to a table with equipment to help him breathe. He may need help breathing with extra puffs of air as his lungs are not yet ready. He may also have a tube giving continuous air pressure called CPAP. Tiny tubes may be put into his veins as intravenous lines through which he can be given medicines and fluids. This may also be done with you supporting your baby while the staff put in a drip, for example. Then your baby will be brought back and put on your chest. KMC born by caesarean. If your tiny preterm needs to be born by caesarean, he will be wrapped in a warm towel and taken to be checked and weighed and chosen for the trial. It is easier to put the baby on the father or a guardian to begin with. This can be done in the operating room or just outside. In this small film, the mother is left in the operating room and the baby is taken to father in the room next door. He can then be taken in a wheelchair into the operating room to meet mother. It is better for the baby to put him on mother's chest on the operating table, but this may be more difficult for the staff. This can be done without disturbing the surgeon or the sterile field. The baby can be put straight onto mother's chest in the operating room if she is awake, and then covered. Here he feels warm and safe. A staff member needs to watch the baby constantly. Immediate KMC in the first hour. The baby then spends the first hour on mother's body. Make sure that the baby is dried carefully and gently. Keep the same cloth with its warmth over him and add more cloths or towels if needed. Normal care and observation should be done without uncovering the baby. This will keep the baby warm. Look for your baby's eyes opening. Switch off any bright lights and you may see this. Talk to him and he will try to find your face. If your baby is a fairly big preterm, he He might wriggle his way up mother and try to nuzzle and suckle from mother's breasts. Don't expect him to breastfeed straight away, but you can help your baby to the breast by putting his nose near the nipple. Even a small baby may make small movements towards the breast. Help him gently. Remember, he's still very little. If you want, you can even hand express a little early milk for him to smell. Remember to always keep him well covered. In the first hour after birth, start expressing to get the milk started sooner. Even a few drops of this very early milk is helpful for your baby. What we have described already is immediate kangaroo mother care, starting in the birthplace. This togetherness of mum and baby should be continuous in the nursery as well. Continuous KMC. Lying down all the time with your tiny baby on your chest is difficult, as you as mother have to watch your baby all the time. But you also need to sleep and walk around. So we will show you how to make this easier. We tie the baby onto mother's chest in a KMC special shirt. This KMC shirt can be used for the first time before moving a baby on mother or father from the birthplace to the nursery. It also helps you to do continuous KMC all day and night, as the shirt will keep him safe even when you are sleeping. It is important that your baby's skin is against your skin, so take off your bra and other shirts. The KMC shirt comes with a non-stretch white piece of material. We fold the long side of this and it is tied very tightly across your baby's chest and back of neck. It is under his ear and above your breasts, just under your armpits. His head is slightly up in sniffing position and to the side to keep the baby's airway open. Your baby's hands must be bent up near his mouth so he can comfort himself or suck his hand like he did inside you. Your baby's head should be close enough to kiss and on your chest bone, not low down between your breasts. Baby's legs should be curled up together next to your stomach as if he is sitting. The white tie is to keep his airway open and safe, so needs to be tight. Babies breathe with their stomachs. This sounds strange, but for the lungs to fill with air, the stomach or abdomen needs space to move and not be squashed. The KMC shirt can then be put on and the two triangular sides tied in tight under the baby's bottom. Make sure his feet do not stick out. You should feel your baby tight on you. Many mothers say it feels as if her baby was still inside. This way, the warmth of the mother's skin always keeps her baby warm, with the baby's airway protected. KMC for transport. A tiny preterm cannot keep himself warm, so it is important that your baby should not be taken out and left, even if you as mother needs to walk around or eat, read, or even go to the toilet. When newborn or when the baby is unstable, the KMC shirt should be used and the mother or guardian should be moved in a wheelchair or trolley or bed with wheels. Once your baby is stable and growing, mother and guardians can walk about freely with the baby in the KMC shirt. Baby can sleep safely in the KMC shirt. Babies usually fall asleep when the KMC shirt is put on. Then they sleep for about 1 hour. A mother can almost always tell when the baby is falling asleep, or is deeply asleep, or starting to wake up. This KMC shirt can also help you as mother to sleep, knowing that your baby is safe. Sleep when your baby sleeps. The shirt must be tied properly when you are sleeping to keep the baby safe. KMC shirt can be used during infant feeding. When your baby starts to wake up, loosen the 2 flaps of the shirt just slightly, undo the white tie, and let your baby slide down inside the KMC shirt so that his head is near the nipple. When your baby is awake, he should not be tied to your chest, but be spending this time feeding. It may take time for the mother of a preterm to produce breast milk for her baby. Your nursing staff will provide alternatives. Whenever the baby is at your breast, try to express some breast milk to get his food supply going. You can express the milk by hand or with the pump if available. This mother is giving her baby her own expressed breast milk. Breast milk can be given through a tube in the nose or in the mouth. This should be done while the baby is next to mother's breast to stimulate milk production. Your breast milk can also be given to your baby through a syringe, pallidi, or on a teaspoon. As he needs more and your breasts make more, a tiny cup can be used and the baby fed. Do this very slowly. The stomach of a tiny preterm is very small, so he will need small feeds of breast milk every hour or so when he wakes up. If your baby hasn't woken in 2 hours, he should be gently woken and encouraged to feed. Notice that the sleep cycle and the feeding time fit together nicely. Breast milk feeding of expressed milk is how we start. Our long-term aim is for your baby to be exclusively breastfeeding. Gradually, you as mother can express more and more milk, and the baby can be encouraged to suckle on the breast. This is a learnt behavior leading towards the baby being able to breastfeed effectively. Exclusive breastfeeding means that your baby is swallowing only breast milk and growing well without anything else. If the baby is sleeping on father's chest, when he wakes up, we can move the baby to the mother for breastfeeding. The baby should always be moved prone or facing downwards with his arms and legs coming to midline. A very small baby should be placed on the mother, who is almost lying down flat on her back. This way the baby feels stable and can control the rate of flow of breast milk. The mother should express from the other breast when her baby can maintain a latch. Keep feeding and sleep cycling going day and night. It is busy and tiring, but it is what your tiny baby needs to grow. Share this work with your close family members. Using the KMC shirt with twins. Twins are more likely to be born prematurely and may be small for their gestational age. Twins should also do skin-to-skin contact, either having father and mother each having a baby on their chest, helped by other family members. Alternatively, one parent can have both small babies on their chest and the parents can take turns. It is important that both twins have their airways protected at the same time with the white tie and are able to breathe well. Otherwise, everything is the same as described above. The mother will, however, need support when feeding both of her babies at once. If she finds it easier, she can feed one twin at a time. Caring for the unstable baby, the KMC shirt. Some preterm babies may change colour because they have times of very slow heart rate called bradycardia, or even stopping breathing sometimes. We call this an apnea. Keep checking on your baby. You might even feel this happening through the contact of your skin. If this happens, you as mother or father may be told to quickly move your baby to see if movement or standing up will get the baby breathing again. Call a nurse quickly to help you. Firm and gentle stroking may be enough to get breathing started. If the baby is very unstable, he can still be held in skin-to-skin contact, but should not be tied on in case the staff need to quickly give him extra oxygen or other support. KMC can be done with technology. Continue skin-to-skin contact even if technology is needed. The staff will make sure that the technology is fixed well to the baby. When the baby is in KMC, all tubes and wires are taped to the parent's skin. This means they can feel the pressure of pulling out before it pulls out of the baby. If the baby is being moved from an incubator, tape all of the tubes and wires together. KMC and the dying baby. Some very small preterm babies may be born too soon and not strong enough to survive. You, as parents, can then ask to hold your baby as it is dying, or if it has already died during labor. This is very sad and may feel difficult, but it is a special way to say goodbye. Some premature babies may be very sick for very many reasons, and the medical staff may not be able to save the baby. If your baby is dying, he will feel most peaceful and comfortable dying, knowing that he is held and loved. Sometimes a tiny preterm may seem to be doing well and then suddenly collapse unexpectedly. As parents, you need to know that it is not your fault. You may cry many tears, but they are healing tears. Whatever the circumstances, it can be helpful to have pictures of you holding your tiny baby. You can also ask the staff to make a small handprint or footprint to remember how tiny your baby was. Other family members helping with skin-to-skin contact. Some mothers will only manage to do a few hours of kangaroo mother care. Other family members should then do KMC so that we get continuous KMC. It may be helpful to use a KMC dose chart. All low birth weight babies need to keep their temperature constant. KMC is the only good way of doing this. Continue KMC throughout the hospital stay using father or other family member so that they are also familiar with the care and will be more likely to help the mother doing it when she gets home. This will help to change the way tiny preterms are cared for at birth, in hospital and in the community when they get home. This big brother was also born preterm. He is now a healthy 18-month-old boy. Preterm babies do grow, so it is important to keep up your hope. This film has told you the main points about kangaroo mother care. The staff will help you with more details. Thank you for being part of this study.
So, do we think that everybody is here again? 101. I guess we just have to think that everybody's here. So welcome back after a short break, and we are now catching up in our schedule for the virtual 2020 Stockholm Conference on Ultra Early Intervention. And I think we might have some people from the other end of the world that has woken up and are joining us in the afternoon. Welcome to you. I'm Stina Klemming, neonatologist in Karolinska, and together with Björn Westrup, we moderate this conference. It has worked quite well, I think, before the break. Some minor technical problems, but we're satisfied, I think. And Next presenter here is Inga Warren on education and training in IFCDC.
Well, then I'm very happy to present another old friend of mine, and that's Inga Warren. She's one of the pioneers of the field. She's an occupational therapist and has serial of academic degrees, and she's also a senior NITCAP trainer in the UK NITCAP Training Centre in College London, University College. She has done many things, but one thing I'd like to highlight is that she developed this scale, EVN, for evaluation the quality of care given to infants during medical and nursing procedures. Look into that. That's a very good thing to use if you want to do quality projects. But also, of course, she has been involved in our standards, and she's also been involved in the Graydon standards that we will hear more about later this afternoon from Joy Brown. And during the last maybe 5 years, she has developed this fine program, which is now available in 12 languages and in training in over 20 countries across the world. I'm sure we will hear about that, more about that. Inga.
So I've called this education for IFCDC in the Age of Glance to reflect this global initiative you've got going here with people from all over the world being able to tune in. I think it's amazing. Well done. Well, when we were looking at the, hang on a minute. I thought we had it all sorted out. Right, okay. So I was referring to this being in the age of glance because of the global nature of this program. So when we were doing the standards, we were looking at education based on those 3 principles that Björn referred to earlier. In other words, people need to know how important it is to manage care sensitively in order to protect the baby's brain. People need education that helps them to feel confident about working with families. And I was really struck by something that Sari said about a study that showed that many people are not very comfortable about even talking to families about things. And when you think of how inexperienced some of the health professionals that go into neonatal care are, it's not surprising that this is challenging.
This is something that Inga asked us, and we take it before a lecture. According to you, how important is it for the NICU staff to get organized education and training in infant behavior and infant observation? First alternative is one of the most important skills for the NICU staff. Second is equally important as every other skill in the NICU. And for a third, education in other skills like procedures and interventions are more important. And the fourth, this kind of training cannot be organized by the NICU. This kind of training cannot be organized by the NICU. And lastly, we do not need that kind of training. We don't need training in infant behavior and infant observation. As much as 61% of all the responders think that this is one of the most important skills in the NICU, for the NICU staff. And the 38% says it's equally important as every other skill in the NICU. And then we have, as you understand, just a very few percentage that the other things are more important, but none has discarded this altogether. So of course we have a skewed sample of NICU staff. But obviously you all think that this developmental part of the IFCDC is of importance.
Okay, so I have a stable internet connection and I'll run the slides.
Okay, so we're back to talking about education in the age of glance. Next slide, please. And when we were developing the standards, the 3 themes that we followed in developing an educational perspective was Björn has already mentioned, which is one of them is that sensitive care protects the brain. People also need to know more about how to be confident about engaging the family and also managing the concept of individualized care. Next slide, please. Next one. You skip this one. Okay. So we need an educational pathway so that people can progress from a basic stage through up to expert stage. And I'll go through some of those steps in this presentation. Next slide, please. But they very much are built into the FIND program, which I will refer to quite a lot, because it is the one program I think that has a step-by-step progression from a basic beginner's level up to preparing people for expert level, which might equate to NIDCAP. The FIND program is very closely related to NIDCAP. It's like, you know, I suppose it's like mother and child or something like that. But it's also a close cousin to almost every kind of developmental care program. So it's not exclusive to one program. It was our intention to make it a universal and to be basically applicable to any model of developmental care. Next slide, please. It's widely used. As Björn mentioned, we now have translations into 13 languages and activity in 24 countries. So I think that demonstrates that it has filled a gap, and so we're continuing to develop it and to explore new ways of delivering it. Next, please. But if we think and start going through these steps one by one, the first step is about providing information, maybe sometimes instruction and advice. So this is the kind of learning that you might do in a classroom, or you might gather resources. And one of the things we wanted to encourage people to do was to collect resources that are appropriate for their unit, for their area, for their country. Because there will be different needs and different things will be available. Next slide, please. And of course, the internet is a huge resource. Today is just one very good example. However, there are pitfalls in the use of the internet. One of the things that I feel very uncomfortable about, for example, is the use of videos taken from the internet for teaching purposes, when those videos may well illustrate different aspects of the baby's care, but unfortunately are very often done watching care that is not respectful or kind to the baby. And this worries me quite a lot. So it is important to be quite ethical about what kind of videos you use for teaching. Next, please. I think it was in Mandy's presentation, we referred to apps and websites for parents. And if we're looking at educational materials, we also want to look at other apps and websites that might be relevant for professionals. And I came across this work done by Justine Doll and colleagues in Canada, where they had evaluated websites and apps for quality, usability, and credibility. And I put them up here, though, because although they're meant for parents, these papers do give you some very good ideas of tools that should be used for evaluating things that you find on the internet. So I thought they were quite useful from that point of view. Interestingly, they weren't enormously impressed with the quality, usability, and credibility of what was out there. Next, please. And then, of course, we have databases of systematic reviews, which are very useful. I recently came across the Joanna Briggs Institute based in Adelaide, and I thought it was quite interesting that they all have also have a lot of systematic reviews about perinatal and neonatal interventions in developing countries, which might be quite useful when we're looking at a global perspective. And then there's the Cochrane database. The evidence-based standards from the EFCNI and the Gravens, which Joy will talk about later, are going to be a magnificent resource for us. And the fact that they are well referenced and they are evidence-based is enormously useful. And then you can also find self-assessment tools on the internet. So the NIDCAP nursery program is available. And I think the American Neonatal Nurses Association also have some self-assessment programs. Next, please. Oh yes, and then we're developing an e-learning package as an introductory package for FINE, which will be available later in the year, but only in English. That's been funded in Australia. Nadine Griffiths is developing that. And if people want to translate it, they'll need to find their own funding to do that. Next. Then several other ideas have been put forward. Kay Spence in Australia made a good suggestion that maybe rather than have a textbook, which we were thinking of, we could have a shared platform for simple fact sheets. So we could have a range of fact sheets that could be easily updated, but also could be easily translated and that were in language that were accessible to people at all levels, not just an advanced educational level. We also thought it would be helpful to have shared research questions to help build on evidence of effectiveness of education. And a core group, FINE group, have been working on that. And we have got now some questions that we're refining, and we hope other people will look at. If you want to know what they are, you can contact me. My email will be at the end. You can contact me and I can share those with you. And then, of course, there's today's conference, and maybe this is the way forward, and we'll need to think of more ways, more things that we can share this way. Next. However, giving people facts isn't always successful. You can tell people as much evidence as you like, but a lot of people really badly want to stick to their own worldview, and this is a big challenge for all of us. Next. So some of the areas where in particular, as we've done, followed training through, that we've found huge resistance to. I mean, pain management is like the elephant in the room. It's something that if you look through the journals, you'll find many articles that tell us that pain management, pain assessment, the use of non-pharmacological strategies is not being used as much as it could be. And it is quite shocking, really, that we still should be needing to educate people about this. Parental presence is another area where people, where you find quite fixed worldviews about parents not wanting to be present when their babies have procedures, about parents not wanting to do this, parents not wanting to do that. And it's often a feeling that this is an excuse, really, not to make parents welcome. So even in units that, trying very hard to engage parents, you come across quite strong resistance in some places. Breastfeeding is another one where we know that breastfeeding is very important and very helpful, but there's also quite a lot of resistance to that. So these are examples of, where people's worldviews are quite resistant to evidence. Next. So if we go then moving on from information and instruction and advice to the next level, this is where observation, reflection, dialogue, and coaching become very important. And so, for example, in our second level course, we start people making short observations of babies in a very structured way. We ask them to reflect on their work and provide mentoring for this. So next slide. What we're kind of working on at this point is overcoming the Dunning-Kruger effect, because when you give people a lot of information, they often become overconfident. And we frequently come across situations where managers, for example, think you can send somebody on a 2-day course and they know everything and they're going to come back and change the world. So this idea that, the Dunning-Kruger effect basically is that people who don't know much think they know a lot, and people who know a lot don't know, people who know a lot think that they don't know very much. So we have to get people over that hump. And in this second level, when people start to observe and are faced with looking at the reality of what's going on in the nursery, they begin to realize how much they don't know, and then they descend into the valley of despair, and we need to guide them through mentoring up the slope of enlightenment as their wisdom accumulates, until eventually you get to the plateau of sustainability. Next. And then when people are in this phase of beginning to know what they don't know and beginning to understand how to develop their own practice, aware of their own practice, then they begin to demonstrate good practice. In other words, to show the way. And that is a very important way of teaching people. Good practice is a very good teacher. Next, please. So then the next step on is where that experience expands into, develops, of course, with practice, but it expands to think about the big picture, to think more about how practice in the whole unit, how systems work, and how you can evaluate practice. Next slide. And we know that, for example, what makes skills really develop, what makes education stick and practice develop is not formal learning. That maybe is, classroom learning accounts for about 10%, social learning about 20%, but what really is going to make a big difference to making these skills sustainable is experiential learning through day-to-day tasks and challenges and practice. And so that's what the third level would be. Next slide. And the NIDCAP nursery program is an example of a very useful tool for actually achieving this, because it addresses standards in looking in care of the baby, care of the family, the physical environment, but also how to look after staff. And these are all topics that have come up earlier today, and this is a way of evaluating that and helping to set goals. Next slide. So then we come to the fourth level, the last level, which is where we're hoping to develop experts, people who can provide leadership, conduct research, and be teachers. And NIDCAP I put into that because as I've kind of given that priority. I know there are other programs, other very good programs out there, but as far as I know, NIDCAP is the only one that has regulated standards that's been translated into multiple languages, which is quite important. Next slide. So at expert level, we're expecting people who can observe babies, very skilled observers, people who know how to use active listening and communications, people who have mentoring skills, understand systems organization and can manage that, people who will be able to lead education and stimulate research and manage change, which is something that people are often think they should be able to do at a very early level without realizing what an advanced skill this is. Next slide, please. But having thought about having the different levels of education, we also need to think about the context in which it's going to be delivered. And one of those is obviously income level. So this is a World Bank map of annual household income average. The darker the blue, the wealthier the countries. And you can see that the darker blue countries pretty well match up with the countries where FINE and NIDCAP are most delivered. And so there's a certain degree of inequality here, of course, into what is available to people around the world. And that is something that we have to think about. Next slide. However, even though, we might have, be well resourced, there are, in in countries that have quite high income levels, it's often quite difficult to educate people, to get people to see that the infant and family-centered developmental care is a necessity. So certainly from my own experience in my own country, it's quite difficult to convince people that if you don't have a huge randomized controlled trial, or if it's not on an MRI, they will consign it to the fluffy bunny bin. You actually hear people talk about it being fluffy, which is, you know, really distressing when you think about the amount of evidence that we have to support it. But getting that across is, we have to think about how do we appeal to people who are firmly fixed in that techno-scientific bias. Next slide. Another big context that seems to worry people a lot is the risk of infection. And this is also given as a major excuse for limiting parental contact. Rosie Mendizabal did a very nice study in Mexico in which she highlighted this. And it's a problem that I've also found in other countries, particularly in some of the Eastern European post-communist countries that are still a little bit stuck in some of the old Soviet practices. So can we have the next slide, please? What Rosie did was to illustrate how this works, was that she mapped the activities of a mother and staff in one of the units she was working in. So in the top slide, you can see the mother comes in. Her first point is the sink. She washes her hands and she goes to her baby's cot. She stays with her baby and then she leaves directly. And then in the lower diagram, you see what happens in an hour with the mapping of doctors and nurses' activities. So you can see they're coming in, they don't all go to the sink, but they go here and there and cross paths and go from baby to baby and baby to bench and baby to trolley. So there's a huge amount of activity. And so sometimes you find that the parents are obliged to wear hats and shoes and gowns and all of that sort of thing because they're regarded as so dangerous for the infection they might bring in. Whereas the reality is that the doctors and nurses are more of a risk because of their having contacts with multiple babies, and very often they don't feel it's necessary to cover their hair or their feet either. So those are some issues that generate lively debate during training. Next slide. You can't force anyone to pay attention to the facts. We have to make people want to seek them out. And how do we do that? Well, one way is to, next slide. One way is to think about very simple practical tools people can use that can help them. Björn referred to this, the EFCNI scale, which many people have found very useful. It's simple, it's very clear, it's very easy to do, and it has multiple uses. You can use it for audit, for teaching, for self-assessment, for all sorts of things. And that something like that has become quite popular. In the fine training, we have quite a number of these practical tools that can help people to assess their practice and at the same time learn through doing it. And they're often very acceptable to their colleagues as well. So that is just an example of the sorts of things that can be useful. Next slide. And the other thing, and Zilka referred to this morning, is the power of parents. And this cannot be underestimated. I am absolutely in awe of the work that parents are doing to promote education in different countries, education in infant and family-centered developmental care. I think, we're seeing from Greece and Hungary and Romania, Lithuania, Bulgaria. We're being asked from parent groups everywhere to be involved. Next slide. And I want to introduce a couple of those people here. Livia Nodge will be talking to you later on. So I won't ask her to join me here, but what she has achieved in Hungary is spectacular. And so the whole of the eastern half of the country, all the hospitals there have now had access to Fine 1 training, and they're now working quite well on the second level training too, which is really impressive. And the energy that Livia's put into this and her ability to persuade people, which is very difficult to resist. Apologies, Livia, but you are. It's very difficult to resist you, and that's one reason why you have been so successful. And we're shortly starting work in the hospitals in Budapest as well. And the next person that I want to introduce to you is Corina Croiteru from Romania. And I hope Corina is with us now. And if she is, I'm just going to ask her to talk about what has happened in Romania. Because when we started working together 2 years ago, there was a lot of muttering that said, mutter, 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 Romania isn't ready for this. But Corina has proved them wrong. So Corina, would you like to go ahead and tell people?
Yes, thank you very much, Inga. Hello, everybody. I am the founder of the Romanian Parents Association, and implementing Fine in Romania is vital with capital letters. You may be wondering why family-centered care is vital in a country in a country that is in top for infant mortality in Europe, a country where the needs for equipment are high, and it is a struggle to ensure even hygiene supplies. What is not known is that in Romania, the system of following up the long hospitalized babies is not well implemented. So that's why it's vital for those newborns to benefit from a care that takes into account their later neurodevelopment. My motivation in implementing the Fine principle in Romania comes from my own experience as a mother with premature twins, a mother who was allowed to hold her baby in her arms only after 724 hours, that means approximately 30 days. Even so, even after this very long time, I felt that it was this experience that saved both of us. Not the incubator, not the drugs, but the fact that I could hold my baby in my arms and become again one body from which to separate slowly. After 2 years of Fine implementation in Romania, in 4 maternities, the best thing that has changed is the role of parents. So our role has been called into question, that we no longer need to be visitors, but to be allowed to be carers, to be parents. The idea of caring for newborns, considering further neurodevelopment, was again an important and new idea for our doctors and nurses. These 2 ideas, supported by the Fine curriculum, have caused the Romanian medical system to change for better. The easiest to implement was the positioning of newborn in incubator. Progress has been made also on the level of light and noise in the NICU. The handling is smoother now, but this is a chapter where more work is needed. There is still work to be done on family involvement in the care of the newborn in NICU. During these last 2 years, also our capacity of our NGO has increased in terms of knowledge level. So our position has changed. The doctors report to us on a level of equality. We advise each other for the good of the baby. So thank you very much, Inga, for your work and for your inspirational team, for all our achievements. I also want to thank EFCNI for their advices on our long way, and also for creating such a supportive network. I'll fight for the future implementation in my country, and I hope one day we'll also have need gap specialists in Romania.
Lovely, thank you very much. And that's very much the point of having a step-by-step process is to move towards that, so that this work becomes sustainable. And that is a big challenge. Next slide, please. Next slide. Oh, these are some pictures from training in Romania. And next one.
Trebuia să le fi dat pe ăsta, dar n-am mai dat nici.
So it's very enjoyable as well as very productive. Thank you, Corinna. It's amazing what you have achieved. I'm been absolutely so proud to be part of that. Next slide, please. So I don't have a lot of experience of working in low-income countries, but I know that in, well, I think apart from Armenia and Nagorno-Karabakh, but I know that in some places it's big organizations that are doing a lot of work, and in sometimes it's just little organizations that are doing work. And one of those is BirthLink, and you see in this picture Kathy Meller, who runs BirthLink. She's the person behind it all. This is her. She's at Panzi Hospital in Congo, which is Denis Mukwege's hospital, where they've been concentrating a lot on breastfeeding and kangaroo care. But she's also been very interested in how we can bring education for family and developmental care to countries that are not well resourced. Next slide, please. So we have been working together on some very simple tools. So we call the program Supporting Family and Developmental Care in the Nursery. And next slide, please. And so she has developed slideshows and also kind of flip chart, books that you can flip over, which have very simple instructions and suggestions, and very simple, very clear diagrams. So you have very strong visual prompts, and they can be adjusted. The babies can be adjusted in these to fit different countries, different ethnic groups. And so these are designed really very much for beginners, but to bring out the basic principles. There are pages on environment, on kangaroo care, on pain management, on handling, lifting, communication with parents, and a whole lot of things. It's a very nice project. And if you want to know more about that, please do contact me and I can tell you about it and share some of that with you. Next slide, please. Evaluation is very difficult because this is not an intervention. We can't just easily measure babies who've had it and babies who haven't, because it isn't babies that get it, it's the staff, so it's indirect. So we have done some surveys in the UK using questionnaires similar to the ones used for NIDCAP research in several other countries, looking at these domains. Next slide, please. And what we found that the perceptions of staff who worked in units where there had been fairly regular courses at both levels 1 and 2. So I think about 20% of the staff had had some education, although the people who replied to the survey, 2/3 of them had not had it, but the idea was to find out whether they perceived there had been improvements in their unit overall since the training was introduced, and the results were very positive and highly significant. This was published in the Journal of Neonatal Nursing last April. But you can see that in terms of the infant's well-being and the infant's safety, and that's particularly important because the managers, they do want to know that making these changes are safe. The integration of parents into the baby's life, the environment for the baby, all of them were significant. The ones that were least positive where there were a few more people demurring, were in the effect of the environment on staff, and that usually, as usual, is something to do with lighting. And the working conditions was affected by, from the comments, we could see that quite a lot of those problems were to do with staffing levels and people not getting their breaks and that kind of thing. Next slide. We also asked people who'd attended the basic level of care, basic level training, whether or not they felt more able to involve parents in the infant's care after they had done the course. So, and again, as you can see, the green bars here, the turquoise bars here, show for 9 different activities that parents were involved in. That was a very significant improvement in how confident people felt about involving parents, and that's what we really wanted to achieve, so we were pleased with that. Next slide. So, take-home message then. One of the things we think it is very important to have a tiered pathway where people can progress at their own speed. If you're just starting out, you may only want to first do the first level. You may want to move on at different paces until you get to the expert level, but it's important to have a clear pathway ahead of you that you can follow, and that is regulated for quality as well. The big problem is going to be shortage of faculty, because as the FINE program is showing, the demand is growing enormously, and finding people at an advanced and expert level who can do the teaching, the coaching and the mentoring is going to be a big challenge. We do need to have more advanced training. Interestingly, in Hungary, we've started to use parents as faculty, which I think is really useful, because as they said to me, you know, you need to put your money where your mouth is, sort of thing, that, you know, you're talking about involving parents and this all being parent-centered. So parents need to be involved in the teaching, parents need to be involved in the attending the courses, and that is what is happening there. Also, you need to be able to fit the education to the context and the biases that predominate in certain different contexts, and also some of the political influences. So your training needs to have a degree of flexibility in order to do that. The idea of shared resources is a good one, and looking at how we can do that, how we can share our knowledge about internet sites and things that are useful, but also perhaps having a shared version, our own version of Wikipedia that people can look things up on. The evidence-based standards, I think, are a huge boost to this, very, very helpful. And then finally, you know, to keep thinking about how we can evaluate the value of education, how we can demonstrate that it is worth investing in this. So we need some more research. Next slide. So if there are any questions, I'm happy to answer. If you want to contact me, if you've got information to share or want to know more about some of the things I've raised, you can contact me on this email address. And I also send out a newsletter every quarter which summarizes recent research to keep people up to date on new research. And it also has other information about new developments, new resources, and educational opportunities. So if you go to www.earlybabies.com, you'll find a subscribe button and you'll get on the mailing list, and I'll send that out to you. Okay, thank you.
Thank you so much, Inga. Fantastic lecture, and very, very important work, and amazing the quick spread throughout the world. Actually, we have a question from Veronique in France. Inga, could you comment the slide with the Bliss survey? Did you understand that the professionals feel less comfortable to perform the care after the training? Were they able to reflect about the rhythm, or could you please?
No, they were more confident. maybe looking at it upside down. No, they were significantly more confident about involving parents in the baby's care, very significantly.
Yeah.
So it was appeared to be very effective in that way. Thank you if I didn't
And
make
these
that
kind
clear.
of surveys, they are methodologically not so difficult. So I mean, you can use them as descriptive.
Yes, they are, but I mean, it's just as a you know, in the ranking of evidence, surveys don't rank very high, and they're full of pitfalls. But it's very difficult to find another way to do it, unless you do quite extensive evaluations before you start training on a unit, train the whole unit, and then do it again. But unfortunately, that doesn't always happen that way. For us, it's trickling. You get 1 or 2 people do the training, and then 1 or 2 more, and so on. It's not, you can't do a before and after.
You can actually turn on your video, because so what about the yellow bars in the BLIS? What do you think about the yellow bars in BLIS?
In the BLIS,
here we go.
Okay, so
less able.
Yeah, those were people. The green ones at the very end were people who it was not applicable, but the yellow ones were people who felt less able, which is quite interesting. It was a small portion, but it was still somewhat worrying that anybody should be less able, and maybe that's because they then knew what they didn't know.
Exactly, that's what I think.
Yeah.
We have to realize that when you start training people in this, some will become very disturbed for what they have done over the years.
Absolutely, that is very true. And that's why with the second level in particular, when people are doing observations and really realizing that they've never looked at babies before and have never really understood the impact of what they're doing, it can be really quite painful. And that's one reason why you need really supportive mentoring.
Yes. Sorry. Very good. Sorry. Okay. Inga? Stina, should we continue or?
Thank you so much, Inga.
You're okay. Bye. Bye.
Guide us. Should we go?
Yes. I think we should. We sent out a poll.
Which, do you remember?
We have one more that is called poll number 10.
Number 10? That's one.
No, number 5. Number 5.
Number 5. Okay. So, have you had specific training? And here you can see different level. Fine level 1, fine level 2, NIDCAP training, close collaboration with parents training, NBO, newborn behavior observation. That's more of Brazelton based. And then the Brazelton training per se, and also APIB. So the NBAS and the APIB are more research tools maybe, but please tell us. And here you can see that approximately 50% had fine 1. That's fantastic, Inga. Congratulations. And as much as 31% has had fine 2. And 48% were NIDCAP certified. I'm amazed. So this is a very selective population, I think, the audience. There's close collaboration, 13%. That's also very good. NBO 10, Brazelton 15, and APIB 15%. That reflects that we have many NIDCAP trainers listening to this conference, I think. You are also a developmental psychologist, and you're head of the 0 to 3 Center at in Eugenio Emilia in Bosisio in Italy.
Parini.
Parini, okay.
Yes.
And I hope you're well in the northern part of Italy. You don't have any corona?
Yes, we have a lot of coronavirus around here because we live in Lombardia.
Yeah, but you are well yourself, I hope.
Fortunately, yes, I'm fine. My family are fine. Thank you.
Thank you. Okay, you have been so much involved in this area. You are one of the members of our topic expert group, of course, and You also have been involved in the scenes, or are involved in the scenes research group, and also in the close collaboration in the program as well. So, but your interest, as I have understood it, is main at the latest in the last years focused on neuroendocrine and epigenetic changes associated with early adverse experience. And so we are very eager to hear your thinking of how the bonding and so forth. So please go ahead. I don't know. Keep your video open as well, please.
Thank you. Thank you. I turn off because my internet connection is a bit unstable.
Okay.
So again, hello everyone. Thanks for attending to the meeting today. I would say that it's a stressful time, and as you know, in Italy, and not in Italy, most of the people is in isolation and separation have a possible psychological cost. For sure, this situation can have a negative impact on the mental well-being of many people. To some extent, isolation and separation put ourselves in the shoes of preterm infants and their parents who are very often isolated and separate each to other. Anyway, I keep thinking we should be able to do real life as lived, even when we are under the stress, as actually how preterm infants and their family do every single day at the beginning of their life. So I'm very happy with the decision to go on with the conference, scientific discussion, and get inspired by science. Because so I wish to thank Bjorn and Stina for not only for this invitation, but also for giving all of us a message of hope. Next. I'm grateful also to all the staff of EFCNI for efforts that has been done for the standard. Very impressive work. Needless to say that parental-infant bonding is a critical piece of neonatal care, but in typical developmental infants and the fragile infants like preterm. And today, I would like to discuss some points about this topic. Next, please. As you know, there is a strong link between parental bonding and physical proximity. These areas are quite interwoven, and I'm supposed that to speak just of skin to skin is rather reductive. But for mother and infant, skin to skin implies a multisensory stimulation, including the auditory, olfactory, visual, vestibular, and tactile stimulation. Maybe we can define this body-to-body exchange embodied interaction. Embodied interaction starts during pregnancy and the event of a preterm birth. And in the event of a preterm birth, this process may be disrupted, leading to a suboptimal bonding condition. While an increasing number of studies suggest that less than optimal bonding has a negative impact on several infant developmental areas, we have also lots of evidence about the beneficial role of early embodied interaction. Next, thank you. Many studies suggest that maternal infant bonding could be described as a co-regulation. That is, when parents use her skill to regulate the internal environment of an infant, homeostasis, as well as ourselves. There has been suggested several reasons for why homeostasis can support infant development in the context of the mother-infant relationship. For example, embodied interaction and interpersonal touch promote a quiet alert state and emotional regulation, which in turn promote cognitive and social emotional development. These are very good reasons for supporting early embodied interaction between mother and infant, but recent research suggests a new view for why embodied interaction could be so important for infant social development. Embodied interaction, physical proximity, and touch could contribute to the infant's bodily perception. The infant's bodily perception is the ability to perceive own body as separate from other entities and provides the basis of self-perception. In turn, this is crucial for engaging in social interaction, interpreting and predicting the thoughts, action, and the behavior of others. But what do you mean by the word embodied? And why use it? From a general point of view, it simply means involving the body. In other words, embodied depends on the body and the brain's processing and integration system for bodily signals. Embodied interaction are established at the very onset of our life, when a full self-awareness is not yet constituted. However, the absence of a self-awareness doesn't preclude the possibility of a rudimental perception of self. Next, thank you. In my presentation, I would discuss how the early embodied interaction could be related to the formation of the infant body self. I think it's a neglected area of scientific investigation. This is a bit surprising given that, as Biomaster has claimed, the self starts with the body. In fact, human experience is basically a me, which resides in my body. The feeling that experience are bound to the body and our experience of a unitary entity is considered to be one of the most incredible features of the human beings. I will overview, given that the multisensory integration is considered to be a central process for bodily self-perception, I will overview of the topic from a developmental perspective. I will also discuss the role played by the maternal touch in multisensory integration, and finally, the contribution of the maternal body in this process. Before I go on, let me make a clarification. Of course, most of research about the formation of infant body itself involves full-term infant. Thus, caution needs in the standing of this result to preterm baby. However, I think that the research about the formation of infant body self in full-term provide us several elements for understanding how much the early embodied interaction is important in this diet. Next, please. As I have mentioned, multisensory integration is the process with information from the different sensory modalities to be integrated by your nervous system, which underlie the bodily self-perception. But what about the multisensory integration and body self-perception in infancy? Next. While there are no conclusive findings about the exact time of emergence of the sense of body self, recent study indicates that processing of information from the body begins during the first year of life, and more likely a process that starts in utero. These studies on the ontogeny of human body perception in infants suggest that no conceptual form of bodily self-awareness, a rudimental sense of self, is already present in the first month of life. The formation of bodily self is hypothesized more by information. Physical contact would facilitate multisensory integration. All this suggests that during infancy, the bodily self is dependent only by maturity. It depends upon relational experience of body-to-body interaction, that is, embodied interaction. Next, please. Before the next slides, please. Okay, go on. Thank you. Before I go on with some evidence about the multisensory integration of body-related information in infants, let me say something about more general somatosensory processes related to the body perception. To some extent, the body is the most multisensory object in the world. In fact, the body perception requires the processing and integration of different bodily signals. Here you can see the classic schema of somatosensory inputs, which include, for example, perceptual information, such as a visual auditory input, but also internal information through an interception. That is the sense of physiological in adult, all this information in adult is integrated with body memory. But before I go on this, what we can say about self-perception in infants? Next, please. Next slide. Okay, thank you. That is, has infant's brain the feature for being conscious? Functional magnetic resonance imaging of the newborn brain show highest activity in the somatosensory, auditory, and visual cortex, but lacks activity in association area and the prefrontal cortex as compared with adults. Also, findings of a big project about the connectoma suggest that a normal term age, a complete set of all
You disappeared there. You disappeared. The connection was bad. Try again. We can't hear you, Rosario.
Can I go on?
Oh, we hear you, yes.
Okay, please press a button. Okay, perfect, thank you. Overall, this finding seems to suggest that newborn brain have structural and functional organization which could support a sense of a body. Based on this kind of evidence, Professor Lagernkratz, that all has suggested that newborn brain has several features for being conscious, aware of itself and the environment. And infants can feel and integrate multisensory, several multisensory modalities. Next, please. Of course, bodily sensations are associated with the need of regulating homeostasis and the behavioral drives that are necessary to maintain the integrity of the body. But through self-exploration and perception of a contingent sensory motor information, infants learn what belongs to their body. This seems to suggest that human newborn have a basic sense of self, a rudimentary distinction between representation of their body and those of other people. And as I have mentioned, press button please, before, in this process, the key role is played by the integration skills. So let me show some example of this skill in infants. Next, please. Here you can see a very nice study. Authors examine the looking behavior of newborn presented with visual, tactile, synchronous and asynchronous cues. In the synchrony condition, the newborn was touched on the cheek with a paintbrush on the congruent location, and the stroke perfectly matched the brush stroke. The infant's corresponding cheek displayed on the screen. In the out of synchrony condition, the newborn was again touched on the cheek, but the tactile stimulation was delayed with regard to the brush stroke displayed on the screen by 5 seconds. In the first hour of life, infants look longer at the video of another newborn face if it is stroked by its brush when their own face is brushed in a synchrony way, rather than in an out of synchrony way. Importantly, this preference disappeared in both conditions when the newborn look at the infant's face in an inverted presentation. This finding suggests, in other words, that intermodal detection of synchrony provides important information allowing infants to differentiate themselves from others. And this finding supports the hypothesis that the human newborn have a basic sense of bodily self. Next, please. Of course, the infant's brain is not mature. Thank you. Now, Stina, you should go step by step pressing the button. I will say, okay, it's fine. Okay. Of course, the infant's brain is mature enough for a complete multisensory integration, and recent studies suggest that the development of this process is not predetermined. It becomes increasingly more specialized with experience, and a very interesting thing is that, along with other processes involved in brain maturation, early embodied interaction and interpersonal tactile stimulation could be implicated in integrating information between modalities. Here, you have an example of this. 8-month-old infants heard pseudo work, but while they were tactile, that is multimodal audio tactile condition, and non-tactile, that is unimodal audio condition. After this phase, please press the button, brain activity, EEG, was measured during the perception of the same word. The results highlight that compared to the audio condition, the audio tactile condition was associated with the higher brain activity in the left temporal region and in the middle frontal region. This is a neural evidence that a multimodal condition, which include touch stimulation, supports higher brain activity, press button please, possibly by integration process. Results like this offer evidence that the multimodal interaction between caregivers and the infants in a natural context might contribute to binding several forms of information in infant's brain. Next. We have just seen that the integration of exteroceptive signal play a critical role in generating our sense of self. But recent studies suggest that integration of interoceptive signal is also crucial for bodily self-perception. Importantly, interoception is strongly associated with touch stimulation. Let's see in which way. Next. First of all, I would say something about interoception. Interoception involves the detection and the processing of several multi-signals from the body, such as temperature, age, pain, cardiac signal, respiration, hunger, and touch. It is defined as the sense of internal state of the body. In adult, this sensation are thought useful to maintain homeostasis, to infer emotional states, and also to provide a sense of self. In other words, interoception has been associated with the generation of subjective feelings and self-perception. Please, next. Of course, but what about next, please? The first point about the role of interception in early infant development is to establish if young babies perceive internal sensation from their bodies. This study provides evidence about this possibility. Meister and colleagues have developed a test which can measure how sensitive an infant is to their own heartbeat, and one of the signals from interception system. During the task, 5-month-old infants were shown an animate character that either moved in synchrony with their own heartbeat or out of synchrony with their heartbeat. The infants spent longer looking at the character that was moving out of synchrony than the one moving in the synchrony. Please press button, suggesting that even at this age, early age, infant can sense their own interceptive signal. The next one. Thank you. Interception has been linked with insular cortex activation. Importantly, this brain region is strongly involved in the regulation of homeostasis and in the somatosensory perception with respect to pleasant tactile stimulation. Furthermore, it has been hypothesized that anterior insula integrates sensory signals and body schema network, which involve different cerebral area, such as parietal and the frontal region, creating a neural representation of the body into an embodied form of self-awareness. Next, please. Insula does a lot of things, and a very important aspect of insula is that is also involved in the empathy and in the interpersonal bonding. Together with the cingulate in the frontal cortex, the insula is active in the stimulus situation of empathic recognition of others' emotional experience and in the processing of emotional bond. Press button, please. Thus, Stina, thank you. Thus, insular cortex could be the neural hub for the integration of somatosensory information and social perception coming from the outside with interoceptive inputs functional to body homeostasis. So you can see, you can imagine how much important is this area, this brain area for mothers. Mother use this area for recognize emotion of their baby. So it's very, this activation, this area, the activation of this area is very linked to emotional, to bonding. Next slide, please. But of course, one can wonder if this cerebral area is active, present during the development. And actually, it is amongst the earliest cortical region to develop, and it is at an advanced maturational stage from 27 weeks of gestation. This indicates that the insular cortex could have an early involvement in the elaboration of somatosensory stimuli at an early maturation level, to which the fetus and the newborn are exposed. At this point, I'm sure all of you are confused. In fact, one can wonder which is the link among interception, insular activation, touch stimulation, and so on. The link is the C-tactile fiber system. Please button the next slide. Next slide. Recent neurophysiological studies have documented the existence of two dual touch systems consistent of two neural pathways, one subserving discriminative touch and the other affective touch. When we are touched or we touch somebody, the stimuli is processed in terms of its exteroceptive discriminatory information content via fast conducting peripheral nerve pathways reacting to primary somatosensory cortical areas. However, an increasing body of evidence is establishing that there is a specialized submodality of touch sensing and processing its affective properties. The latter is encoded and processed by a specific fiber called C-tactile afferent that respond optimally to the gentle caressing touch, typically of nurturing care. The C-tactile afferents project mainly to the dorsal posterior insula and to the brain network involved in the social perception processing. Despite this dual tactile response to lesion touch clearly assume a particle valence in the interpersonal relationship. Next, even more interesting, C-tactile afferents are sensitive to temperature, discharging to skin temperature stimuli. Also, C-tactile fiber optimal firing response to gentle skin shocking is between 1 to 110 centimeters per second. I would like to draw your attention to the fact that this stimulation feature corresponds to self-reported pleasant perception of touch, leading to the hypothesis that these fibers have evolved in all social mammals to encode the social affective and rewarding dimension of the touch. Only, but even more important for us, this speed is exactly the speed that parents use when they gently stroke their babies, 110 centimeters per second. Not more than, not less than the speed range. In adult, gentle touch leads to widespread activation of a network of brain regions which comprise area involved in social perception and social cognition, including insula. But one could wonder, is there evidence that gentle touch leads of insula in infants? Next, please. Although the research is at the very beginning, recent neuroimaging studies targeting the insular and the somatosensory cortex in 2-month-old babies report that slow stroking compared to fast stroking activate insular cortex. In a couple of studies, one using an infrared technology and the other using the fMRI, researchers have examined the influence of touch on the brain of babies aged about 2 months. The researchers found that several areas of the brain respond to stroking, but the insular cortex was particularly involved when researchers struck the infant by a slow touch stimulation that is between 3 and 10 centimeters per second. Thus, we have evidence that gentle touch sensors are virtually active from birth and maybe before. And this mechanism seems to work in young babies in a like adult equivalent manner, that is, by the insular activation. Next, please. These findings are fascinating, and using the same experimental design, it would be nice to examine if insular cortex is also active in preterm infant. That's exactly what Eleonora Mascheroni, a young colleague of mine, is conducting at my lab. Last year, she won a starting grant of Italian Ministry of Health, titled Skin-to-Skin Contact in NICU, Caregiving Touch and Neuro-Related Slow-Stroking Touch Stimulation in Preterm Infant, MRI study. The main idea is to examine potential links between the skin-to-skin experience and interaction in NICU and brain activation associated with gentle touch. We have just started a couple of months ago with a few of filter main from the control group. So I hope we are able to show you our results soon, let's say at least after the coronavirus outbreak. Next, please. At this point, what could we learn in infant body cell perception? Let me show this, just to clear up some points. First, we have seen that infants have the capacity to perceive their own body, for example, using multisensory integration. Second, it's unlikely that this skill depends only on a neuromaturational process, but rather is integrated by body-to-body connection. Third, interpersonal touch is processed by C fibers and by the brain area they project to insula could support the perception of the infant body self. The next one. Let me say something more about the bonding at this point. We know that mother and infant synchronize their body during embodied interaction. That is during tactile stimulation and physical contact. That is during tactile stimulation and physical contact. Of course, this body attunement supports infant adaptation to life outside of the womb, promoting a better regulation. However, the importance of early embodied interaction could go well beyond this aspect. Francis McGlone and I have just written a paper in which we posit that embodied interaction could assume a specific role on the perception of the body in infants. Specifically, touch could enhance the early subject feeling of the body, supporting multisensory integration and facilitating the interoceptive sensitive in infants. The next one. Thank you. When we speak about bonding related to skin contact, I think it would be reasonable to treat an additional point, the role played by the mother's body. In fact, if we agree on the importance of a body interaction, then we needed to consider it and not only focus on the infant's body. In other words, it will be of interest to understand what is the contribution of the maternal body in this process. The next, please. Of course, the idea is not new. For example, the role of maternal body has been considered in the Kelman cycle theory by Welch and Ludwig. This is just that earliest emotional relationship between the infant and the mother begins in utero through subconscious co-conditioning of the pair's autonomic nervous system. Such very early autonomic learning between mother and infant is the primary factor that help the infant form emotional relationship with others. Autonomic learning serves not physiological and behavioral autonomic co-regulation between the pair that triggers various subconscious. The next, thank you, the next one. Common single theory process proposes several ideas that advance our understanding of embodied interaction. For example, the idea that the mother and the infant co-regulate one another visual oxytocin level, show a Pavlovian condition mechanism of the gut. However, the theory does not include the recent findings about the role of C-tactile fibers and of the maternal interceptive sensitivity. For example, maternal tracking is not only tuned to the stimulation of C-tactile fibers in infants, but stroking velocities, stroking speed is significantly correlated to maternal interception as measured by heart rate, suggesting that maternal affection-matched behavior may be moderated by some aspect of maternal interception. Also, the mother's ability to perceive, thus the mother's ability to perceive her own internal signal might further support the responsivity to her infant's cues. And we have in some indirect evidence of this possibility. The next one. In this slide, you can see findings from the first study in which researchers have examined interception sensitivity in the parent's brain. Feldman and colleagues used the fMRI to examine whether interception sensitivity in the parent's brain during the first months of parenting combines with sensitivity in parenting predict children's somatic symptoms 6 years later. Here you can see the greater activation of the parent on the, on the right side of the slide. You can see the greater activation of the parent anterior insula in the first months of life was associated with lower child somatic problem at 6 years. So the scatter plots show significant negative correlation between activation of the parent anterior insula in time 1 and child somatic symptoms in time 3 when the child was 6. Authors speculate that the early embodied interaction could promote in the child a subjective awareness of emotional states and body perception, which may reduce the likelihood of the child's being on the somatization continuum, ranging from middle body misperception to severe somatoform symptoms. The next, please. Thank you. At this point, one could wonder how these findings and this view could inform the skin-to-skin practice with preterm infants and their mothers. Before I go on that, please let me show a couple of things more. Please, the next one. It could be this. Assume that the suboptimal bonding could have an
Rosario.
Yes. Yeah.
Take from go from here. We didn't hear you.
Okay. Start again.
Yeah.
Okay. okay, we assume that the suboptimal bonding could have an impact on body self-perception in preterm, but do we have any evidence to support this? Recently, my colleague and I have tried to get clarification on this point. A group of school-age children born preterm without neurological outcomes was assessed by a visual body recognition task. I have no time to explain the task, but the result is, compared to the full-term children, preterm children showed alteration in body representation at the levels of body visual perceptual processing and of the body schema. We have no data about the early skin-to-skin contact in this group of preterm, but overall, our findings suggest that even after several years, children born preterm could have some kinds of difficulties in the body-related information processing. The next one. On the mother side, suboptimal bonding could have an impact on the mother's skills in the processing the infant body signal. Yes, we have some result about this. We have explored the association between maternal sensitivity and the maternal visual perceptual process in perceiving the infant's body, but in mother of preterm infant and mother of full-term infant, when the infant were 6 months old. Again, I'm no time to explain the experimental design, but I want to tell you just the main result. Mother of preterm infants had less refined maternal perception of own infant's body. This finding suggests, please press button, Tina. This finding seems to suggest that less than optimal early and body interaction can affect the implicit maternal knowledge of the infant's body, which in turn can affect the maternal perceptual processing of infant body. Next. In sum, there is evidence that suboptimal bonding in preterm diets could have a long-term impact on the body-related information processing, in body-related information processing, both in preterm children and their mothers. Again, how these findings could inform the skin practice with preterm infants and their mothers. Of course, there are many aspects that we could consider here, such as, for example, maternal tactile biography or maternal beliefs about personal touch. But I would like to remind you the findings of studies which have inquired the link between interoception and empathy in general population. The first neuroimaging study found that interceptive sensitivity enhanced neural activity during empathy in anterior insula. Not only, but it is also been documented the link between interoception sensitivity and empathy. Therefore, focus on parental interoceptive sensitivity in early and body interaction offer a new perspective for promoting contribution that mother's body could provide in infant body self-development. In fact, if maternal empathy were, at least partially, associated with the accuracy with which mothers perceive their own body signal, then maternal interoceptive sensitivity might facilitate parental inference about infants' physiological and emotional states. Of course, press the button. As a consequence, it could be important to promote the mother's ability to perceive her own internal signal during skin-to-skin practice or embodied interaction. So the maternal awareness of our own body is incredibly important during the skin-to-skin. Next, please. I'm at the end of my talk. but let me say a couple of things more, very, very quickly. Next, please. I would like to conclude my presentation with some speculation. I like to think that the experience of being touched might be linked to the discovery of Owen's own body by the interpersonal gentle touch provided by caregivers, not only by parents. So I like to think that each time we touch, you touch, in gentle way a preterm infant, we are promoting a special form of neuroprotective care, the infant's ability to form accurate representation of bodily sensation. In other words, how, when, how much, and where the caregiver touch infant could sculpt the sense of infant body self. I also link to think that embodied interaction not so only support well-being and growth in preterm infant, but it co-creates the infant's body self. The next, please. In fact, I have tried to show you that early embodied interaction is much more than co-regulation. Press button, please. The start point of this could be summarized with the Chanukka words. Chanukka suggests, before an infant meets mother mind, the infant meets mother's body. But, please, the button, again, one more. But the contrary is equal true. Before mother meets infant's mind, mother meets infant's body. So bodies come first. And along with several other interactive processes, embodied interaction make embodied meaning within and between individuals, which increase the coherence, complexity of each infant, and likely parent's sense of body self, establishing reciprocal awareness. Next one. As I told, this is a bad time, but maybe it turned out to be an opportunity, the more solution, the more wish to be in touch among people. I hope this wish will be strong even after the epidemic will be over. Thus, beyond the coronavirus, I wish you always to have nice affective touch during your interpersonal life. And thank you for your attention.
Well, thank you very, very much, Rosario. I'm always so intrigued by your scientific views of these very important natural things. And I thought it was quite comforting that you said that the insula has an early maturation, as early as week 27. And
yeah.
That, I think was very comforting for us, that we think that early skin to skin, even in the immature babies, are important. Also, yeah. I remember the first time I sat skin to skin with my first child. I would like to ask you a question. Don't you think that also that experience actually could mature my insula, even if I was 26 years old or something like that? Are there hopes for us that have not had that good maturation of our insula because we have abusive mothers or others? Please comment.
I agree, and but the point for me, the point is not the infant body, but the embodied interaction. We are too much focused on the infant body. We need to have a wide view. And we need to include in this interaction the maternal body and the sensation, the feelings, and what the mother can do with their own body. The awareness of personal sensation, feeling, it's crucial to permit the diet to biosynchronous each to other.
Yes. And I would argue that it also can happen in males, in fathers. And also, even if you're old, almost 70 years old, I still hope I develop my insula.
In fact, the touch is the first sensory system, but also is the last one.
Ah, thank you.
So we can
thank you.
go.
I will tell my wife.
I will tell my wife. But yes, I'm getting old. My hope is that my touch fiber can work until my death. Thank you.
Thank you. Gives me hope.
Rosario, I have a question. Often we hear staff say to parents, and it's probably right, when we observe babies and preterm infants and you touch them a lot, they get overtaxed and they have aversive behaviors. What are your comments on that?
You know, there's a nice study from Fabrizi. It has been published a couple of years ago. And in this study, the team, the researcher, showed that there is the possibility that even the touch is very painful for preterm baby. So we use static touch instead of stroke. But anyway, I think that it's not important only the stroke, but it's important the skin to skin, the sensation, and the maternal is like a multi-integration process for the baby, for infant body. This is very important. We are integration. Our brain integrates the information. So we needed to understand that the infant brain, even in so fragile baby, the brain continues to integrate the information. And the most important information comes from the maternal body.
Okay, Rosario, do you have any questions thinking about the dose of skin-to-skin contact? I was thinking of the studies that Mirelius published when she compared with the group of parents with 20 hours skin-to-skin per day compared to 7 hours. And at 1 month of age, the high dose group showed less stress reactions. So that indicates that KMC, including close parental contact and human touch, has a buffering effect on infant stress reactivity. So that was saliva cortisol study. And Livia, Inga mentioned you and already showed pictures of you as a family, a parent of a preterm baby, and apparently you were living in Hungary by then. Now you moved to Switzerland, but still you are very much involved in the activities in Hungary, and we are very, very grateful for that. And as I understand, you also have a professional experience of a pediatric cardiac intensive care unit, and that's very challenging environment, of course. You have been very active in the EFCNI from the very start. You're also extremely active in the GLANCE project. So please, Livia, tell us about your experience. The floor is yours.
Wait.
So far, it is just with Stina because I have a Wi-Fi that we are going to turn down my video. So yeah, it's turned off. And because maybe you remember a few years ago, there was this home office CNN guy who was giving an interview, and then all of a sudden his little daughter was coming in while he was giving an interview. So you must know that we are I'm living in Switzerland and in the border of Switzerland and France. So we are locked down for 3 days now. So in the back of the door, I have 4 children who is stressing me that they're going to arrive in the worst moment. And I'm trying to put on the screen share my presentation. So it's an ad as a stress. So you must know that my husband is in my back, so he was helping me. And if we would be, if you would hear me, I would ask you for clap for him, because he is the one who is taking care of my kids for the whole day to be with you. And he's doing homeschooling and then cooking and then taking care of them, plus my son who is multi-handicapped. So he is really multitasking in this moment. Yeah, thank you, Björn, thank you. Hungarian experienced NICU parents can initiate changes. Well, as you really good mentioned it, as I'm a Hungarian born in Budapest, but 16 years ago I got married to a French guy. This is my family celebrating Mother's Day in May 2005. French daddy, Hungarian mom, and the 7-year-old little girl. We lived happily as a perfect European model family. And then we decided to have a second child. In Christmas 2005, I got the most beautiful present, the ultrasound result, which revealed that I was pregnant with a little boy. It was a happy and relaxed pregnancy. I was a dream for every gynecologist. A 31-year-old mother who did not smoke, didn't drink, with a previous healthy pregnancy, and natural, uncomplicated birth. In the 25th week of my pregnancy, my gynecologist authorized one last flight to let me visit my family in Budapest, Hungary. But two days before I returned to France, I got sick. First, I had a headache, then my legs and arms got heavy and swollen. All of a sudden, I was feeling extremely tired and dragged myself into the closest hospital. I had preeclampsia. Until that moment, I had no idea about preeclampsia at all. I have only vague memories of the next 14 weeks, what happened. And I remember well the emergency doctor who explained to me, to my frightened husband, that 1,300 kilometers away from us, on the phone, that was happening to his wife and his unborn son, and that they would have to deliver the baby immediately. My son was born on the 27th week of the pregnancy with 890 grams. I remember the moment when my son was born and I saw his tiny feet and the neonatologist running away with him as he had no signs of life. And I will never forget the moment when I woke up in intensive care and the pain I felt when I realized that this was not a bad dream, this was the reality, my tummy is empty. My husband rushed to us from France. I will always remember the first time we met our son around 24 hours later after his birth. I tried to prepare myself for the sight of my son, but you cannot prepare for this. 5 days after his birth, the hospital released me and I had to leave my baby there alone. I was devastated. At the same time, my husband had to go back to work to France and took with him our then 8-year-old daughter on the day of her birthday. So I stayed alone in Budapest. The NICU door will haunt me for the rest of my life. I was afraid of what was waiting for me behind that door. For the next 14 weeks, I stood in front of that door twice a day and pressed the bell. Why would they open quickly, or would I need to wait? If I have to wait, was it because something was going wrong on the other side of the door? Was it my son? I insisted on calling the NICU every morning at the same time. And as Mandy mentioned it, every day I wrote down every little detail on his baby journal and also added one photo for every day. It was really important for me. If anything is happening, I need memories. I need to prove his existence. Often I found myself not looking at my baby, but the monitors. I try to think that this is not my son to avoid getting too attached to him. I did not want to feel any pain if he would not make it. Although everybody tried to convince me that I had to be happy as I survived, I blame myself for his premature birth. I felt invisible in the hospital. Doctors, nurses were overworked and did not have time for a mother who was depressed. I had no psychological help at all. There were 6-7 incubators for one nurse and 1-2 neonatologists every shift. At that time, I was confident and felt that my baby was in good hands. I had no choice. I couldn't even compare it with anything. Never, not for 1 minute, I questioned that my son and I did not receive the best treatment and care. Now, in hindsight, I know how dangerous this situation was. Every day when I walked into the NICU, I only watched incubator number 23. I was mom 23. The doctors came by, often said some cliche like, my favorite 2 steps forward, 1 step back, and then they left me alone. The visiting time for each child was 20 minutes, 2 times a day. I remember the exact day and the exact hour when my son started to breathe without any machine. And that moment, he was born the 2nd time, but I wasn't there. They told me on the phone. The moment when I could hold him in my arms for the first time is equally unforgettable. He was 12 weeks old. Then one morning, they told me I can take my son home, and all of a sudden, he was lying there next to me in the bed, a little 2-kilogram baby who was on monitors only a few hours before. I felt completely incompetent and did not dare to sleep for weeks in a row. I had to watch my son during the night, always checking, is he still breathing? After my son got out of the NICU, I felt many things, but I missed the most important feeling. I did not feel like his mother. I felt more like a nurse, as Mandy mentioned also this morning, and did not let anyone near him. When I fed him, I was wearing the green NICU uniform and mask for weeks. It took another 2.5 months until we both could take a flight to come home to France. You cannot imagine the financial burden. For nearly 6 months, we paid 2 household charges, taxi fees, phone, internet, flight tickets, which had absorbed all our reserves. And if you think the roller coaster got easier, usually us parents, we are describing this journey as a roller coaster, what we having in the NICU. We learned that the French and the Swiss social system is extremely weak, and without enough information and a good advisor, you can slip out really easy from it. During follow-up, nobody took my worries, my comments seriously. My son's development was extremely slow. After 2.5 years of pleading for an MRI, they finally gave us a diagnosis. My son has PVL, profound brain damage, equal mentally and physically disabled child. Our son became a fantastic little boy. He's a 5-6 years old child who lives in the body of a 14-year-old boy. Now he's 14. He was 14 last week. He walks, he's happy. He speaks 2 languages, French and Hungarian. He has his own friends. And he is the only boy and enjoying every attention of his 3 sisters. But he cannot change his clothes. He's not able to write or read. He will never be an independent adult. He will always need someone around him for 24/7. Every year, more than 8,000 newborns begin their lives in different levels of need throughout Hungary. The pillars of family-centered care are absent from numerous units. One of the most significant is the access for parents and their involvement in the care of their children. My story is not special in any case. The past 14 years learned a lot about the neonatal practices of domestic and international level, and being part the development as a parent advisor at the EFCNI Standards of Care project, which I'm extremely proud of, and I'm so honored, and I cannot thank enough to Silke and her team. Now I dare to say out loud, my son did not get the best practice in Hungary, and France and Switzerland failed during follow-up. Was he the unfortunate little boy who was born in a wrong country, in a wrong city, or in a wrong NICU? No one knows whether my son would be healthy if he was born in France or Switzerland. But 20 minutes visiting time twice a day has definitely not helped to let him thrive. He couldn't benefit from skin-to-skin care. Not at all. He wasn't breastfed because I lost my mother's milk after 2 weeks. These may seem simple things, but we know for a long time that these are the things that contribute to making a difference. Because of these differences in care between countries, but even between single hospitals, I started to work voluntarily as the very same NICU still until last year. Continue the harmful practice and give limited time to visit for parents. Couple of hundreds of meters away from that NICU, in the same city in Budapest, 2 other NICUs working 24/7, giving 24/7 access for parents. How is it possible? How can we let such differences happen? How can we provide the best possible care for such vulnerable little children if there are no widely accepted regulations? The first time when Hungarian healthcare professionals heard about the FINE program was in February 2018, when our association organized the 4th Global Summit for Preemies in Budapest. 17 months later, all neonatal units at the east part of Hungary have taken part in the first level of training of FINE and are embarking on the next stage. I think this achievement has been the result of desperate parents as they joined forces, regional parent organizations, as we had similar experiences and still a need for more infant and family-centered care. We got huge support from healthcare professionals, doctors, nurses, and most importantly, hospital directors. Without them, we couldn't make it. For the financial part, because the eastern part of Hungary is the most poorest part of the country, so these regions could get an EU grant. So with this EU grant, and with Miskolc, which is in the north part, who is not part of this region, so they couldn't benefit from the grant, it's GE who helped us. And they heard it really quickly that if they're going to help us with the finance, then all the eastern part of Hungary can have, and they will be in the same and equal training. In June 2019, a few months ago, at the Young Neonatologist Conference in Hungary, along with Professor Jacques, Inga made a summary about those 17 months of experiences she worked together with the Hungarian nurses and neonatologists. Jacques gave an insight about experiences working as family-centered care unit in France, the challenges and how they climbed those mountains to make it work. And Inga summed her experiences hard but hopeful. FINE is evidence-based, but lack of access to information, most of which is only available in English, has made it hard for mostly nurses to understand those evidences. So with my fellow parents, all the materials, PP presentations for this training be translated into Hungarian and have been reproduced. I hope that it's a high quality, they are high quality books. I still remember the stress I felt when Inga made the declaration, I need you parents to do some presentations with me. Thoughts were running in my mind. The nurses, but most importantly, the doctors will question our competence level. How we will make it through the day? They will leave in the middle of the training. Inga was very confident, and to my surprise, it worked. We really are true experts on the field and began to take part in the teaching, not just as translators, but also as teachers. She gave me the pain management part, the first part of pain management. And I would say that all of the experiences what I had with my son, the nurses understood really quickly that how is it important to do some protocol regarding pain management. So this is the map of the country, and then you can see the east part is trained now. And now we started to discuss it with the president of the Hungarian Perinatal Society and with Inga to do a research to make comparable studies that how it's working on the, to make a study that after the training, how the NICUs are working, comparing those NICUs who haven't done the trainings yet. Despite low staffing levels and varying space, some units are old and cramped, while others are new and spacious. The response across the region has been enthusiastic, and we are already hearing about taking steps, spreading ideas, for example, good positioning to make children more stable. And as I mentioned you in pain management, the hardest challenge is still the inclusion of parents in baby care. Restricted access is often justified by fear of infection, as Inga mentioned. But we had several Hungarian units, Debrecen, Veszprém, Miskolc, that set a good example, as also Inga mentions, with the pioneers, despite limited space, making parents welcome, supporting opportunities for them to participate in their baby's care and to be close to their baby. These units do not demand the parents be completely covered, but they do have high standards of hand hygiene. 11 units are given unlimited access to parents out of 21 level 3 NICUs, which is a huge success, I would say. When we started to work with the association 4 years ago, we had free family-centered care in Hungary. These units made extremely good work, a lot of adjustment and change in their daily routine to make it happen. Observing babies, the level 2 FIND program started a bit difficult, mostly because all participants lost in translation. At the end of the course in Debrecen and Nyíregyháza, Inga adjusted the program, so the second FIND level 2 training, running currently, much smoother than the first one, and normally had to finish it next month. Well, now we know that this is not going to happen, so it has to be delayed. During 2019, last year, the association made enormous lobby efforts within healthcare politicians to implement the European standards of care, to get evidence-based supplementary training for the professionals, and to get their support to achieve 24/7 access to every NICU in Hungary. The family-centered care, nutrition, and patient safety topics from the standards are in line with the aspiration of the Hungarian government. Standard would have fast and visible positive effects on the Hungarian premature care. We had been invited by Dr. Yes, you can see Dr. Ildikó Horváth, she's the Secretary of State for Health, and then Gabriella Babini-Sotfried, she's the President of the District Nurse Division of the Medical Association. And we had follow-up meetings with Ildikó Lelkes. She's working as head of health policy department, head of Department of Family Policy, and Sebastian Bea, she is the head of the health policy department from the Hungarian Ministry of Human Capacities. In the meantime, Budapest in November in 2019, we hosted with the Help with Semmelweis Unity the 7th scene symposium. And of course, with support of EFCNI. And the symposium was a success. We had 125 researchers from 24 countries, and had Hungarian health politicians were sitting together with the researchers and saluted all our efforts to implement the standards and assured us about their continuous support. And then by all of this work, this is what I think the biggest achievement, and this is my take-home message, that yes, parents can make the difference, as because by the end of the year, the Hungarian government announced the family-friendly obstetric program grant to support for family-friendly, family-centered obstetrics, newborn and premature intensive care with integrated infrastructural and equipment development and training programs, as well as the strengthening of programs to prepare expecting mothers. Within this governmental decree, you are listed as FIND training and family-centered developmental training. It's written FIND program. So the government is financing for all of the NICU who applied for the grant. We had the association help the head nurses and NICU chiefs to achieve a successful participation at the grant procedures with all of our best knowledge. They have time and financial support till the end of 2021. And the first trainings will be held at the Semmelweis University NICUs, all of the three of them, 2 maternity NICU and 1 surgical NICU, and one of the maternity NICU is my ex-NICU, which a few of you already visited last year. I think we were in the right time and the right place, and I'm so proud of our team. We were a few people at the beginning, and throughout the year we became a huge, strong team where parents are equal partners with the healthcare professionals. Thank you for your attention.
Wow. Fantastic, fantastic, Livia. It's amazing. You're so right. When you have this strength of the parent organization, I think that really makes a difference. Thank you so much. You are teaching us and inspiring us. I wish we had the same support in Sweden. I mean, we have done a lot here, but we don't have that much official support, actually.
I'm always thinking about what I think that the most of the success is coming that we had really challenging experiences. All of the parents who became extremely involved to make it. So I think that's the key. That we were extremely strong and we were negotiating hard.
Well done. Fantastic. Did I get you right that you had support from the obstetrics as well now? Do you think the couplet care could be implemented in some way?
It is in there. It is in there. So
but if you have the support now with the obstetrics, maybe in 5, 7, 10 years, you can go there.
I think that they have to be a little bit quicker because they get awful lot of money and they have to prove how they spend that money. So now they are restructuring maternity and obstetric parts, also not only the NICUs. And the second step is, because we were fighting for this, we told them that, you know, that especially the politicians were thinking that, okay, if we are going to make or decorate or cleaning or making it bigger, so then it's going to be more family-centered care. And then we told them that this is not going to make a change, only because the wall is just going to be purple. It's not going to make any change. Maybe somehow the parents are going to feel better, but most importantly, the mentality and about the approach, and they need more, especially in the NICUs, they need neurodevelopmental care. So I'm extremely, extremely grateful that you let me in to learn from you and learn about, maybe, as I'm always saying, that I know that Antoine couldn't be, I don't know if he could be healthy if he was born in France or Switzerland, but it's, I've been in the other side of the bed. So I know how we worked as nurses.
But one paper that we published 10 years ago was that we actually reduced the length of stay by 10 days in the intensive care units if we had the mothers living in units. So there is actually an incentive. The mothers needs to stay somewhere anyway.
Yeah.
So this is why we argue now in the developing countries, and the WHO, I'm sure, will issue a new guideline recommending zero separation with this mother NICU concept. Mm-hmm. And so before you redesign and argue that you should put the mother's bed closer to the infants, and as close as possible, of course, and they could save money. From my experience, and we have seen this also when we studied the stress regulation, the reason why we could reduce the length of stay when the babies were mostly critically ill was because the parents could buffer the stress challenges of the infants in this phase. Because we have much more nurses per mechanical ventilator than you have, but even so, the parents can make very much big difference, I think.
Yeah, but as you started to speak about couplet care, I mean, I would be extremely happy if parents, both mother and father, could have access to their children. But in this moment, they have to ask for access and they have to ring at the door. And we still have in a lot of countries this issue. I know that in my country, we still have these issues that they have to beg to see their children. They cannot even touch them.
But maybe WHO will issue a new guideline in a year or two so from now.
I'm extremely happy if they will follow those guidelines.
I hope so. I hope all Sweden will do that, because we don't have couplet care all of Sweden, not even at Karolinska for all babies yet, still. So Stina, please, now you can read about Charlotte, and of course she's Swedish, I would say. You haven't been living in Sweden for so very long time, but actually you're trained at Karolinska. So that's very nice. You're a neonatologist and you're a professor in pediatrics and in France. You are on a research sabbatical or sabbatical in Qatar at the moment. But you also have been founded the second French NITCAPS training center in Toulouse, in France. And you have been a co-founder of the Green Project together with Pierre and others in France. So thank you very, very much for taking your time. And I'm very sorry that you didn't have in person this year with the whole group that you had planned, but please, the floor is yours.
So hello everyone. So this presentation is about implementation of infant family-centered developmental care in a greenfield single family room level 4 hospital in Qatar. So I have nothing to disclose, and just I wanted to give you a quick update about Qatar. Qatar is in the Middle East, nearly 3 million inhabitants. The migration rate is high. Nearly 100,000 people are moving into Qatar every year. The sex ratio is quite in favor of male. 75% of the people are male because of the high immigration. There are 32,000 live births in Qatar in 7 obstetrics facilities. Home births are very, very rare. The neonatal mortality is 4.28 per 1,000 births. The consanguinity rate is very high in Qatar, 54%, which means that marriage is between first or second degree cousins, and there is 10% prematurity. In Qatar, there are multiple nationalities, as you can see here, many Indians, Nepalis, Bangladesh, and you can see on the right side of the screen that the population of nationals, in fact, is not very high over time. Now, 10% of the population is nationals, and all the rest are expats, in fact. So Sidra Medicine, this is a very big hospital that opened up in January 2018. It's a women's and children's hospital. And what is so innovative in this hospital is that there are only single patient family rooms. You can see how the structure is of this hospital. You can see that there are 3 cells, and that is the entrance for the parents and the families. They go into gardens, and through the gardens they come into the units, so that they have kind of a nice impression when they come into the hospital. So in this brand new hospital, medical, nursing, allied health staff came across the whole world, and there are more than 63 nationalities working in this hospital, and we are linked to Weill Cornell Medical College in New York. There is a campus in Qatar. NICU is on 2 floors with 2 times 27 cots. So implementing infant family-centered care and developmental care in this hospital, well, you have to address different issues. There's a specific patient population. How are the parental expectations? What about this fantastic architecture of the NICU with only single family rooms, even in the ECMO room? And also, the last but not the least, it is a greenfield NICU that needs to be built up. So if we look at the specific patient population, we in Sidra, well, if we look at the first 6 months of 2019, well, the gestational age is 36 weeks approximately, and you can see that there are many cardiac and surgical diagnoses. It's a level 4, so there are other NICUs in Qatar but in SIDRA, referral is made for all the complex cases. Death is 7%, prematurity rate is 58% of the patients that come into an ICU. And you can see also that the congenital abnormalities are high, 46%. We are part of the Vermont-Oxford network, so we can compare our data with all the other level 3 or 4 units worldwide that are part of VON. And what I just wanted to show you here is that you can see the green dot is the SIDRA unit, and the bar is where the rest of the level 3, 4 worldwide are in terms of gestation, small for gestational age and congenital abnormalities. As you can see, our rates are really much higher. Again, here you can see that for here specifically, that major surgery, where we have high levels of surgical babies if we compare to other level 3 and 4 settings worldwide that are part of VON. Oh, sorry. So that is the first challenge. The population is complex and very sick with surgical complex abnormalities and also genetic issues. Secondly, what about the parental expectations? So again, we need to know that, well, most of the patients, well, they come from different countries, but as you can see on this chart, most of them come from the Middle East and from Asia, but from various cultural backgrounds and social levels. So we set up quite quickly, when the hospital opened in January 2018, education sessions for parents in an ICU. And we, despite communicating a lot about it, the attendance was rare. So we had a social worker that did an audit by phone to explore the expectations and the motivations of the parents to attend to these sessions. She talked to 34 parents, 20 mothers and 13 fathers, and the barriers that the parents talked about was that they didn't have time to come to the education sessions for 20 of them, but 2 of the parents said they prefer to spend time with the baby instead of coming to the education session. And for 30, so really the vast majority of the parents, they felt that there was no need of education sessions in the unit. And then talking about their expectations, well, most of them, in fact, had non-expectation at all. 10 of them had wanted to have more private face-to-face sessions because they felt they want to talk about their baby and not in general. And 3, quite few of them, wanted to maybe have a session about breastfeeding. So this is raising really, so how did they perceive, how did they felt about their role in an ICU? I think that at this stage, we can see that we haven't been able to communicate in a way that make them feel that they are doing a difference for their baby. Or, well, there is something that is missing, that is clear. The third challenge after the patient's profile and the parents' expectations is the architecture of an ICU. So here, the NICU on 2 levels, 3C and 4C, you can see a view here, and you can see there are only single family rooms all over the unit, very big and really a fantastic environment. Here is the neonatal intensive care advanced integrated room. So this is for the very sick babies and for ECMO babies, and there is still a bed space for a parent. So in this fantastic architecture, how can then this staff coming from 63 different countries in a country they don't know, how is the staff experience of single family rooms in an ICU? We wanted to evaluate this staff perception of single family rooms after 1 year of opening. And we did a web-based survey that we sent to the NICU team. We asked 16 questions to explore their perception about the family's experience, safety of clinical care, and the work environment. And we used a Likert scale to explore the responses. So 5 is very good and 1 is very bad. So here is some demographics. You can see that most of the team is quite young, below 50 years. Many nurses responded to this survey. Mostly it is women, and the experience in a single family room unit previously was rare. 9% of the team had some experience in that. Most of them had good experience in neonatology, and most of us were in Qatar for not a long time, less than 5 years. And here, if we look at the different parameters, you can see here, so on the first column, you can see the different parameters, and then it goes from good assessment to mostly bad assessment. So the communication of parents was felt to be good, family access to the baby was good, but then quality of patient care, it was, well, not significantly different between good and bad. The privacy for families was very good. Family interactions was felt as not very good. The feasibility of skin-to-skin was very good, and noise level as well. But the communication among the staff was felt as not appropriate, and the staff peer support was not good as well. And the ward round experience also was bad. And there was also the feeling that staff couldn't leave the room for breaks. So all the persons that had a bad assessment of different items on the Likert scale, so less than 2 or same as 2, we did a qualitative study about that, and here is kind of the mapping of that, and it's a colleague called Natalie Verhaas that did this nice graph. And you can see here that, in fact, well, these family rooms, the staff felt that there was risk because they felt that the baby could be treated less safely with some inequality because the nurse couldn't hear the baby or had less time for the baby. She had to walk between the different rooms. They felt that the families were more isolated and they could be less supported, and also the staff felt less support when there was an emergency, when they needed support. They felt alone in this room, and also not knowing each other. Again, you have to remember that all of us, we didn't know each other, in fact, very well. So feeling that also the learning opportunities were rare. When the ward round was there, they were only experiencing 1 or 2 rooms and not hearing about the other babies. So the conclusion is that, in fact, these single family rooms in this very particular setting, again, a new hospital with a new team, with a fantastic architecture, well, it is beneficial for the families, but the staff felt it impacted the patient care. There were feelings of isolation and concerns about the safety. So, of course, that doesn't question the importance of family rooms. Just we need to have in mind that adjustment of the organization of care is needed to optimize the benefits. So in CIDRA, we have improved awareness of the potential staff isolation. Assigned breaks were more regular or more clear for the nurses. Nurse leaders and floaters were available also for the rooms. We also encourage nurses to work on the computers outside the room to meet and share, and psychological support was also put in place. So that was the third part of this challenge. And then, well, the fourth is that, well, this NICU level 4 with ECMO and surgery and, well, is a green field NICU. So we have at least 12 quality improvement projects ongoing in an ICU, everything from avoiding term admissions into neonatal units, to small baby group, to unplanned extubations. And I'll just show you quickly that the unplanned extubation rate was high when we opened, and now has come down. That breast milk as discharge was not very good and now is increasing. And antibiotic administered within 1 hour after ordering also went up on this run chart over time. But a lot of processes needs to be put in place in various aspects. Of course, an important group is the developmental and infant and family-centered care core group that is working really hard. Hospital beds for mothers in the NIC rooms are encouraged because by now it's regular beds, and when the mother is has newly delivered, well, an hospital bed is more appropriate for her. Training in family-centered developmental care is done. Education sessions for parents. We still try to find a good way to reach the parents, and we feel, in fact, that like Inga Warren said, really it's about parent empowerment, that they feel that they can do a difference. So we are supporting the implementation of a parent association in Qatar. We also plan to do a research study on the skin-to-skin in these very complex babies, and we have been celebrating to raise awareness the World Prematurity Day. So in summary, Sidra is a new hospital with a really unique environment. The workforce comes from different countries, the families with multicultural background, and well, work is in progress. There's a lot of work still to do. Thank you for your attention.
Thank you so much, Charlotte. Thank you. Impressive unit, and I'm stunned. Do you think that actually the single family rooms are so many, 27 per floor? Of
Yes.
course, the meters between the staff and the family rooms must be quite wide. I mean, the distance many times. So it's...
Exactly. There's a lot of walking, but I think also when, well, we need to be aware of that the learning opportunities of the nurses is less if you have a multiple cut environment. Well, the nurses can learn much easier from each other. It is different. So as I think for us, it was really like an experimental, it was experimental because new team, new setting, and an environment, new country. So everything was there to make things difficult. But I think that, yes, we need to be aware of that. The rooms are fantastic from a certain point of view, but we need really to follow up and help and support so that the staff doesn't feel isolated, and also the parents, because here in this survey we didn't talk to the parents about this. It is only a survey for the team. So of course, next step would be to have the view of the parents.
Yeah. In your setting, are parents always present? Are the babies never left alone?
No, exactly. So we have for the NICU beds, we can have one nurse for one baby sometimes when the baby is very sick, or one nurse for 2 babies or 3 babies, and so the baby will not be left alone. But then the parents' attendance is not. It is very variable. Some parents are there all the time. Some parents are coming often in the evening or the night more than in the day. It is very variable. And I think that the ward room is very kind of open, and the parents are part of the ward room. They know everything we talk about and we discuss with them, and we have translators coming, so it is really kind of translated on the spot. But I feel the parents have more the feeling they come to defend their baby, but they don't really see, or we are not able to show them what they can do that we can't do. that is something we need to work on more.
I don't know if Siri is still in the meeting, but I remember she points out that when you have family rooms, it's extremely important that you have a good communication between the staff, so that you write down what you have discussed, so that if a new person enters the family room, it should be easy to get an idea where they are, what has happened. And she also showed me charts we sometimes use for how far the parents have developed in their competencies. And they are sometimes openly displayed in the room. So when you enter the room, you can see, oh, these parents, they think they know this, but they need help with this. So you need to find out different methods of increasing communication.
Yes. Yes, it is a challenge. I think it was really striking for me when I came to Sidra that it is really a challenge that, the handling and the way of working must be adapted to that architecture.
Okay. Stina, anyone else have questions? Well, if she doesn't stop me, I think I will continue. George, are you there?
I am here.
Good, perfect. So happy. What time is it in your place?
It is 10 o'clock in the morning.
Oh boy. I'm sure you have missed most of the conference, but we will record it and we hope that will work.
Yes, I got up about lunchtime for you, and I was able to hear Rosario's and Lydia's and Inga's and Charlotte's talks, which were fantastic.
I think if we could ask people to mute their microphones, please. Ben Joy is also a very old friend of mine. She is a clinical professor in the departments of pediatrics and psychiatry at the University of Colorado in Denver. I think you started out as a pediatric clinical nurse specialist, didn't you?
Yes.
You continued on to become a pediatric and developmental psychologist and also an infant mental health specialist. And we're very happy to have you as a NIDCAP master trainer, an APIP trainer, and you're also very involved in many projects under this Wonder Babies program. And of course, you are very instrumental in the Gravens conferences. Since decades back, you have been chairing that together with Bob White, and they are so wonderful. Many of us have been there, and we're extremely grateful for that. And also that you have taken the responsibility and chairing the Gravens Standard Group Interprofessional Consensus Panel for IFCDC. So please, Joy, tell us more about your work. Thank you.
Thank you, Bjorn. Let me get my screen up here. Is everyone able to join me? And I would like to, first of all, say hello to everyone. Let me just say that in looking through the people who are in the audience, many of you are friends, colleagues, both in the United States, Australia, and Europe. And I fondly say that it is typical that I have more friends in Europe and Australia than I do in the United States. So I'm so glad to see all of you. I'd also like to say that I am very impressed that Stina and Bjorn have gone from very little acquaintance with the Zoom process to being able to put on a conference like this, because I think that there is a very steep learning curve and you have mastered it beautifully. So we, yes, so we actually did this at the Gravens conference because you all were predicting that there would be a lot of difficulties with travel. And so we got you up and going on Zoom from there. And actually on the last day, there were 3 speakers who were restricted from traveling in the United States. And so we had to get them up and going really quickly on Zoom as well. So kudos to you for doing that. I think what I will probably do is stop my video so that you can see it. You can let it, so that if there is any problem with the internet, the video won't be the problem. So let me see if I can do that. Is that still working? If anybody could just say yes or no.
It works.
All right, good. So let me just say that this last Gravens meeting, which was the 33rd meeting of the Gravens Conference, was our kickoff for the recommended standards, competencies, and best practices of infant family-centered developmental care in the intensive care unit. We have been, as a group, working very hard for the last 5 years on determining what we needed to conceptualize and then what evidence was available to make sure that people had guidance and recommended best practices for work in intensive care. And I want to stress that, is that one of our major foci is that it be all intensive care for babies, not and families, not just in the neonatal intensive care unit, even though most of the information about this kind of work comes out of neonatal intensive care units. So we were very pleased to be able to get this kicked off at the last Gravens meeting. We also were very aware that the EFCNI standards, the European Standards of Care for Newborn Health, was kicked off during the time that we were still laboring to kind of figure out our direction. And we're so impressed with the work that went into that. The work is now on the Notre Dame website. And everything that I'm going to say is there for you to take a look at. It is published by Notre Dame in conjunction with the 9th design standards that Bob White has chaired over the years. So if you wish now, you are welcome to go to this website, which is https://NICU-design.nd.edu/NICU-care-standards/. So on this website, you can access the standards, the competencies that are there to date, the rationale, the application, the evidence, and we are now working on links to articles of the evidence that we have been able to identify that will help you to guide other people to evidence that substantiate the guidelines and standards. So when you look at the contributing panel of members, I think you will see that these are, if you're familiar at least with the United States leadership in many different disciplines, they come from very influential positions in their interprofessional organizations. Joan Arvidsson from speech and language, Rose Bigsby from occupational therapy, Bob Chico from the American Academy of Pediatrics, Becky Hatfield, who was our parent support specialist, Michael Heinen, who represented the psychologist, but also is a parent of a baby who he had, I think, 30 years ago in an intensive care unit, and has done so much work on the stress for parents in intensive care. Carol Kenner, who is so instrumental in the Council of International Neonatal Nurses, Kathleen Kohlberg from Notre Dame, who is an expert in